All right, I think we'll get started. Again, good morning and welcome. This is our meeting of the Advisory Committee on Infant and Maternal Mortality, or ACIMM for short, as we like to call it. I'm Vanessa Lee. I'm the designated federal official for the committee. Before I turn it over to our chair, Belinda Pettiford, just want to again welcome our members, our federal ex officio members who are here, our speakers, presenters, also members of the public who have joined either online or in person. It's been 4 years since we've been able to hold a committee meeting here in HRSA in the building, so we're all very excited. It's a great day. So welcome again to all of you. I'm officially opening the meeting and calling us to order. I'll now pass it over to our chair. Oh, let me do some housekeeping first. Thank you, Belinda. So for those of you here in the room with us in the building, this is Pavilion B as in boy, and you're on the 5th floor. So if you venture to other floors of the building, just remember to come back down to 5th. Again, this is the Pavilion B room that we're in. For restrooms, if you just exit the front door here behind me, we pretty much have restrooms in every corner of the 5th floor atrium. So if you step out, there's restrooms to the right around the corner. I've been using one if you just go left around the corner. But if you want to venture towards the cafeteria, which is straight ahead as you leave the room, there's also restrooms on each side of the cafeteria. When we break for lunch, there's a full service cafeteria, as I mentioned, breaks or for lunch. There's also a little snack shop if you exit the room and walk diagonally to your left. Anything that I missed, Belinda? Thank you, Jasmine. Okay. Well, again, welcome everyone. I'm now going to turn it over to our committee chair, Belinda Pettiford.
So good morning, everyone, and it is so great to be in person. I know every place that I've been, maybe in the last year, people are getting really excited about coming back together, and more people are coming out. So it is really nice to have some of you in person. We also know that some of you tried to get here and be in person. We know that there were some challenges with some flights, and we know people have other lives. You know, ACIMM is not always first in their lives, so we understand that. But we're just excited to have so many of you here today. As you look at the agenda, and everyone should have a copy, you will see we have a full 2 days. We try to use this time very wisely, but also build in a little time so you can connect a little bit offline. As a committee, we don't get to meet in person often. So when we do like to have that chance to just check in with each other and get to know each other a little better. As you look at the agenda today, you will see we have quite a few federal updates, and we're grateful for those. We're going to also take a few moments to share updates about some of our ongoing efforts based on our last group of recommendations to the Secretary, where we prioritize American Indian and Native Alaskan challenges. So we will get some updates on what all of us around this table and others have been doing to move that work forward. Then we'll delve further into a specific area around social determinants of health. You will quickly hear, as I've been meeting with various committee members, that social determinants of health or social drivers of health is one of the priorities that many of you in this room are interested in, and many on the committee. So today we'll get to hear about housing. So very excited to have housing highlighted on our agenda. We'll also, as always, we try to make sure on the agenda that we are centered and remember the importance of our work is based on our community voices. So today, and as well as some, I think tomorrow, we'll have a couple of community people, consumers, participants that will be able to join us and share their experiences and their challenges and their concerns, and also give us recommendations if they like. We also have a federal update on the federal Healthy Start program that many of you who don't know my background has always been near and dear to me. In North Carolina, we received our first site in North Carolina in 1997, and I was the first project director. So it is Healthy Start has been near and dear to me for quite some time now. And also to remind our committee that we are the advisory group for Healthy Start for this federal program. So just keep that in mind. And we are the ones making recommendations. So it's always nice that we get to hear some background on it. We're very fortunate to have a very specific Healthy Start project here today to share their experience. We have so many public comments that have come in that are on our schedule, that we've scheduled 2 times for public comments. We've got a long list. We see how many show up. We think a good number of them will, but so It's always nice to have people come and share their thoughts and challenges and concerns with us. And as a committee, we have an opportunity to respond. We'll also take time during today and tomorrow to consider what do we want to truly prioritize as a committee and focus on next. So we'll start that conversation today. We'll think a little bit about it tonight, not a real homework assignment, but just something to be thinking about. And then we'll try to move it forward tomorrow. And then tomorrow afternoon and tomorrow day, I guess, we have two panels that we're really looking at. What are our our national partners doing to address issues around infant and maternal health? And that is important to us so that we can try to make sure wherever we can that our efforts are aligned and we can develop more synergy to move our work forward. And then we'll always wrap up with any updates anyone wants to share, as well as our next steps. So as we get started this morning, we want to start by asking our committee members to introduce themselves. And because we have quite a few people in virtual land, we want them to introduce themselves as well. We want our committee members to introduce themselves, our ex officio, and then others that are in the room that will get them to introduce themselves. But as a committee member, just to keep it as brief as possible, because we can go on, and I know Belinda can. You can go, if you'll just give your name, your role, and kind of where you're from, and we'll keep it that simple. And then I'll take personal privilege to just let everyone know on Saturday, we celebrated my mother's 90th birthday. So I feel like I need to let the whole public know that, because we had the best time. And she had the best time in the world. Any of you that are connected with me on social media, you can go out and find the pictures. Otherwise, you can see me at break. But I am, yes. Hey, you can see it at break time, not doing the meeting, right? So I am Belinda Pettiford, and I have the privilege of serving as your chair. I hail from the wonderful state of North Carolina, and in North Carolina, I am as part of the state Title V, and I head up the Women, Infant, and Community Wellness section. And we will just go around, or we'll go this way. You want to go?
Sure. Good morning. Michael Warren. I'm the Associate Administrator of the Maternal and Child Health Bureau here at HRSA, and it's so great to welcome you all to our headquarters. Thanks.
Good morning. I'm Allison Cernich. I am the Deputy Director of the Eunice Kennedy Shriver National Institute of Child Health and Human Development at the National Institutes of Health. I'm an ex officio on this committee, and thanks so much for having me.
Hi, Karen Rimley at the CDC National Center for Birth Defects and Developmental Disabilities. I'm the center director.
I'm Danielle Ely. I'm from the National Center for Health Statistics, and I manage the linked birth and infant death file.
Good morning. I'm Alika Ampry Samuel, and I serve as the Regional Administrator in Region 2 for HUD.
Good morning. My name is Kate Menard. I'm a maternal fetal medicine specialist, hail from North Carolina, and a faculty member at the University of North Carolina in Chapel Hill. I feel like I should give a little more information because I feel like I work for all of you. I have HRSA funding for the MHLIC work that is leading maternal health work and our maternal health innovations program locally. I have an IPA with CDC. I'm consulting with them, particularly related to levels of maternal care. And most of my funding right now is coming from the NHLBI for the work I'm doing in implementation science of hypertension treatment. I just felt like that was kind of disclosure stuff.
Hi, Steve Calvin. I'm a maternal fetal medicine physician from Minnesota, and I am a big fan and work with midwives and community birth with birth center care as well.
I'm Caroline Dunn. I am an ex officio member from the U.S. Department of Agriculture, specifically Food and Nutrition Service, where I work with the WIC program.
Good morning. I'm Phyllis Sharps. I'm a professor emeritus of Johns Hopkins School of Nursing, and I'm a clinical nurse specialist in maternal child health.
Good morning, everyone. My name is Sarah Meyer-Holz. I am the program lead for ACIMM, as well as a project officer. So nice to meet everyone in person. I'm also going to pass it around the room. Is that what you want, Belinda? Perfect. Lachelle, let's start with you since you have your personal mic there, and then I'll walk this around.
Good morning, everyone. I'm Lachelle Stewart. I'm the Executive Director for Baltimore Healthy Start, and I'll be presenting about us later.
Thanks, Sarah. Good morning. I'm the snack person. No, so there are snacks on the table. My name is Abigail Duchateau Judy. I serve as the contract office representative that supports the logistic for this meeting and other duties.
Good morning, everyone. My name is Monique Fountain Hanna. I serve as our Chief Medical Officer here in our Division of Home Visiting and Early Childhood Systems. And I also serve as currently detailed to the Office of the Administrator, serving as liaison for perinatal health equity.
Okay, sure, yes. Hi, good morning. My name is Dawn Levinson. I'm the Deputy Director in the Division of Healthy Start and Perinatal Services, and I bring greetings from our Director, Lee Wilson. He's sorry he couldn't be with us today, but says hello to all.
Good morning, everyone. My name is Rochelle Logan. I'm the Supervisory Public Health Analyst for the Division of Healthy Start and Perinatal Services. I've met a lot of you all via Zoom, so good to see you in person.
Hi, good morning. My name is Mia Morrison, and I'm also a supervisory public health analyst and team lead in the Healthy Start branch in the Division of Healthy Start and Perinatal Services. So nice to meet all of you.
Good morning. I'm Sonsi Furman, and I work in the same division as all these wonderful ladies, and I work in the Women's Health branch with MDRBD, soon to be Maternal Mental Health and Substance Use, and FASD.
Good morning, everyone. My name is Kimberly Sherman. I serve as the branch chief for the Maternal Women's Health branch here in the Division of Healthy Start and Perinatal Services. Welcome.
Hi, my name is Liv Hoynes. I'm here today on behalf of the National Indian Health Board and our maternal and child health team. We work on Indigenous maternal health projects, and I'm also a public health associate with the Centers for Disease Control. So I'm really excited to be here.
Hi, good morning, everybody. My name is Andre Chappell. I'm the Director of the Public Health Services Division in the Office of the Assistant Secretary for Planning and Evaluation. I'm going to be talking a little bit today about maternal health and social determinants of health, a couple of topics that I've been dabbling with for a few years. So very much looking forward to the conversation. Thank you.
Hi, I'm Emma Kelly. I am the logistics for this committee, along with my colleagues Emma Allen and Kelsey Judd, who you've probably gotten a million emails from in the past 2 weeks from.
Okay. Okay, so I know we have some members that are joining us via Zoom. So as I call your name, if you'll come off, unmute, and introduce yourself, that will be helpful. Sharonda, I see your name. So will you come off of mute, Sharonda, and introduce yourself? We may have to come back to Sharonda. Oh, there you are.
Hello. Yeah, at first it wouldn't let me come off mute. I don't know what was happening there, but hello, my name is Sharonda Thompson, and I am the community voice that's on the ACIMM council, and love to get as much information as I can from the community so that I can be that spokesperson for them.
Thank you, Sharonda. Sherry, I think you're on. Sherry Alderman.
Yes. My name is Sherry Alderman. I am a developmental behavioral pediatrician in Oregon, and I come with a deep passion for infant mental health.
Thank you, Sherry. And as I was sharing earlier, she was trying to get here like yesterday. So thank you so very much. Trying to see if Jacob is on. Jacob, are you on? So he may be joining us later. Or Tara. Don't see Tara's name. If either you're on, if you'll just come off of mute, otherwise we'll catch you later in the day. I know we have a few ex officio members that are on. I think Tina is on. Tina?
Hi, Christina Pacharalao. I'm the maternal child health consultant for the Indian Health Service, also an OBGYN, providing care to American Indian Alaska Native communities and for the Phoenix area. Thank you for the opportunity to join today.
Thank you, Tina. And Wendy?
Hello, Wendy DeCourcy from the Administration for Children and Families. We are a program service arm of HHS, providing Office of Head Start, Office of Refugee Resettlement, Office of Family Assistance, Administration for Native Americans, and the Office of Child Care, among many other programs that we support.
Thank you so much, Wendy. And Charlene, I think we see you on.
Good morning. This is Charlene Krellinger. I'm the Chief of the Maternal and Infant Health Branch in the Division of Reproductive Health at the CDC. And happy to be here.
Thank you, Charlene. Did we miss any ex officio members? So please just come off and introduce yourself. Okay, if you're there and you can't come off of mute, just drop a note in the chat and Sarah will let us know you are there. So thanks, everyone. We will continue to follow our agenda as noted. And next, we will have a review and approval of our minutes from our March meeting. So hopefully you've had a chance to look at them. I'll give you a moment. They're in your briefing book. And once you have reviewed them, if I can get a motion to approve the minutes. Thank you, Kate. Do we have a second? Thank you, Steve. Those in favor of the motion, if you'll say aye. Any opposers, likewise? Then the motion passes. Thank you all. And let me back up a moment because I did not share one critical piece of information with everyone. Many of you know, probably all of our committee members, but we have had one resignation of a committee member. So Charlene Collier in Mississippi, we are sad that Charlene has decided to step down. As I tell people, it's a lot going on in Mississippi, just like I said, it's a lot going on in North Carolina. So she is, she's doing okay, but she has made a decision to step down. As a committee member, if you want to reach out to her, I am sure she will appreciate a note from any of us because we think she does amazing work and will continue to do that even beyond ACIMM. So excited about that. I also wanted to give a special welcome this morning to two of our new ex officio members. They introduced themselves, even though I didn't make sure everybody knew that they were new. So we're happy to have Alika Ampry-Samuel with us with HUD. So we've been wanting someone from HUD. So thank you for being with us today, as well as Carolyn with the Department of Agriculture. And she and I had a whole conversation about another Carolyn Dunn that I know in North Carolina. So that she knows as well. So it's all good. Who also works in the nutrition field. We're gonna have to get them together. All right. So now we're going to continue on. We've approved the minutes and we have a couple of federal updates this morning. So we'll start off with Dr. Michael Warren to give us updates and turning it over to you.
Thank you, Belinda. Good morning again, folks. Just going to share a few updates from the Maternal and Child Health Bureau to give you a sense of some of the things we've been working on over the last few months. All right, next slide, please. So you'll remember about a year ago on Mother's Day in 2022, we launched the National Maternal Mental Health Hotline. This was a new authorization and appropriation from the Congress. We were really excited to get that off the ground. Really incredible response, about 13,000 calls in the first 12 months, and I should say calls or texts. Because you can either do a voice call or text the hotline. What we found is about 70% of the incoming conversations are via phone, about 30% via text, so a substantial number of folks using that. It is free, it is 24/7, it is confidential. folks are able to answer the lines in English or Spanish, and then 60+ additional languages are available via translation service, and we get calls from all over the country. As we have gone through the first year of the hotline, a lot of lessons learned when you stand up something new like this. One of them is that the number was difficult to remember, and it was longer than a traditional toll-free number, and some folks were actually having trouble with calls going through. So we did some engagement with stakeholders to think about a new number, something that would be easier to remember. And so where we landed on with a lot of excitement from stakeholders was 1-833-TLC MAMA. And so that is the new hotline number. The QR code that is there on the screen will take you to a webpage with information about the hotline. And I'll talk a little bit more in a minute about some of the exciting things that are there. Next slide, please. You all know really better than anybody why this matters. We know that maternal mental health conditions are common really across the perinatal period. If we look, for example, at postpartum period, 1 in 8 women report depressive symptoms. That is self-report. And interestingly, the converse of that, 1 in 8 women report that they weren't asked about symptoms of depression during a postpartum visit. And so anything we can do to increase the availability of resources and make them easier to obtain is really important. Next slide, please. I should also add, we know from our maternal mortality review committees that our colleagues at CDC lead in partnership with folks in the state that maternal mental health conditions contribute substantially to maternal morbidity and mortality across the country. So as we think back to the first year of services, I mentioned over 13,000 calls or conversations coming in. The wait time for these is just remarkable. So well under 30 seconds for both calls and text in terms of when folks are getting response. And we do this, we operate this hotline in collaboration with Postpartum Support International, or PSI. They've got a network of trained folks across the country representing a variety of disciplines who are specially trained in perinatal mental health on the other end of the line. Next slide. Just to give you a sense of who is calling, the vast majority of folks, about 3/4, are calling for themselves. But you'll see we've got providers calling, folks who are calling on behalf of another person. This may be a partner, a parent, a friend. And of those who are calling for themselves, you can see about a little over 1/3 are in the postpartum period, about 1 in 5 are pregnant. And then that gray wedge of the pie are folks who are not reported. As you can imagine, the primary focus of this line is to provide support and assistance. And while the data collection is a nice piece of that, we don't hold up the service on behalf of the data collection. And so we have some missing data, and we will work to refine that over time, but the primary goal of this is really around service delivery. Next slide. If you look at why people are calling the hotline, probably not surprising to you, the top 3 reasons for people calling are depression, anxiety, and feeling overwhelmed. You will notice these numbers add up to more than 100% because these are, folks can often report multiple reasons for calling the line. And you can see the top 5 that are there represented on this chart. Next slide, please. I mentioned that I would share with you some exciting news. So we've had on the hotline for a while materials that can be downloaded for print. So we've got posters, we've got flyers, we've got wallet cards, we've got text that you can insert in newsletters or emails or web postings. But we also got some additional funding from the Congress to be able to support additional promotion. And so on the website now, in addition to being able to access any of those things for free, you can also request to have materials shipped to you for free. We're able to do that in limited quantities: magnets, wallet cards, posters. So the response has just been incredible to date. I think last I heard, we're over 400 entities across the country had requested promotional materials. If folks need to order in larger quantities, they can reach out to us at the Bureau and we can have conversations about what's possible there. But really excited that these materials are available. I think it's a good way to put those precious funds from the Congress to use and to be able to make more folks aware. We have seen a bump in calls to the hotline since the launch of the new number. And since the availability of the promotional materials, and as those materials get out into the community, only expect that call volume is going to continue to increase. Next slide, please. So just a few other updates. Belinda mentioned Healthy Start. We were excited in the fiscal year 23 budget to get a funding increase for our Healthy Start program. And the Congress specifically called out additional funding to support an enhanced version of Healthy Start with a focus on communities with high number of excess infant deaths. And we've talked with this committee about that before, those deaths that are due to disparity in the deaths that we need to prevent in order to be able to achieve equity in this country. So with the additional funding, we plan to make up to 10 awards. That funding opportunity is currently on the street and applications are due in mid-July. So if you are interested in that, please take note of that. If you know folks who may be interested, please let them know. These are for new communities that aren't currently served by a Healthy Start program. And so we really want to make sure we're getting to those communities where the need is great. That's always been a criteria for Healthy Start. You have to have an infant mortality rate at least 1.5 times the national average. And we really also want to make sure we get to those communities where those excess infant deaths are the highest. I'm so proud of the team that has worked on this. Many of them are in this room. They were very deliberate to engage folks through a number of listening sessions and a public request for information that are influencing not only this funding opportunity, but also our Healthy Start main competition, which will happen in 24. So the entire cohort of Healthy Start grantees, 101 communities, will recompete in fiscal year 24. So later this calendar year, those NOFOs will likely be available. And so we're excited to be able to use the information that we've gathered. Just an example of the kinds of things we heard, one of the hallmarks of the Healthy Start program since its beginning has been this notion of a community consortium, folks who are from the community, who know the community well, who can help guide and direct that work. In previous iterations of Healthy Start, we've called those community action networks. We also have made the participation by community members aspirational. So it was a goal that folks worked toward over the course of their Healthy Start project. We've now put in a floor of participation as a baseline expectation for community engagement, along with expectations for the percentage of community members that should be a part of that consortium. We've also put in strong recommendations that those community consortia should be led or co-led by folks who are from that community. I think this was a consistent listening or theme from the listening sessions we heard, that folks don't want people coming in sort of swooping in to help a community. These efforts really need to be of, for, by the community. And I think this is one example of how that work is going to move forward. Next slide, please. Also really excited that there was additional funding in the fiscal year 23 budget for a research network for minority serving institutions. This was originally part of the Momnibus, that package of bills related to addressing the maternal health crisis. And this was one of the pieces of that passed. We will be able later this year to make 16 awards for research centers, as well as one national coordinating center. And again, this was a NOFO that the team did an amazing job of gathering input from the field as we were thinking about drafting that funding opportunity. A number of themes came up in those sessions that are reflected in that NOFO. One of them is really about meaningful community partnerships. And this, I think, builds on that theme we talked about with Healthy Start. And so not just having members of the community participate in your research, but having members of the community help you develop the research questions, think about what those research protocols look like, think about how you update community members periodically, and then involve community members in dissemination of your findings. So that's reflected in the NOFO. We also heard from a number of minority serving institutions about institutional challenges and barriers to applying for our funds. And so we have done a couple of things to address that. One is that we have built in a funding preference for minority serving institutions in this application process. We've also built in a planning year, recognizing that you get grant funds. It's not like you just flip a switch and boom, your program is up and running, but it takes some time, especially if you're working to build capacity. And so we've built in that expectation that the first year will be a planning year here. So really excited that NOFO again those grants will also be awarded later this year. If we could go back one slide, one thing I failed to mention on the Healthy Start NOFO, we are making 10 of those awards. Our hope is to be able to fund at least one project in a tribal community and at least one project in a rural community. I think back to what this committee heard at our meeting in Minnesota and thinking about how we can support tribal populations in particular. And so we were able to put a special funding consideration in that application process to be able to do that. So we can go forward a couple of slides now. Thank you. We would be remiss if we didn't take the opportunity to talk about work that is active and ongoing across the department and with many of our partners, and that is making sure that folks are connected to health insurance. I think everyone knows that during the pandemic, there were a number of waivers in place that allowed people to continue coverage with Medicaid and CHIP without going through that sort of regular redetermination process. Those waivers have now ended and states are going through the redetermination process. Nationally, there are about 15 million people who are at risk of losing coverage. About 7 million of those are eligible to continue to receive coverage. And overall, we know that about 5 million of those 15 are children. And so as we think about the needs of MCH populations, we know that insurance doesn't solve all of your problems, but it is a big start in helping you get connected to care. And so we want to make sure that folks who are eligible for Medicaid and CHIP stay connected and go through that redetermination process successfully. We have been supporting a number of our grantees to be able to do that. Our colleagues across HHS are working on this. There are materials that are available through our colleagues at CMS in a variety of languages. They've got a number of materials available in a toolkit that you can use to be able to do this work. And so we would ask that in your networks and in your program efforts that you take any opportunity you can to be able to connect people to care. If they, for some reason, are not eligible for Medicaid or CHIP and they have been covered, we always want to think about what's the opportunity to make a warm handoff. And so healthcare.gov is a great resource to think about connecting people to care that they may qualify for. And I think that is my last slide, maybe. Yep. And certainly happy to answer any questions. I'll be around for the next couple of days if you have any questions. Thank you.
Any questions for Dr. Warren at this time? Any questions? Unfortunately, as he said, he'll be around for a little while, so great. So now we're going to turn it over to Caroline Dunn with the Department of Agriculture for her to share some updates.
Thank you so much. I feel like Dr. Warren's always a tough act to follow, but I appreciate it. So again, good morning. My name is Caroline Dunn, and I am with the United States Department of Agriculture's Food and Nutrition Services, specifically in the Office of Policy Support, where I am a senior analyst with the Supplemental Nutrition and Safety Programs Research and Analysis Division. So among a suite of 15 nutrition assistance programs, FNS administers the Special Supplemental Nutrition Program for Women, Infants, and Children, or WIC, which is one of my main programs and what I'll focus on today. So WIC is an important program that provides services to families across the country, and I'm so excited to be here to represent USDA in this important work. Since it's my first time attending, I'll do just a quick overview of the WIC program and also highlight some of our efforts to modernize the program in ways that we hope will continue to allow us to improve the lives and protect maternal and child health. I'll also give a brief overview of 2 upcoming efforts that we have related to addressing WIC's role in maternal morbidity and mortality. Next slide, please. So at USDA's Food and Nutrition Service, our mission is to increase food security and reduce hunger by providing children and low-income people with access to food, a healthful diet, nutrition education in a way that supports American agriculture and inspires public confidence. Next slide, please. I'm going to start off by giving a quick overview and overarching description of some of our efforts intended to guide the work for the next coming years. The first is USDA's emphasis on addressing nutrition security, which Secretary Vilsack announced in March of last year. And this extends again beyond the work that FNS does across the US Department of Agriculture and really builds on USDA's work to promote food security by increasing a focus on emphasizing the coexistence of food insecurity and diet-related diseases, and also by applying an equity lens to our efforts and recognizing the role that structural racism plays in increasing food insecurity and the risk of diet-related diseases. You may have also heard that President Biden recently convened the first White House conference on hunger in over 50 years. And that conference brought together over 600 key interested parties in person and thousands more online. And through listening sessions and private sector commitments around the goals to ending hunger and increasing healthy eating and physical activity by 2030. Next slide, please. So the Special Supplemental Nutrition Program for Women, Infants, and Children, better known as WIC, has been serving families since 1974 during critical periods of growth and development, including pregnancy, the postpartum period, breastfeeding, infancy, and early childhood. And in its 50-year history, WIC has been proven to be one of the most powerful and evidence-based public health programs available. WIC is a tailored assortment of healthy foods, nutrition education, and importantly, referrals to other health, community, and social services that families may need. The program currently serves just over 6 million people per month, including almost half of all infants born in the United States, all through DC, and 33 tribes, as well as 5 territories. Services are provided at a variety of clinic locations, including but not limited to health departments, hospitals, schools, nonprofits, and other healthcare facilities. And WIC also plays a key role in USDA's nutrition security efforts. Although eligibility criteria are slightly different, many families receiving WIC are also eligible for programs like SNAP, and the majority are eligible for free and reduced price school meals. Because WIC provides certain foods rich in nutrients that are important during pregnancy, infancy, and early childhood, it really ensures that families can include these foods in their diet and allows them to stretch their food dollars, including those through SNAP. Next slide, please. So some examples of the foods available in the WIC package include dairy, such as milk, cheese, yogurt, eggs, canned fish, peanut butter, tofu, whole grains, fruits, and vegetables. And WIC participants receive food benefits on an EBT card, which works similarly to a debit card. Participants can also shop at a variety of stores approved by their state agencies. Next slide, please. However, despite the proven impacts of the program and the great benefits, right now we know that only about half of all eligible women, infants, and children participate. And we believe strongly that to maximize our program's impact and make families across the country and territories healthier, that we have to close this gap. So the American Rescue Plan Act of 2021 provided about $390 million and waiver authority for USDA to invest in WIC outreach, innovation, and modernization. USDA engaged interested parties to identify investment priorities, including making sure that all eligible families know about WIC, making WIC easier to access, ensuring that WIC shopping is simple and convenient, connecting WIC families to farmers markets, and providing culturally responsive care. Next slide, please. So our overall WIC modernization goals really focus on enrolling all eligible families, making WIC attractive so that families stay on the program and the entire time they're eligible, making shopping simple and convenient so that families can use all of their benefits, and making WIC equitable and accessible for all. Next slide, please. First, we know that today's families need services to be simple and convenient in order to fit them into their busy lives. Before 2020, WIC was only available in person. WIC state agencies have been able to use a variety of flexibilities since then as a result of public health emergency to provide services in different ways. And today's families also rely on digital communication and tech-forward interactions in their daily lives, including interactions with their healthcare providers. So we're working to make remote and digital services, including telehealth, a key and permanent part of the WIC program. Providing options for families to choose how they want to access WIC will help us reach more eligible families and provide the services and support to families they need to live a healthy, active life. Next slide. So WIC is really uniquely positioned to improve families' lives long-term and to reduce racial disparities in maternal and child health outcomes. But again, to make an impact, families must know that they're eligible and enroll in the program. So we've really been prioritizing outreach to ensure that all eligible families know about WIC, especially in underserved communities. We're investing in outreach at both the local and national level to spread the word about how great WIC is, whether they hear about it from a healthcare provider, from a community organization, or from other forms of providing assistance dissemination through family members, friends, or neighbors. We're developing WIC National Outreach Campaign, which is expected to launch in 2024. And that campaign is being developed under a contract using a measured approach grounded in research to inform strategic audience engagement. The WIC campaign is really being developed to resonate with a broad swath of populations, including historically underserved communities and communities of color that participate in WIC disproportionately low rates compared to white families. Next slide, please. Overall, we want to make sure that we deliver a modern WIC experience that feels relevant and helpful to families. We envision a WIC program that uses technology to make applying to the program, scheduling appointments, receiving nutrition services, and interacting with WIC between appointments easy and carefree. Moving in this direction will reduce many barriers to participation for eligible families who may not want or be able to attend in-person appointments. For example, those without access to reliable transportation, those in rural areas, and those working during WIC clinic hours. So as part of our modernization portfolio, we're really working on strategies to simplify that enrollment process and make WIC easier for families to access. We really believe that these strategies are important for bringing new participants in and keeping the ones that we are currently serving. Next slide, please. WIC also is prioritizing and has been prioritizing providing culturally relevant care and is investing in efforts to support and diversify the WIC workforce. We believe that providing culturally competent care and ensuring that WIC staff reflect the diversity of their communities is the ideal way to implement WIC. And to work towards this, FNS has partnered with USDA's National Institute of Food and Agriculture to combine the expertise of both agencies to tackle this critical component of our WIC modernization strategy. We understand that retaining staff is just as critical as recruitment, and so this strategy will address both recruitment and retention. Next slide, please. So FNS's Office of Policy Support has also done considerable work focused on maternal morbidity and mortality and infant health, and we're excited to continue expanding this portfolio as we learn more about the impact of WIC on health outcomes and about the role that WIC can play in identifying and addressing early warning signs of maternal distress. So in the last year, FNS has engaged with several activities related to maternal health, and what we've learned from these activities has provided us with direction for our future work in this space. Two activities that have been incredibly impactful in shaping our current understanding of WIC's research and evaluation efforts are supporting a stakeholder engagement session in April of 2022, which included presentations from key federal partners such as CDC, NIH, and HRSA, in addition to other academics and researchers in the maternal health space. FNS also supported and coordinated with the Agency for Healthcare Research and Quality to conduct a review by the Hopkins Evidence-Based Research Practice Center. And findings from that report supported activities determined that more evidence is really needed in this space to understand the impact of WIC on maternal health. And based on findings from these preliminary activities, FNS is determined that additional research and evaluations are needed to better understand that relationship between WIC participation and maternal health outcomes, and also to evaluate how evidence-based approaches to detect and address early warning signs of maternal distress can best be implemented in a WIC setting. Next slide, please. So building on this work, USDA is committed to supporting research into the relationship between WIC and maternal health, both understanding how WIC impacts maternal health and also investing in research to understand how WIC program can be used to grow our efforts to support maternal health and address health disparities. As such, USDA intends to initiate 2 cooperative agreements focused on maternal health and addressing health equity in the coming year. At a high level, the first of these cooperative agreements will support rigorous academic research into the impact of WIC on maternal health outcomes, especially using available secondary data, and also building new evidence and data for public use. With this work, USDA intends to continue building strong cross-governmental research relationships and also to diversify the existing research community by encouraging young researchers from diverse backgrounds and institutions to participate. Our second effort will really focus on understanding how USDA can deploy innovative approaches to addressing maternal morbidity and mortality in the WIC setting. As we know, more than 80% of maternal deaths are considered preventable, and early warning signs and interventions have been shown to improve maternal health during this important period. So this project will fund a cooperative agreement to an entity that will subsequently award subgrants to WIC state and local agencies who will implement and evaluate education, communication, and other evidence-based activities aimed at assisting WIC clinic staff and pregnant and postpartum people with recognizing early warning signs of maternal morbidity and mortality. Next slide, please. So to summarize, USDA is committed to supporting programming and research that supports women and infants' health and in modernizing our programs to ensure eligible families have the ability to easily enroll, that eligible participants remain in the program, to increase the redemption of food benefits tailored to support optimal health, and to extend program access and equity among diverse populations. We're excited to be involved in the efforts of this committee to provide perspective and to learn from other agencies and advocates who work tirelessly to support maternal and child health. And I thank you for the ability to be here this morning.
Thank you so much, Carolyn. We really appreciate you joining us. Questions for Carolyn? I have one question. I know you talk about, the outreach and their efforts because about half of the participants that are eligible do not actually participate in the program. Do you have information on why they're not participating? Because that's an interesting kind of thought process. I know we've looked at it some in my own state around why, but I would love to hear from a national perspective why.
Absolutely. It's a great question. And I will say that there is a diverse set of reasons for non-participation, ranging from access to the program to consideration of benefits and also feelings of wanting to make sure that benefits are available for others or not wanting to be considered a burden. And so we see a very diverse set of reasons for non-participation, which I think, we're able to really address throughout the campaign. So a big part of the national outreach campaign is making sure that people are aware of the WIC program and eligibility for the WIC program. There's also a lot of confusion about who might be eligible. So we will be working very closely with partners in Medicaid and in SNAP to identify adjunctively eligible families and to conduct outreach to them as well. I would say, there's a great body of research out there looking at this in different populations, and it's such diverse reasons for non-participation that it's really not a one-size-fits-all approach to addressing it. It's really a comprehensive approach across the entire program.
Thank you. I know one of the areas that we started hearing a couple of years ago was when some of the legislation came out around if you are not legally in the US, you should. And so a lot of people they kind of went back and were a little nervous about coming to a program that they consider that, ICE or someone might show up for, to be honest with you. And so I think it's still overcoming some of that barrier is part of what we're hearing also.
Yeah.
Oh, wonderful. Other questions? Anyone in the virtual world with questions? Yes.
I know I'm new.
Just jump right in.
Have there ever been any intentional collaborations with HUD to work with families that live in HUD-assisted properties? And I ask that question because we did some really direct work with HRSA around the maternal mental health hotline nationally, and we got a lot of input and feedback from our team. So I'm just wondering if there's anything.
So I will not speak to the comprehensive history of WIC collaborations, but I will say that it is, I think, a very good and natural partnership. And I'd love to continue the conversation about how we can continue to partner on that.
Wonderful. We are about making connections because we're all trying to support the same families in many instances. So great. Can't tell us if it's anything in the chat. No chat. Okay. No questions. If you think of questions later, fortunately, Caroline will be here with us all day, right? Well, most of it. Yes. We can track her down. We'll say that.
I don't really have a question, but just a comment. And I love the modernization term that you're using is just really resonating with me. So for so many of the programs, be it WIC or so many of the social support programs that we have that require this show up for it, signing up for Medicaid or signing up for this show up for it is so, we just, there's so much better, so many better ways to do it, to allow women to, go to work, you know, and do this after hours and, you know, all those things. So I'm really, really encouraged to hear that y'all are going that direction.
Thank you all. Remember, you can ask your questions at any point. So if no other questions, and we want to thank you again so much for coming and being with us and being on as an ex officio member. So now we'll continue on the agenda and follow up and get any updates that any of the committee members would like to share about any efforts that you've been focused on or working in related to our last set of recommendations. Remember, we submitted, I think it was 59 recommendations to the Secretary around American Indian, Alaska Native. So there's a lot to choose from. You could pick any one you want. You don't have to go with all 59. But any updates that anyone would like to share that they've been working on in the last little bit since we met in March? Oh, yes, please.
One thing that isn't really directly infant mortality, but it is, and that we're working, we have PHAP, which are public health associates. So they're people who've just graduated from college with a public health degree. Two who are working with tribes in the Southwest to better understand when children have newborn screening, and in particular, hearing loss detection at birth, they're not getting followed up well. And why not? And what can we do to work with the states and with the tribes to better understand what the barriers are, and then to replace and then to fix those barriers. What we learn more than anything is the PHAP experience of being embedded into the tribal health department rather than the state health department makes a big difference in their experience. And you know, what they're going to be learning. The two we have are staying in the tribal health departments because they had such a wonderful mentoring experience. So that, you know, I think what we learn may help with a lot of early identification of children with developmental problems in tribes, maternal health, you know, just kind of really learning the culturally competent way to be engaged, be involved, and participate.
Thank you so much for sharing. That is a great example. Excellent. Thank you. Yes, Allison.
Just one other note, and I will be restarting this work coming up soon, but NICHD led with a number of our federal partners, a lot of work around stillbirth over the past 6 months. And so we published a report, and we can get the link for you all on the issue of stillbirth and the ways that we need to continue to address this. You know, obviously we led this through research, but we worked with our federal partners and with a group across the country to think about what issues we need to confront to better understand and prevent stillbirth. And so we will be restarting this group again, as I said, to talk about, we made some recommendations about how to move this forward. And we'll be now working on the implementation of those recommendations.
Okay.
And so we do this through the council, NICHD's councils, where we do the public reporting of this, but we also open the meetings that we have to the public. So a number of my federal colleagues here have been working with me on this. And of course, we invite you all to track this. The information about this is on our website.
Thank you for sharing, Allison. Oh, you're going to say
I mentioned earlier the funding considerations that are in the Healthy Start NOFO. One of the things we heard during the tribal meeting in Minnesota and in the recommendations were to think about where there are opportunities to make more funding available specifically to tribal communities. So we've been exploring where we've got the authority to put in those special funding considerations in our funding opportunities. The other thing to share is that there was this overwhelming feedback that it is so important to have meetings in the community. The meeting in Minnesota was the first time this committee has ever met outside of a virtual space or a federal space. And so we are continuing that, and our December meeting, which you'll be hearing more about, is going to be a community-based meeting in St. Louis. So our tribal meeting in Minnesota really paved the way for that.
Thank you. And we'll thank Sharonda later for letting us come to St. Louis with her. Others want to share any updates? I know we've got Tina Patara-Lau. I don't know with Indian Health Services. If you've got any updates you would like to share, Tina, to please just come off of mute.
Hi, thank you, Belinda. This is Tina. And good morning to the committee. Thanks for the opportunity to provide some updates from IHS. As I mentioned in March, several recommendations from ACIMM's report on making amends have been incorporated into IHS's 2023 agency work plan, specifically focus on patient safety, quality of care, expand and diversify the workforce, strengthen approaches to adapt and augment social determinants of health. As you are aware, many sites are in rural maternity care deserts where housing, transportation, and childcare provide challenges in access to care. And lastly, increasing our communication with IHS tribal and urban sites. So since we met last summer, I've established a maternal care work group, which is a multidisciplinary group of MCH consultants and subject matter experts in PEDS, ER, behavioral health, including midwives, nurses from the field who provide patient care. And we've developed several programs with a focus on safe quality maternity care in IHS. We've drafted an obstetric readiness and emergency department or OB Red manual, which will provide training and technical support for sites in maternity care deserts. IHS has 20 federal and tribal hospitals providing planned births and additional 48 critical access sites. And so this training is critical to provide the frontline staff with readiness checklists, emergency protocols, and curriculum for training to safely triage, stabilize, transfer pregnant patients and newborns. Second, we're piloting a maternity care coordinator or MCC program, which will provide telehealth and home visiting support to the maternal infant dyad beyond that 20-minute clinic appointment. This is modeled after a pre-existing program in the VA. This will increase screening and education intervention during pregnancy and postpartum. And we are partnering with the Community Health Aid Program, or CHAP, as well as our public health nurses, community health workers, doulas, and birth support workers. We have 5 IHS areas interested in participating in the pilot: Albuquerque, Great Plains, Navajo, Oklahoma, and Phoenix. So really excited to get this off the ground, and we'll certainly keep this committee updated. Lastly, to increase our communication with the field, always is our goal to bring policies and programs to the bedside. We continue our MCH newsletter, as many of you receive twice monthly. Please let me know if you're interested in receiving this. Carved out an MCH space on the IHS website for launch later this month, and we've been invited to collaborate on several webinars, including responding to the rise of congenital syphilis in Indigenous communities, looking at maternal mental health and the family spirit home visiting program. We're now been invited to develop curriculum with the Northwest Portland Area's Indian Health Board, Indian Country ECHO, on care and access for pregnant people from Indigenous communities. Our next one will be on substance use disorder in pregnancy, Tuesday, August 15th at 9 in the morning Eastern time. So thanks for the opportunity to provide updates, and happy to answer any questions. Thank you all for the work that you do.
Thank you, Tina. Can you repeat again what the pilot sites are for your, I think you said maternity care efforts and a couple other things?
Sure. So 5 IHS areas of the 12 have expressed interest in starting this MCC program. So Albuquerque, Great Plains, Navajo, Oklahoma, and Phoenix. And this is very much, again, a pilot phase. You know, we want to, of course, make sure that this is something that shows impact, but additional sites are interested as well. And hopefully we can ideally expand, as the VA has, you know, that has an MCC at every site.
And your pilot is for a year. What's the time frame? Excuse me.
Right now, we are actually able to hire, and so we intend to continue ongoing with these 5 areas, and certainly have the support to do so. We'll certainly study outcomes as we go, so we don't have the time restriction.
Oh, wonderful. Thank you. Well, in the building with us for our next in-person meeting, because we want to hear more about that. Thank you.
Of course. Thank you.
And I did reach out to any questions for Tina? I'm sorry. Any questions or anyone that's shared? I did reach out to our former acting chair, Ed Ellinger, as well as Janelle Palacio, to see what efforts that they have been working on to move the recommendations forward. And as you know, they have both been very busy. But they were able to share, you know, there's been a U.S. World and News Report webinar confronting the crisis of inequitable maternal and infant health outcomes that I think Janelle participated in and was part of that webinar. They've also, I know Janelle participated and did a couple of presentations at the AMCHIP conference around health beginnings with Title V, building the racial equity competence through partnerships between Title V and community-based organizations. She did a couple of presentations during the AMCHIP conference. I know Janelle also participated with the maternal health tribal learning, community health and well-being, reconnecting indigenous lifeways. They did a webinar, and so we can send that link out because that webinar is actually now on YouTube, so people can listen to it. Janelle also participated in the National Healthy Start, their 2023 conference. She did a plenary there rooted in storytelling in clinical practice, research, and policy that was very well received. They're also planning a podcast, an incubator podcast that her, Janelle and Ed are doing together with the University of Illinois at Chicago. It is planned for July the 27th. We can share information on it. I think Ed had shared that there is some work going on in Minnesota with their local PBS station, and they're doing some work in this area. And there's some ongoing conversations going on with the Kellogg Foundation around ways that they can move some of the recommendations into action. As we know, CDC has already released their Hear Her campaign with a very specific American Indian, Alaska Native focus as well. There will be a fireside chat on Native American and around maternal health. It was held actually in March and is now part of the Policy Center for Maternal Mental Health. ProPublica is looking at this area, so this may be something for those of you who've ever worked with ProPublica or seen articles they release. They do a lot of background research, and then they'll release a series. So this is an area they're looking at. And then most recently, ASTA podcast will be released soon, where they will be sharing this information. So when we get that podcast, we will share back out with our committee members. So as you can see, they've been very busy, and I'm sure I left something out. But those are the things that I am aware of that Janelle and Ed have been working on. So any questions from anyone? No questions. I can't believe we're right on time. Anyone in the chat? Everybody in the chat is fine and quiet? Okay. We are going to move on with our agenda then. Our next presenter, and we're happy to have with us, our focus is on social determinants of health, and we're happy to have Andre Chappell with us. He's the Director of the Division of Public Health Services, and specifically the Office of Health Policy and the Office of the Assistant Secretary for Planning and Evaluation. When I did one-on-one conversations with each of the appointed members of ACIMM, many of you mentioned that social determinants of health, social drivers of health, was one of the areas that you wanted us to delve more into and look at ways that we could elevate this work. And so we were very fortunate to have with us today Andre, who will share his work specifically around social determinants of health, but I think it will also lean into some of our conversation on housing. So turn it over to you, Andre. Thank you.
Great, thank you very much. I'm delighted to be here today to talk about a couple of different topics that I've spent quite a bit of time working on over the last few years. It's been a great deal of my attention on these topics. I feel very strongly about them. And I just want to note that I think it's terrific that you've got 2 new members from other departments around the federal government. It can be really challenging. There's so much going on in the federal government for us to collaborate closely on some types of initiatives. I think we do a pretty good job within HHS. But especially when you're crossing boundaries, not just across departments, but across topics. It's one of the things that's been really challenging about what I'm about to talk about, which is social determinants of health. You know, at Health and Human Services, we have health and human services, and they often operate along their paths, and we're trying to get them to cross over more and more in that. And that's terrific that we've got these 2 new members. So move on to the next slide. So I'd like to start off some of my talks with just saying who are we at ASPE, because a lot of people don't know. It's the Office of the Assistant Secretary for Planning and Evaluation. We go by ASPE. A lot of folks don't know who we are because we don't deliver services to the public. We're located in the Office of the Secretary. We're considered a staffing division. And so people who are in sort of the health policy community know of us, but others outside don't always know who we are. We serve as the principal advisor as an office to the Secretary. The Secretary has many different advisors across the department. I like to think that one of the value adds that we bring as an organization is our cross-cutting view on what's going on across the department. We have somebody at ASPE that touches every part of the Department of Health and Human Services. It's kind of a fun place to work because if I want to know about what's going on over at FDA, I can walk down the hallway and talk to one of my colleagues about that. Within ASPE, we have a few bread and butter sort of activities that we do. We are a research and evaluation shop. That's one of the main activities that we undertake. We always undertake activities. So when we're going through our research planning phase each year, one of the most important criteria that we judge when we're trying to figure out what we're going to work on in the next year is what are the policy implications of the work that we could be doing. We want to make sure that we have policy levers, that we have somebody in the department that's going to uptake our work, that they can do something with it to inform decision making. We do both quantitative and qualitative types of research. We have access to pretty much all the data across the department, including all the CMS, Medicaid, Medicare claims data. We have survey data. We buy private claims data, surveys, what have you, to be able to inform the work that we do. We also do a lot of qualitative work with, especially with some of our agency partners, where we'll go out and do case studies. We'll convene technical expert panels on topics where we're looking to inform the work that we're doing. And we co-chair the department's legislative development process. For a lot of folks outside of the federal government, when I say legislative development, they're like, what is this about? You're the executive branch. Why are you doing legislative development? Well, the president's got a budget every year, and the part of the president's budget is a series of legislative proposals. And so those all have to be developed somewhere. And so each department has a process whereby we develop these proposals each year. And these are all where we need authorities that don't currently exist. They're not for topics that we can address through our existing administrative authorities. So we're telling Congress that we see something that could be improved in one of our programs, but in order to do that, you have to give us additional authority. And then we do provide input on a variety of different clearances that I mentioned here. So we'll move on to the next slide. So these are a few of the topics I'm going to be talking with you today. I'm going to provide a little bit of context on social determinants of health, and another term that we use, health-related social needs. I'm going to talk a little bit about an action plan that we developed at HHS, as well as some follow-up activity that we've been doing with the White House, and implications for all of this for maternal and infant health. Next slide, please. And we can keep moving. Okay, so, I think for the members of this committee, you're very well aware of what do I mean when I say social determinants of health, health-related social needs. The primary distinction that I'll mention here is social determinants of health are the underlying factors that exist within a community where somebody lives that can impact their well-being. So there are things like transportation, education, the neighborhood and built environment, in social and community context. For health-related social needs, it's can be an expression of where somebody lives, the impact that it has on them individually. So social needs, things like financial strain, housing stability, food insecurity, access to transportation. So you can see there's a tie-in with social determinants of health, but there's not necessarily perfect overlap. Somebody could be living in an area that has a solid sort of foundation of social determinants of health, but still be struggling. Somebody could be living in an area that is got a lot of challenges, but they happen to be in a stronger personal position. We'll move on to the next slide. So this is what we've been calling our social determinants of health ecosystem. It's just sort of a fun diagram to try to explain how all of this ties together. It's not, intended to be perfect in any sense, but it is intended to give sort of a conceptual view of how we view the situation. So upstream, you're looking at the social determinants of health, underlying factors. Public health has a role to play in prevention here, multi-sector, public-private partnerships. You're looking at whole of government types of initiatives to try to address the underlying factors in these communities. As you move down the stream, you're moving into midstream, which is human services. And this is basically where if you have challenges with social determinants of health, they can express themselves in terms of personal social needs. And moving then all the way to the bottom of the stream, you're getting down to health outcomes. And this is where we really don't, ideally, we're trying to prevent things from getting all the way down the stream. We want them to stay upstream and promote prevention at the earliest possible point. As you move down the stream, though, if somebody develops social needs that can affect their health as well. And that's why we call those health-related social needs. And we really want to have the healthcare and social care sectors working closely together to do a better job with coordination of needs. So we can move on to the next slide. On this slide, I think the main point here is just to say that, these factors are really important. Up to 50% of county level health outcomes are affected by social determinants of health. We've got a diagram that we show here that the Robert Wood Johnson Foundation helped to prepare. And it just indicates that while clinical care is extremely important once you develop a medical condition, obviously vital to be able to address that successfully, there's a lot more going on that determines health outcomes. And it's really important that we don't turn a blind eye to that. We can move on to the next slide. And this slide is just intended to say, all of these disparities that we see in social determinants of health, underlying structural factors, are also some of the contributors to disparities that we see in health outcomes for the reasons that I just mentioned. So just take a pause here to just say that there's a number of different things that I've listed that can affect people's health outcomes. And we can move to the next slide. Okay, so the next few slides are not intended to be, a thorough review of the literature. But I did want to dig in a little bit and say that, social determinants of health, health-related social needs are not just factors that affect everything else, they affect maternal health as well. There's a few studies that I've listed on this slide and the next ones that talk about poverty and its impact on maternal health and infant health. Educational attainment, again, maternal health, infant health. We can move to the next slide. Housing, so great that we have our friends from HUD here joining us because it's incredibly important. Housing instability is got a lot of really unfortunate implications for both maternal and child health. And I was surprised when I was looking through the literature to find that infancy is the time in somebody's life when they're most likely to be having housing instability, which is really, really traumatic, I would imagine. Racial segregation closely linked to housing, where do people live and the impact that that has on opportunities to be able to access all kinds of things like healthcare, social services, what have you. Nutrition, this one I almost didn't even list because it's like, how could nutrition not impact somebody's health, and especially maternal and infant health. And I've got a little shout out to WIC there because so I was glad when you were talking about that because I thought, geez, there it is. Having participation in WIC can really make a difference in somebody's health. And the environment as well. So it's, the environment often gets skipped over because it's sort of challenging and like it's this big issue that we have to deal with that spans more than just like health and social care, but it's also incredibly important. And, every day we're seeing the implications of the environment. And I take a pretty broad lens on what I mean by that. Air pollution here is what I've listed. But there's all kinds of things like lead and safety issues and everything. So we can move on to the next slide. And then these are just some of the citations just for people's reference, but we can keep moving. Okay, so now I'm going to switch gears. I'm going to talk a little bit about what we've been doing here in HHS to try to address social determinants of health. And we can move to the next slide. So early on in the administration, ASBE and CMS met with the chief of staff to present some work that we had been doing on socioeconomic status and social determinants of health. The chief of staff was quite enthusiastic about the topic, said he'd be interested in finding out what else is going on around the department on this topic, expressed that it was something that was certainly of very much of interest to the secretary. And so we said, well, we can develop an action plan. That's one way to sort of operationalize learning what we're doing across the department and starting to think strategically about what do we think are sensible next steps to try to address this topic. We convened a group of folks from across the department, 130 plus folks, to help us develop this action plan, including, I think, pretty much most of the operating divisions and staff divisions in HHS. And I've listed a few of the materials that came out of this process. So this was back in April when we developed this plan. We didn't make it all publicly available because, as I mentioned, a big part of the plan was to try to think strategically about what we wanted to do next. There's deliberative type of process, and there's things in there that we're talking about potential next steps, but things that we hadn't finalized that we were going to do yet. But we did release a summary of what we were doing, both in a JAMA Health Forum article, as well as a 2-page summary on our action plan on ASPE's website. And we also did a review of evidence-based strategies and federal efforts. So it's just sort of a review of what do we know about what's working out there for social determinants of health. So you can find all of that at the link that you see on this slide. And we can move to the next slide. These are the 3 goals that we had in the action plan. The first one was enhancing data infrastructure and utilization of data, something we love at ASPE. We love working with data. But it's not just about doing research. It's about trying to improve quality. It's about trying to share data to make sure that we have good coordination across sectors, interoperability, what have you. Goal 2, which was improving the affordability of healthcare services and support partnerships between healthcare providers and community-based organizations. I'll be talking a little bit more about this as we move forward. And goal 3, this is our whole of government approach, trying to tackle the underlying social determinants of health. Something that's we found, for us just within HHS is a little challenging to do because many of the levers that exist elsewhere in the federal government. But there was something that developed a little bit later, which I'll talk about in a few moments, that allowed us to do more of that. So move to the next slide. Okay, so following up after we developed our action plan, we coordinated 4 different priority groups. And this is where I was talking about where we had some deliberation during the process of developing the action plan. People sort of circled around various topics where we found multiple people in different agencies wanted to do additional work on them. And there's 4 of them listed here on the screen. I'm going to talk a little bit more about the first one. It's something that I was personally a little bit more involved with, and it's sort of informed other things that we're doing as a federal government, but all of them equally important, and they're all contributing to strengthening our efforts. So move to the next slide. Okay, so for this first group, health and social care coordination, you can see our vision statement here. We had a vision of developing an interagency approach to coordinating HHS policies and programs that can drive alignment of health and social care. We really believe that it's not only important, we've done lots of things as a federal government to try to expand access to healthcare services, but it's really important that as we have more and more people being able to access healthcare, that there's venues for them to have their other needs addressed, their social needs addressed. You can see on the slide here, there's a number of different policies. The ones I've listed here, I think all from CMS, and they're all intended to try to improve access to health-related social needs in different ways. So there's new screening measures that are being implemented through regulations at CMS that are incentivizing providers to engage in screening of health-related social needs. But that's not the end of the story, right? So you screen somebody for a health-related social need, and then it's just like medical care. If you just screen and then you don't follow up, what's the point of doing that? That's actually can be not helpful. So, we're trying to find ways that we can expand what we're doing within current existing authorities to be able to support access to these services. And you can see here that CMS is doing actually quite a bit through Medicaid program, as well as through Medicare Advantage for older Americans. They are opening up opportunities to be able to pay for social services on a limited basis, but nonetheless able to pay for them under certain circumstances, particularly when it's been demonstrated in the literature, in the evidence base, that addressing a social need could result in savings and improvements in quality of outcomes for health outcomes. And then there's some new measures that in terms of maternal health that CMS is putting out, which I'm sure all of you are aware of already, but severe obstetrical complications, sort of similar to severe maternal morbidity measure, a birthing friendly designation, and cesarean deliveries. And we think that all of these have tie-ins to social determinants of health, and trying to improve on all of these metrics means that there's probably it's probably gonna help drive the agenda for moving forward and addressing social determinants of health. Okay, next slide, please. And I think it might actually be the slide before this one, is it? Thank you, this one, yep. Okay, so how do we go about doing this? None of us are blind to the fact that being able to adequately fund social services is vitally important. And, that can be a challenge at times. I did mention on the last slide some of the actions that CMS has taken to try to open up our new opportunities to be able to fund this. And, funding is one piece, but actually being able to connect people to care is the next piece. And so if we're successful at being able to have people screen for social determinants of health, we want to create an environment at the local level that encourages coordination across the social care sector and the healthcare sector. One promising approach that we've identified is community care hubs. They're a type of backbone organization. They represent a network of community-based organizations that come together to for a number of different functions. We've got a blog post listed here, and I think one of their things that they're doing is trying to come together to establish contracts with healthcare providers and manage that process, because it's really difficult for any given community-based organization to figure out how they're going to engage with the healthcare sector and manage, there's a lot of complex processes and things in terms of managing referrals and so on and so forth. So they sort of serve as the backbone administrative organization for a group of CBOs to come together. And I've listed a number of different functions that they can engage in. They can integrate sources of funding across multiple funding streams, something that's incredibly challenging, as many of you already know. And they can develop that sort of intellectual capacity to know what grants are out there and how to braid and blend them together appropriately. They can help with managing referrals and payments, ensuring that delivery fidelity and compliance. And that's just to say that the whole process, they can try to standardize so that people having the same experience coming in from different healthcare providers and going to different areas of the network to have their needs met. Implementation, IT implementation and maintenance. This is an incredibly important one. It's getting at the whole idea of the silos in electronic health records and trying to break those down, but also the communication between social care and healthcare and information sharing. And that can be incredibly challenging as well. And there's, a number of different vendors out there that have entered into this space. The systems don't always talk to each other. So we're trying to support having more communication between systems to improve coordination. Data collection and quality improvement, reporting, that all comes from trying to improve these data sharing mechanisms. Fostering the community-based workforce development, something that CDC has been doing quite a bit with, and as well the others around the department. And we can, I think, move on to the next slide. And this diagram is just intended to sort of be one way to see like what kind of functions does the community care hub engage in and how does it all fit together. So some people can come in through screening. It could be through a healthcare provider. It could be through this community care hub organization as a whole. It could be through an individual community-based organization. You're connecting them with other services. You're having a referral sort of feedback loop. We call it a closed loop referral, to make sure that not only was the person referred, but they received services and this was the outcome of it. And then you're tracking outcomes to try to get at that quality improvement piece over time. Okay, can move to the next slide. I've listed a number of related efforts that are going on across the department to try to support this type of environment. ACL and CDC have been partnering on trying to support community care hubs. They've developed a national learning community and center of excellence programs to support the continued development and expansion of hubs. ACL directly supports a number of hubs across the country. The Office of National Coordinator for Health IT, this is getting at interoperability of SDOH and health-related social needs data. So they have a few different programs that they're operating to develop standards and to try to promote adoption of those standards. There's the partnership. This is outside of HHS per se, outside of the federal government, but something that we're engaged in nonetheless, the Partnership to Align Social Care, which is really bringing together all these organizations that are involved in these hubs and trying to develop strategies to encourage partnerships at the local level. The CDC's community health workers, so this is getting back to the community-based workforce topic that I was talking about. These are all kinds of different folks that fall underneath this umbrella. It's intended to be a broad terminology. Community health workers, doulas could fit under this. A number of different sort of supports that aren't necessarily clinician-based. And then of course, HRSA's community health worker training program as well. So they also have a community health worker training program. And these are the types of folks that often get engaged in community care hubs that are all about trying to coordinate services, engagement with the community, and so on and so forth. Okay, we can move to the next slide. The CDC also has something it's called accelerator grants, and these are planning grants and then also implementation grants. They've moved on to implementation now to try to develop approaches to trying to address social determinants of health at the local level. They go out to a variety of different kinds of organizations, everything from tribes to local communities, different organizations. And then there's complementary efforts. I've listed these. These aren't, quite as directly related to supporting hubs or supporting local community coordination, but they have implications nonetheless for the operations of hubs and trying to coordinate services. So there's HUD we speak to here, and then the CDC has a few different cooperative agreements that they've built social determinants in as a focus on. Okay, we can move on to the next slide. Okay, so these now are switching over to maternal health a little bit more again. And these are a number of different programs. Again, not all of them are, quote, about social determinants of health, but social determinants of health has implications for all of these. The NIH has the Improve initiative, which is really trying to get at what are the underlying factors that are affecting maternal health outcomes. And you'll see here that I've highlighted in blue structural factors. I think that gets a little bit of the underlying social determinants of health. And they're really building in a focus on having community identified needs and having community participation in research planning. And then for CDC, we've got MMRCs, PQCs, and I think they just can really benefit a lot from having community engagement to understand what are some of the non-medical risk factors that are contributing to maternal health outcomes. And I know they're doing work in this space to try to bolster community engagement. Mentioned here, going back to some of the discussion a little bit earlier about facilitation of cross enrollment across different benefit programs, Medicaid programs, working with WIC. There's a lot of different programs that are getting into this and trying to figure out how do we best get multiple folks enrolled in all the different programs that could be benefiting them. And then there's other efforts like the White House Conference on Hunger, Nutrition, and Health that have obvious implications with social determinants of health for maternal health. Okay, so we can move to the next slide. Okay, so just on this slide, this is really like, what are you all about here? Why are we meeting here today? And how can you help us? Because we need help. Addressing maternal health has obviously proven to be very challenging. I think there's lots of wonderful things going on that I hope are going to, turn the situation around in the next few years. But we'll wait to see. Social determinants of health, as I mentioned at the beginning of the talk, also very, very challenging for its own set of reasons. But maternal health is affected by many different things. I think, as I mentioned a little bit earlier, social determinants of health and health-related social needs are certainly some important factors that figure into this. I think dealing with social determinants of health is probably a little bit more challenging because it really gets at some of those underlying factors. I think they're incredibly important, but probably a bit of a longer term prospect to be able to address. Health-related social needs also are challenging to address, but with some of the recent policies that we're putting out by the department, I'm really hopeful that we'll be able to do more in terms of trying to meet the needs of our beneficiaries in more ways than just healthcare or just social care, but the full picture of well-being holistically. So, in this environment of limited resources that we're moving into, obviously with the recent legislation, we all know that we're going to be living in an environment of limited resources. What types of things could we be working on within that environment that are going to make the most difference? What are the things that are going to push the needle most? I've put some food for thought on this slide and the slides that come before this, but we really are looking forward to hearing your advice on what we could be doing as a federal government to make further gains here. So thank you so much for your time today, and happy to take any questions that you might have.
Thank you so much, Andre. And we'll take a moment for maybe one or two questions. If anyone in the committee, anyone has, including the people in virtual land, you can ask questions as well.
Yeah, I think I'll go ahead. Thanks for the presentation and kind of the outlining of all the possible solutions. I know that I quickly looked and your background is a lot in healthcare financing and kind of just how to drive things. A number of years ago, I just kind of looked at the fact that we in the US pay about $140 billion for pregnancy care, about 50 to 60 billion are public funds. And we've got this scattered thing of Medicaid all around the country and Medicaid managed care. Do you have any thoughts on how kind of just paying for care in a different way would drive a lot of this? I mean, I see we have an interest in coordinating and community hubs. And if you also, maybe just adding one other quick question, do you have any thoughts on the health bond idea? I'm not sure what I feel about that either, but kind of providing incentives to address social determinants. I think that also might get into a problematic approach with just, the profit motive just sort of drives that too. So I don't know if I made it.
Yep.
Clarity of a question.
Yeah, and I'm not as familiar with the bond issue, but I can say that, so one of the interesting spaces in HHS over the last, 10 years probably or so has been over at the Centers for Medicare and Medicaid Innovation, where they've been testing out a lot of different types of models to be able to cover services. They recently completed work on the accountable care health community model. And, one of the challenges they did run into, even though they were trying to coordinate services, they weren't able to provide some of these financing for social needs. And when they were trying to coordinate having people go to get social care, they were finding that not only that was the issue, but more so was just trying to have enough capacity in the social sector to be able to address the needs of people who are going to them. So that's something that we're continuing to think of, more about how can we try to bolster the sector and do what we can to try to create efficiencies as much as possible to try to ensure people can get these needs met. But I think it's a chicken and egg situation we're always dealing with. Like, if you don't have the financing, how are you going to build the capacity? And then you build the financing, and then you don't have the capacity. So I think it's going to take a number of years for us to figure this out, but certainly something that we'd be interested in hearing more about from you all if you have thoughts on this.
Kind of a follow-up. I agree. The CMMI work is really interesting. And I've just become passionate over the last decade, seeing kind of the chaotic way that care is paid for. Fee for service, it's a big problem just in general in the system. Pregnancy is such an ideal episode. It's time limited. It's pretty definable. And the more we can do it that way, and then also provide transparency about how the money is spent, and then accountability about outcomes. And of course, there will be clinical entities that'll say, well, we really can't fix this housing problem, but this, we can then connect with people that can. So somehow starting with pregnancy as an episode, it's something where we all started basically.
Definitely.
Thank you so very much. We don't see any other questions, but if we could get a copy of that. I think you had a 2-page summary on your action plan. That will be helpful that we can share with the rest of the committee. But thank you for your time and coming to be with us today.
You're welcome. Thank you, everybody.
Thanks. We're going to continue on with our agenda. And if you need to just stand up or move around a little bit, take care of your personal needs, because we are going all the way to lunch. Okay. But we're happy to have our next panel with us, where we're focusing again on social determinants of health and the impact of housing on birth outcomes. So we are fortunate to have 3 panelists with us today. We'll start with Veronica Helms, and Veronica is with HUD, U.S. Department of Housing and Urban Development, and specifically in the Office of Policy Development and Research. After Veronica joins us virtually, we'll then have Adam Mueller. Adam is the Executive Director for Indiana Justice Project, which is one of the catalysts for infant health equity programs funded out of the division. And then we're fortunate to have in person Lachelle Stewart with us. She is the Baltimore Healthy Start Executive Director, and they're also one of the catalysts for infant health equity. So we will go in that order and start with Veronica.
Awesome, thank you. And when I try to hit start video, it says you cannot start your video because the host has stopped it. I'm happy to present without video, but I just wanted to make sure we were all good.
Okay, we see talking up in the corner. We will get a message to you. Why don't you
Oh,
go
I
on?
gotcha.
And then we'll see you at some point, Veronica. Thanks.
All right, great. Can you all see me now?
We can see your slides. We cannot actually see you.
Okay, let me try again.
Okay, if you start, so she has control. Think you have control of your own slides if you like to try to start, right?
Perfect.
Oh, some people can see you. We just can't see you in the room. So
I gotcha. Well, thank you guys so much for having me. I'm going to be filling in today for Solomon Green, who is the political appointee that oversees the office that I sit in, the Office of Policy Development and Research. I know that this is a really important to him and a really important cause, but he's actually representing Secretary Fudge at the UN this week. So he is out. So you guys get me. I'm sorry, but I'm really passionate about this and excited to talk to you all about this topic. All right, let me see if I can move my slides. There we go. So as I'm sure all of y'all know, HUD's mission is to create strong, sustainable, inclusive and communities and quality, affordable homes for all. And our most recent strategic plan, which was for fiscal years 2022 to 2026, has 5 core goals, which are listed here on this slide. Most of the work, I think that is in this maternal and child health space falls under goal 4, which is to advance sustainable communities. And the reason, sorry, I'm just trying to, okay, sorry. And the reason I bring this up is because within goal 4, we have 3 sub goals. The first one is 4A, guide investment in climate resilience. This is really focused on climate change, renewable energy, what HUD is doing in this space. 4B is strengthen environmental justice. This again is in the climate resilience space and focuses on healthy homes, reducing inequities, environmental hazards. But what I really want to draw attention to in this group is 4C, which is integrate health and housing. And the office that I sit in, the Office of Policy Development, actually leads this particular strategic plan goal, which is to integrate health and housing. And for the first time in the agency's history, we have a specific mile marker or goal that is improve maternal and child health, which I think is really exciting. When I started HUD about 10 years ago, it's something that I wouldn't have imagined, but I'm so happy to see. So we've heard a lot from other speakers about housing insecurity, and I know a lot of folks are familiar with the concept. What's interesting about housing insecurity is that on the research side and the data side, there's not necessarily an agreed upon metric or measure for what housing insecurity means from a measurement perspective. But when you think about persons of reproductive age and their infants, we really want housing that is safe, physically adequate, affordable, based on choice, and certain. And this can really, again, it really depends on who's talking about housing insecurity as to how it's being defined, who the research community is, or if it's a program. It can tend to really span a large gamut. So it can be everything from red burdened, are you paying more than 30% of your income for housing, to are you facing eviction, whether it's formal or informal. We know that's a pretty big issue following the pandemic and even pre-pandemic. Are you facing violence in your home? Are you living in your car? But we also think that if you live in poor housing quality, we would also consider that to be housing insecure. So on a broad perspective, on the HUD side, I'd say that we tend to be pretty inclusive in what we believe housing insecurity really entails. So this graph here shows housing insecurity during the COVID-19 pandemic. I don't know if folks are familiar with the Census Household Pulse Survey, but it's a really great survey that was deployed in April of 2020, so about a month after lockdown started happening. And the survey started out weekly, now it's monthly, but it was one of the first times in government, I'm sure all the data people know, that we actually had data in a timely fashion. So we were getting data about a week after it was being fielded, which was really exciting. And we were kind of able to assess how many folks were confident in their ability to pay rent, how many folks were fearful of imminent eviction, how many folks were behind on rent. And I think that this graph does a really good job of showing from time, so April 2020, when the pandemic first started, we see about 5.4 million renter households that say they're not confident in their ability to pay rent. But you see that it really tends to ebb and flow based on what's going on in the larger political environment. We see peaks around May of 2020 when Dr. Fauci testified before the Senate and they were talking about mortality numbers. But then we also see in December of 2020, once the FDA approved the vaccine, numbers started to go down. So we're continuing to track housing insecurity post-pandemic. We see that numbers are a little lower than they were in April of 2020, but we know that this is a problem that's not going anywhere, and we really just want to continue to track it. So what is the current state of housing insecurity for women and children? I believe the colleague before me underscored a few of the points that I'm also going to underscore. So first, we wanted to think about women and children that live in public and assisted housing. Women represent about 70% of all HUD-assisted adults, and over 3/4 of them identify with a racial or ethnic minority group. We estimate that approximately 50,000 new babies are born every year to HUD-assisted women, and children comprise about 36% of all HUD-assisted children. An interesting statistic about these 50,000 new babies, we're working on some research now where we were trying to look at the timing of when someone gets on a wait list versus when they're homeless, when they get on a wait list, and then when they actually enter the program. We're seeing that what often happens is that women will find out they're pregnant, but they'll get on the wait list, they'll have the baby, and then they'll be admitted to housing. We would love to see there be a shorter window between when we would like to see that baby born when they are housing assisted versus while they're still on the waiting list, because there's an emerging kind of body of evidence that suggests folks without a voucher versus folks with a voucher tend to have better MCH outcomes. And I'll talk about that a little bit more in a few slides. But one thing I just want to underscore about HUD-assisted women and children is that they tend to be high utilizers of the public health care system. For example, about 1/4 of women report having 2 or more emergency room visits during the prior year. Self-reported health is not that great. And for children, we see high rates of some ailments such as asthma and learning disabilities. So I again want to underscore what my last colleague said about infancy is the period of life when a person is most likely to live in a homeless shelter. And approximately 10% of homeless families have an infant under 12 months of age. And this goes back to the point I just made about really trying to understand that trajectory of pregnancy, wait lists, and homelessness. We're really trying to understand what that timing looks like and how we can decrease that timing to better serve special populations. We also see that there's a strong link between housing stability and MCH. Prenatal homelessness is associated with higher odds of low birth weight, preterm delivery. Again, in this group, I know I'm not saying anything that's new or astounding, but just to underscore some of the statistics in this space. So we wanted to quickly highlight some promising MCH and housing efforts that we're really trying to think about as we move forward in our strategic plan and move forward with thinking about how we can address this goal of improving maternal and child health. We see that there's a small but robust is what we've been calling it, emerging body of research that shows that when housing assistance is paired with health services, there can be striking results for maternal and child health outcomes. I'm going to bring up a few studies. So the first is the Ohio Healthy Beginnings at Home study, where we did do a joint briefing on this want to say a couple years ago, but I feel like I have no concept of time anymore, with ASPE, where we brought together these researchers and they did a presentation to HUD and HHS staff, which is really great. There are some issues with power just because they didn't have a very large sample size, but the results are still pretty astounding. We saw that babies in the intervention group were less likely to be admitted to the NICU. When NICU was required, the average day spent was lower. And then we also saw differences in terms of full term and healthy weight. The family options study is another study I just wanted to quickly underscore. It is a large scale RCT where essentially homeless families with young children were given 4 interventions, one of which being a voucher. We saw that families who were given vouchers had less child separations, decreased maternal psychological distress, fewer child behavior problems. We really saw that those results were pretty outstanding. That study is continuing on, and we're continuing to track these families, but this study really does gives us some of the best statistics in terms of what can vouchers do for families that are facing homelessness. And lastly, I'll bring up Boston's Healthy Start and Housing Program. This program was in Boston. It was similar to the Ohio one in the sense that they had a carve out of vouchers for pregnant women. And then they also use home visiting, and their evaluation really showed that there was improved mental health status and reduced stress for women in the program. So what are we doing moving forward? HUD, as I mentioned, really has a commitment to improving outcomes for women, children, and families. I think Alika might be in the room. We're so happy to have her represent HUD and help move the ball forward. We're really thinking strategically about what is this emerging body of evidence and how can housing really improve maternal and child health? How can we facilitate cross-agency research? And how can we build partners with MCH stakeholders? So there are a few studies, 2 specific studies we're working on with the National Center for Health Statistics to really quantify some of these MCH outcomes using some linked data sources that I can get into another time. But what we wanted to ask, and I know Richard said this when he did this meeting in 2021, is really to include HUD at the table, to consider how we can incorporate housing screening into existing programs to really help build stronger partnerships at the state and local level, and explore shared programming funding opportunities. I will underscore that we did have a large influx of money to prevent eviction. And as those grants start to go out the door, I think there's also opportunity to incorporate that into MCH programs. So here are just some resources, but I just want to thank everyone for their time. I don't know if we're doing questions now or at the end, but I appreciate having the opportunity to chat. I appreciate Alika being in the room, and thanks for having me.
Thank you, Veronica. We're going to go on to Adam, if you can hang around, and we'll do questions at the end. Thank you.
Hello, can you hear me okay?
We can hear you, Adam, and apparently you may be able to turn your camera on if you want to.
I think it's on. I can see myself, so I think we're good. Okay, great. Well, thank you everybody for having me here today. I will be brief in my comments and my slides, knowing that we're heading up against lunchtime. A little bit about me. So I'm the executive director of the Indiana Justice Project. We're essentially a law and policy / legal aid organization in Indiana. Prior to that, I had 16 years of experience as a legal aid attorney at Indiana Legal Services, working on a variety of housing-related cases, Medicaid-related cases, those sorts of things. And I'm here to represent a team of folks from the Housing Equity for Infant Health Initiative, which is the project that is HRSA funded, Catalyst funded, and we're really excited about it. Next slide, please. So as I mentioned before, Indiana Justice Project is a statewide law and policy program, and we're focused on health and economic justice are sort of the areas that we look specifically at. And our essential mission statement is equal justice and opportunity for all Hoosiers. Go ahead, next slide, please. So this is a bit of a reiteration of what we've already heard today, but the overview of sort of the premise behind this project is to show that there's a consistent relationship between housing instability and adverse pregnancy outcomes. If we can address housing, we can address that social determinant. Next slide, please. The project itself has several partners. I've listed a few, but I'll also mention a few others. So the lead partner is the Grassroots Maternal and Child Health Initiative, which is a project out of Indiana University. The actual grantee of the recipient of the Catalyst funding is the Indiana University trustees. Then through that, there are several different buckets of work that are being done. And I'll talk about those in a second, but some of the partners include City of Indianapolis, state agencies, CareSource, the managed care organization, and Indiana Justice Project, which is us, as well as several sort of affordable housing related organizations. Next slide, please. There are essentially two interventions to the project. The first is the Healthy Beginnings at Home, and our previous speaker did a really good job of describing the model that's is being done in Ohio. We're essentially replicating part of that in Indiana with CareSource, who was also involved in the project in Ohio. So we're really excited to have them on board with that. And then the initiative I'm going to talk a little bit more about today is the health justice intervention. So we're sort of the lead organization working on this particular intervention. Next slide, please. In the simple, go back to the last slide, please. The simple premise between the health justice intervention is that we use all available legal tools to improve housing, health, and security for pregnant moms and babies on a systems-wide level. So that's sort of where we're starting with our premise, and we'll talk about how we do that with the next slide, please. There are essentially three buckets of work being done in this area. The first is education, know your rights, materials, and presentations. So this is going to consist of a periodic bi-monthly presentation given either in person or virtually to folks who may be housing insecure or facing housing insecurity on what are their rights? What are their rights when it comes to being facing eviction? What are their rights to healthy housing, housing free of environmental hazards, that sort of thing. The second one is a strategic court advocacy intervention, and this has a lot to do with sort of thinking about that engagement with folks who are housing insecure and where that actually translates to legal action. So oftentimes that's talking about people who are facing evictions and court cases that are sort of moving through the system. That's also about a dialogue with the judicial system. One of the things that I like to think about with this is if you think about how the speakers have talked about starting with health as the core and then moving out to sort of looking at those social determinants of health. And one way we're sort of looking at the legal sphere and the legal judicial ecosystem, and how do we bring health considerations into that conversation, and what does that actually look like? And finally, it's legal analysis. So helping both housing related advocates as well as health related advocates understanding how laws as currently written in Indiana are affect housing insecurity and affect health outcomes, and then helping to sort of do that analysis if there are proposed laws or regulations and about how that would affect them. That also includes looking at amending court rules when it comes to how evictions are processed, and seeing what that how those things may be changed as well. Next slide, please. All of this work that we do in the health justice intervention is also informed by what we call our health justice intervention work group. And this is a group that meets monthly that consists of housing law experts, grassroots community leaders, and other folks that are interested in, and we sort of talk about what are the goals of the how are the goals being achieved, What strategies should we tweak to achieve the interventions and that sort of thing. It's a really great place for us to get sort of dialogue and feedback. Next slide, please. So within the first year, we've sort of hit several different tackled several different objectives and feel really good about sort of where we stand with the project. We were approved on our IRB for our Know Your Rights sessions. We're actually having our first session tomorrow night virtually. We have about 33 participants. We're really excited. Part of this, I should say, going just a step back, the theory behind the Know Your Rights is creating, giving rights bearers, giving them the sense about what rights they have, either affected individuals or community partners, so that they can then become, sort of go to the community to help sort of explain and sort of be empowered to exercise those rights. We have represented about 4 or 5 individuals in eviction proceedings. I'm really excited that to mention that one of the sort of the early successes we'll be writing up is we recognize that the way that eviction orders in a particular court were being issued needed to be tweaked a little bit in order for folks to be able to apply for certain kinds of rental assistance. It was through our advocacy that we established that, and that was through an individual client representation. But obviously, working with a judge to figure that out, for all the folks who don't have representation in court, this is now something that could be applied to them. We've had 2 written products. One of those was a commissioned product from the University of Notre Dame's Law School Clinic that sort of looks at Indiana's eviction laws and compares them to the American Bar Association's sort of 10 guidelines for stopping evictions or avoiding evictions, and sort of says, how does Indiana compare? And this is useful for policymakers, useful for decision makers, judges, that sort of thing as well. This month, we had a piece published in the Indiana Bar Association's magazine that essentially says that judges and the courts and the law should recognize the impact of evictions on pregnant moms and babies in doing their legal analysis. That went out to over 8,500 members of the Indiana Bar Association. We're really excited about that and the dialogue that that's going to be generating. We sit on the staff of the Hoosier Housing Needs Coalition Steering Committee, which allows us to help inform the legal implications and the health implications of some of the law and policy that's being proposed in Indiana. We sit on the Indiana's Coalition for Court Access, which is essentially the body commissioned by Indiana Supreme Court that looks at tweaks to rules and law change and court rule changes, and how can we sort of look at equity as being a reason to say, did this rule be tweaked in this way or that way, all with sort of the goal of avoiding eviction and eviction trauma. And then next week, we're hosting our first annual Housing Justice Conference, where we're going to bring together a lot of legal aid practitioners, as well as community members, data research, analysis folks, to sort of say, how do we sort of meld these spheres in a way that really does bring the health, MCH issues to the legal sphere, to the judicial process, and whatnot. Next slide, please. Nope, that's the end of my presentation. It's really exciting work. It's a lot of fun, and we're doing a lot to develop partnerships through this. I'm happy to take questions at the end, and thank you for your time.
Thank you so much, Adam. And we will again take questions at the end. We're going to transition now because Lachelle is in the room here with us. And so we'll turn it over to Lachelle.
Okay, well, good morning again, everyone. And I just want to thank you so much for having me here today. And so much of what has went forth so far is what Healthy Start is actually doing in the community. And I feel like my presentations are out of order because later on this afternoon, I'm going to talk about who Baltimore Healthy Start is and what we do. So this Catalyst for Infant Health Equity Grant is just a piece of what we do at Baltimore Healthy Start. And I will say that everything about this grant came out of our Community Action Network, which Dr. Warren mentioned earlier. All Healthy Starts have those. Our Community Action Network is made up of people from our community, agencies, nonprofits, for-profits, businesses, and our most important members are members of our Healthy Start program, our parents. And so our parents at Baltimore Healthy Start are very vocal on our Community Action Network. We actually have what we call a parent leadership group, which trains and helps them have the confidence to speak in rooms like this of people who have all these letters behind their names and talk about what's important to them. So I'm very proud of our Catalyst for Infant Health Equity grant. And you can go to the next slide. So the Catalyst for Infant Health Equity Grant's purpose is to support the implementation of existing action plans that apply data-driven policy and innovative system strategies to reduce infant mortality disparities in specific counties and jurisdictions. And I will say that our Catalyst grant was funded by way of a plan. Yes. And then we applied for it and we got it and we were like, praise the Lord. So all these things that we thought were like pie in the sky things, we're able to start implementing. So we're so excited to have this grant. Can you go to the next? So our Catalyst grant will address housing for pregnant women and families as it relates to the social determinants of health and birth outcomes. The overarching goal of our project is to reduce infant mortality and the disparities in infant mortality between the various racial groups. Next slide, please. So the social determinants of health focus, and I'm glad Andre talked about the social determinants of health. We've been talking about social determinants of health since 1991, right? And so the focus is that this Catalyst grant addresses is economic stability through our university courses, through our housing affordability, and through our workforce development component. The social and community context is addressed through improving capacity and stability and engaging and strengthening our residents. And the neighborhood and built environment is addressed through working with landlords to develop healthy housing, walkable communities, and green spaces within our communities. Next slide, please. So what we will actually do, our strategies are we have housing navigators that will work with 40 tenants per year to secure affordable and healthy housing within our communities. We are asking landlords or housing providers to commit to 24 to 36 month contracts, because oftentimes our moms get into housing and it's a year and then they're left to find housing again, which is very stressful. You can imagine during the pregnancy and the postpartum period. So we're asking people to do more long-term housing commitments with our families. And I will say that this grant is addressing housing, not just with the tenants. We are engaging the landlords to see what it is that they need to help them have healthy housing for our families, as well as educating our families about the opportunities that they have for housing through public housing and HUD and those opportunities as well. The next thing is the education piece. So the presenter before me talked about educating our parents, and we do have within the Housing University, we have courses. So we have 101 series and 201 series where they're talking about their rights. They're learning about their rights. They're having people come in from the housing department to tell them about opportunities that are available to them through the voucher programs that they may not have known. We talked about escrow and evictions. And so all those things our families are getting educated on so that they are better informed as they go out and try to achieve housing as well. We also, very happy to say, are developing green spaces within our communities with canopies and trees and just safe environments for our moms to go out and enjoy as families. And then we will be hosting landlord and developer symposiums to provide information and support to landlords, because a lot of times it's not that landlords don't want to do well. They don't know all of the resources that are available to them, just as moms don't know all of the resources that are available to them. So we are engaging and supporting them as well. Next slide, please. We are also advocating to make tenant assistance resources more available to our moms. We're working with landlords, like I said, to find out about existing programs. We are equipping pregnant women with knowledge and resources through workshops. We are individualizing counseling and eviction prevention grants through our housing navigators. We do have funds to help people not get evicted. We have funds to help people get their homes organized. We have funds to do pest prevention because that's a big thing as far as having safe and healthy housing for our moms as well too. And then we have media campaigns that will amplify and raise their awareness to the sensitivity and the connection between safe housing and infant health equity. Next slide, please. So as I mentioned before, all of our strategies were developed based on the planning grant that we received. During the planning process, the community was engaged through surveys, one-on-one interviews, and meetings to determine what they needed. There's a lot of, we talked a lot about what everybody thinks people need, but we went to the community. We're grassroots, we're boots on the ground, we're from the community. I'm actually from one of the communities that we serve as the director, and many of our staff are as well. And so we went to the community to find out what it is that they thought they needed, what they wanted. Our moms were very vocal, and that's how the strategies came about. Next slide, please. So some of our strategic partners, we wanted to bring unlikely partners to the table because infant health and maternal mortality and morbidity are important to us all. And so people don't often see the connection. And when we first as a CAN chose housing as our priority in 2015, people were like, housing, how's that going to help the baby be better? And we were like, what? That's fundamental to everything else, right? And so now we're getting a lot of support around it. But some of our strategic partners are the Center for Urban Families, the Family Survivor Network. We have other partnerships that are right in the community where our green space is being developed. The Family Survivor Network is right on the corner of one of the green spaces. So when we talk about community-based, it's definitely driven. One of the young ladies that works with us, like the community space backs up to her backyard. And so this is, so I can tell you those names, you won't know those people, they're from Baltimore, but when I say that it really is community driven and community based, it really is community driven and community based. Next slide. So I talked about, and everybody else has talked about how important housing is to infant mortality reduction and improving birth outcomes. It's when we talk about Maslow's hierarchy of needs, it's at the base of the hierarchy of needs. You can't do anything else effectively if you don't have a safe place to lay your head at night. And so that's what I want to drill home to everyone is fundamental. It's fundamental. It's fundamental. We can't have moms to have healthy babies if they don't have safe, healthy, and affordable housing. And the thing that we would like, and I see that Boston, I think he said, is doing it. They have set-asides dedicated to pregnant and recently postpartum women, just as there are other governmental set-asides for housing. And we're taking it to the landlords, we're taking it to the private developers. But if there were a such thing as a set aside for a pregnant woman during that pregnancy period to get into housing quickly and not do the waiting lists just in the general population, I think that would be very helpful. That's something that we're trying to advocate for in our city. And that's something, if it were just on a national level available to pregnant women, it would definitely result in improved birth outcomes and reducing infant mortality. Next slide, please. So we're almost 1 year into our Catalyst for Infant Health Equity grant, and we have had so many successes. We have all of our staff on board. Our staff were trained in tenant rights and everything prior to us opening the doors. We opened the doors on April 11th, 2023. We did not have a kickoff until May 11th because April 11th was during Black Maternal Health Week, and we had a big event there where we recognized some leaders in Black maternal health. And I see Dr. Joya came into the room. So we wanted to give it its due. And so we had a press release and a ribbon cutting and a launch on May 11th. We currently have 44 women in the program. Now, mind you, we were supposed to serve 40 a year, but we have 44 women in the program already participating in services being served by navigators who are going to help them find housing, reduce all those other barriers. I'll talk about all the other things Healthy Start does in concert with this to make sure that the women are getting everything that they need in order to get into that stable, safe, and affordable housing. Next slide, please. We do have the planning committee established for the Housing Providers Symposium, which is going to happen September 16th. And like I said, that symposium is aimed at developers. We want to engage them. We want to engage landlords. We want to engage all those people who provide housing to our families and not just look to HUD. We love HUD. Nothing against, we love HUD, but we want everyone to come to the table and it'd be a concerted effort to improve housing for our moms in Baltimore. We have identified our plots for our green space, and it just so happened the Lord made it so that the community had the same vision that we have. So we'd have an oasis in mind of several blocks, and it's coordinated through many community organizations that are going to make this happen. And then I think that's it. Next slide. Yes, that's it. So as everybody was talking, I had so much to say. I only had 15 minutes. There's a lot I left out, but I can answer questions just like everyone else. Thank you.
Thank you, Lachelle, and thank you to all of our panelists for this session. I have been waiting on this session, so I'm really excited to be able to work with Vanessa and Sarah. I've been worrying them probably about this session. So wanted to take time to see if any questions that anyone has. Anyone on the committee and our appointed or ex officio members, any questions that you all may have? Yes.
Mm-hmm. I would just make a comment to say how incredibly important this is. And it kind of connects with the social determinants of health conversation. And I'm biased, of course, being a pediatrician, but social determinants of health starts when you are conceived, not when you're an adult. And even in my own agency, people think of it as being its services and everything are still very adult focused or mother and infant. And we know that, if you graduate from high school, your opportunities to have better social determinants of health increase. And so I think for this group, the more we can talk beyond even infant and maternal mortality, but that really having the best opportunity for pregnant women and babies is the cheapest way to impact social determinants of health. And our country still doesn't get that, yeah. But the work you all are doing is so important. So thank you.
No, thank you. Others? Yes, Kate.
Well, then a very naive question. This might be for Andre, or it might be for others that I don't know. Very naive question. We know and we've learned a lot about how services support individuals, right? That are in need. And I'm thinking about in agriculture. We do a lot to support our farmers, and that sort of thing. I'm just wondering if there's any programs at the federal level to support those that are landlords who are trying to support affordable housing so that it makes it easier to to serve that clientele and in a way that's sustainable.
Right. Can you repeat the question?
Well, I think that's the work that we do. Okay, and I know so little about it, but we didn't hear about that today. I probably wasn't as eloquent, but I'm understanding what HUD does or other to support the landlords of supporting of affordable housing, that then, if we can support that infrastructure in a more robust way, then it makes it easier for clients to, for individuals to seek affordable housing and stay in affordable housing and meet their rent obligation, et cetera, and not face eviction notices. It's more upstream, I guess, is what I'm thinking.
Oh, sorry. Go ahead, Alika.
You could go, Veronica.
No, go ahead. I'll follow you.
So just the start of it, we do, so my role as a regional administrator is in the field. And so there are 10 regional administrators. And one of the reasons why I'm actually here and the secretary wanted to appoint me to this particular committee is because it's moving away from HQ, right? We love the smart folks at headquarters in DC, but this is to make sure that we are on the ground. And so Michelle, when you were talking about landlords and having a symposium for the landlords, that's the work that we do every day, is connecting to make sure that landlords understand the programs that we have available. So we're intentional about landlord outreach. And
if just for a quick example, if we have a landlord that's deciding to come out of our program, we're going to do everything we possibly can to make sure that they stay within it, and figure out other resources or other programs to keep the units affordable. So that's the work that we do every single day on the ground outside of, you know, all the smart people in headquarters. Does that answer your question?
Yeah.
And just to piggyback off of that answer, which I think is rings so true of like, when you think of the folks on the ground, it's FPM, it's like building these relationships because we have the same 10 regions. And I think there's opportunities there. I would say that at the headquarter level, because I sit in policy development and research, we tend to be very research focused, obviously, and less programmatic. There is a large focus, particularly under the last administration, on why landlord participation was so low, because we realize there's a huge issue when we give vouchers, that the act of getting a voucher and then actually leasing up is the phrase we use, leasing up or voucher success, is not that great, right? Sometimes folks will get vouchers and not be able to use them. And there has been a lot of focus on interviewing landlords and understanding, why don't you participate in the program? And if you do, how can we better build that program? I believe that research has been published, but let me see if I can find it and drop it in the link. But we certainly do realize this is an issue just from a research perspective.
And just one last thing, we also provide a lot of incentives to get more folks interested in our programs. And then when you look at our voucher programs across the table, we're doing more direct financial funding and support for things like security deposits and just other ways to make it more attractive. If that's helpful, to be a landlord in the program.
Are you able to direct some of the?
Adam, can we get you to a microphone? Thank you. And then we'll go to Lachelle.
Are you able to direct some of your vouchers and things like that directly to pregnant people? Because I remember that was something, that we had talked about a year or so ago, and it was a real challenge. So it still remains a challenge, because I think that kind of gets a little bit to what Catherine is.
And so for us, that's working directly with our continuums of care, our COCs, in addition to our public housing authorities. But with our COCs, they all come from different backgrounds. They work with and cater to certain populations. And so the funding will go towards, or the vouchers will go towards those programs. And there are some that work exclusively with like certain populations.
The issue, oh, I'm sorry. Go ahead.
I was just going to give some information about our survey. One of our surveys, only 30% of the landlords that we surveyed accepted Section 8 and housing vouchers. However, 94% indicated that they would be willing to accept and earmark units for pregnant women if the women were participating in the program that helped to support them, educate them, and help them with the housing. So like you said, the need is there, and so that's why we wanted to extend the hand to landlords, because a lot of them are not participating in those programs that can help them as well as our families. And they just need the help, just like our families need the help. So, and I think, thank you for keep bringing up that, that voucher program for pregnant women. Alika, I want to.
We're so excited, HUD. We want to chime in. Go ahead, Alika.
No, I was like, go ahead, Veronica.
Okay. One thing that we've been talking about at headquarters that I think is been kind of an issue is we would love to nationally see a carve out of vouchers for pregnant women. However, the issue is a fair housing issue, because that actually discriminates based on family status and gender, which are both protected classes. So it's kind of one of those things where like the fair housing rule intends to make these positive changes, but then there's unforeseen consequences. So we're trying to figure out like how we can work around that, but we haven't had much success. Sorry, Alika, I didn't mean to interrupt. Go ahead. Oh yeah, she's like, I'm good on that. So we would love to see that at a national level. We would love to see a build out of the program, but we just haven't gotten there yet, unfortunately.
Thank you. And Sharonda, I see you've put a note in the chat. Do you want to read your question, or I'll read it? Are there ramifications if a property owner or landlord is not providing or maintaining the property appropriately? So I don't know what the ramifications are. Alika looks like she's getting ready to answer it. So they can Adam, the attorney in the room, might also be trying to answer it. Yes, Alika. No, go. You can go first, Alika.
I'll put the lawyer part of me on the other side. But yeah, so we do have the enforcement departments. We have departments where you can file a complaint. I work out of the field policy and management. We're like the first eyes and ears to the community. So you can reach out to our office. And then there's a division, our multifamily division, asset management division that will be the ones to connect with our contractors who work directly with our vendors, our landlords, if there's a problem. And I usually find myself and other regional administrators at these buildings talking to property managers and the residents to make sure that our families have the support and decent housing that they deserve.
And when you're talking to them, do you also let them know about other resources? I'm just trying to close it, of course. Okay. Adams, I see maybe you're going to chime in.
Yeah, in addition to what was just mentioned from a tenant's perspective, there are rights under every state law has some sort of code that could be enforced, and there's also local health departments can enforce codes for irrespective of whether or not the apartment is subsidized or whatnot. The problem from a tenant's perspective is that it's difficult. It's just very difficult to enforce these things. You know, if you're not current on rent, you've essentially your arguments are dead in the water. But you know, finding an attorney that would help represent you, going through the process, taking time off work to go to court, taking pictures, there are all sorts of hurdles. Part of what we're trying to do in our project is to reduce those hurdles and barriers as much as possible so that folks know their rights and can enforce them in as easy a way as possible.
Thank you, Adam. And Lachelle?
I just, as far as Baltimore locally, talking about our parents again, in 2018, our parents helped to influence a law for Baltimore because it had not existed previously that all landlords in Baltimore had to have a checklist and before renting. And so now our moms, they talked about what they needed to have in the homes in order for them to be safe and healthy. And so that law passed in 2018 that all landlords, even individual property owners, before it was property owners, and a lot of our moms live in single family homes. And so now they do have that checklist. They do have to get that inspection before they're able to rent. And we did a big campaign in concert with a lot of other agencies in Baltimore to make sure that people are aware of that law so that if they move into a place that has not been inspected, then they have that recourse to make sure that it is up to code and up to standards for the city.
Good to hear. Thank you. Other questions? We have a few more minutes. No other questions. We want to thank this awesome panel. Thank you all for taking time to be with us and sharing your perspectives and your expertise. And again, we're excited to have Alika to hang around with us, to stay on as an ex officio member, because I do think this is one of those topic areas that's not getting ready to go away. So thank you all so very much, and we appreciate you all. But now I'm going to turn it to Vanessa because we're going into the public comment period that we're a minute or two early. So we'll see where we are with public comment.
Thank you, Belinda. As Belinda mentioned, at all of our advisory committee meetings, we spend a portion of the agenda on providing the opportunity for comments from the public, and people are able to submit them in writing. We received some written public comments that the committee members you should have received in your briefing book. And then we had a number of people sign up to provide their comments orally, and we actually had to split the group up between the 2 days. So I have a list of those that are prepared to provide their comments today on Tuesday, and I'm just going to state the names in the order that we received them so that you sort of know when you're up. But we are going to start with Candy Cornelius from Oneida Community Health. Candy, I'll let you get yourself teed up and we can be sure you can unmute yourself. After Candy will be Dr. Joya Career-Perry, who is here in the room with us from the National Birth Equity Collaborative. And then I've been scanning online to see if Kristen Farmer is on. You would be third. Sociologist Thurman from Seattle Indian Health Board. If you're in the Zoom, we'll keep an eye out for you. And then John Mueller If you're online again, we'll look out for you in the Zoom as well. But why don't we first start with Candy Cornelius online? Are you able to unmute, Candy?
Yes, can you hear me?
Perfect. Thank you. Thanks for being here.
Yes, thanks for having me. My name is Candy Cornelius. I am from the Oneida and Menominee Nations. I work here in Oneida, Wisconsin as the prenatal care coordinator, which is the state Medicaid benefit. So I provide support and education to first-time moms. We have a contract with a nearby Prevea where we have the OBs come in here and see our clients. We see about 200 to 250 women per year. This is very rare. Most other tribes, their title is probably like MCH nurse, do not have OBs. And I believe one of the reason is IHS funding. I had noted this earlier, that IHS is severely underfunded. There was an article stated during COVID when some of the facilities had to close, there was people that actually died because they had, that was their sole care provider. And I do see a proposal in the 23 budget, possibly for more funding, but it sounds like it's a one-time payment versus sustainability. I seen somebody else in the comment section where they also noted in tribal communities, there's often one person doing all maternal child health work. That's me. I have no assistant. There's other community health workers, but their focus is elders, which you'll find pretty common in tribal communities. Elders come first. So additional funding obviously is a need and a concern here in Oneida and probably all tribal facilities throughout Wisconsin. I also wanted to note, I've done a lot of presentations on maternal child health, specifically for Native Americans. And I wonder often, all of the research has pointed out specific reasons for, and that this is Native American specific. The past research has noted the timing of maternal mortality. They know it's over 40 years old. They give you a time frame. It's during pregnancy, and they give you the causes. You know, they list, say, cardio and hypertension. Where are the treatments? Where are the solutions? What are the next steps to finding some remedies for this? I've been here 12 years, and I've not seen really any change in OB practice as far as test, care, increased visits, increased tests, anything like that. The only thing I remember was March of Dimes when they rolled out the to stop inductions. So there was a toolkit encouraging hospitals, no inductions without medical conditions at 39 weeks. Made phenomenal changes and stopped many preterm births. So that's my my wish, my goal. My concern is we already have the research, where are the groups and where are the actions taking place. Another thing is I had seen, and I was really, it was nice to listen in on all of the updates because one of my concern was WIC. Since COVID, majority of my patients are not enrolling. I just reached out to the WIC supervisor and she said there's no in-person visits until August. So even though our state of emergency within our tribal reservation has ended, WIC, and I don't know if it's according to USDA or who's giving them guidelines, but their doors are still closed. And for people from minority groups, it is so important to walk through a door, meet the person, you know, develop that trusting relationship, hear it from somebody that what the program's about. So I really think within my population, it's a lack of information. Some people thought, well, the moms, like, I don't want to get the dad in trouble, thinking it's kind of like child support. So simple education. They don't feel it. I mean, I give them a to-do list. They don't feel it is a priority, probably because of that lack of information, that lack of trust. And like I said, the lack of actually in person. So that is also a big concern. And I hope for change for that. And I hope with the recruitment, there'll be a big turnaround once I'm able, because before I was able to walk my patients right down there, have them talk to somebody and enroll, and it would be that. But, you know, over half of my clients that I follow are not enrolling. So definitely there, I see the need for that. So I'm glad there is going to be more recruitment and awareness. But I just wanted to tell you a little bit what I think here about my population. And lastly is To note, in the research that I did, I found the rate of severe maternal morbidity. So morbidity, how are women before they're pregnant, while they're pregnant? And within the last 20 years, there was a study between 1993 and 2014. This maternal morbidity rates increased 200%. So for me, this is prevention. We need to step back and talk about well women visits. Do you have a primary? Even further, going into high school, we're just having a lot of women enter pregnancy unhealthy, obviously leading to complications and leading to that high risk of morbidity and unfortunately mortality. So I just wanted to note that. And the method of delivery. I was also nice to hear that more research projects are going to be done. I'm also involved in a research project with UW-Madison Native American medical student. We are going to look at the change in method of delivery. I'm in Brown County right now, and when I started in 2011, within 2 to 3 years, I noticed a big change from normal vaginal to primary cesarean, and then just repeat. Where's the VBACs? Where's the vaginal birth after delivery? And the medical student dove into the public data and proved that to be true. Brown County rates of VBAC increased at a very slow rate for all races: Black, Asian, Hispanic, white, Native American, none. So we're looking at right now interviewing patients who received care here, who had a primary and then a repeat. Were they given enough education? Was it a personal choice? Did you feel persuaded? All those types of things. Or is it something medical that, once again, prevention before pregnancy may be the solution? So method of delivery is also a big concern here. And obviously we talk about expenses. It's twice as much to have a cesarean, and then all the complications that go along with it. So I guess that's it for me. Any questions you may have or references that I made? One last thing is Healthy Start. I did mention this last time. We did qualify for the Healthy Start, I want to say 2015. And at that time it was due to infant mortality rates. We qualified, had an excellent program come in, and then we did not re-qualify. So I don't know if that meant we met the goals and then didn't re-qualify. But that was a real disappointment, because that was additional staff into our tribal clinic that was focusing on moms and babies. So just interested to see what the qualifications are for that grant. And with the 3 years possible expansion, we have probably a full year for our staff to get trained here just in Oneida on Oneida Nation policies, procedures, nonetheless having to deal with Healthy Start. So they really got maybe a year and a half in of true Healthy Start. So we always have a problem with those 3-year grants, and just looking at recommendations to qualify and extending the grant cycle. Thank you.
Thank you so much, Candy. We've taken all of that feedback. I know in the room, I see lots of note taking by the members. We will try to save some time at the end for any reactions or comments by the committee members. But for now, thank you again, Candy. I'm going to move to Dr. Joy Career-Perry in the room.
Hey, Vanessa. Hey, y'all. How
Hi.
y'all feeling? It's been a crazy couple of years, huh? Anybody feeling? I'm just happy to be back here with y'all, just to say that to begin with. So hi, I'm Joy Career-Perry. I'm an OBGYN by training and the founder and president of the National Birth Equity Collaborative. And I could nerd out on every single presentation. I've had examples. I've actually worked with almost all of those groups, from Boston to, we could have a whole conversation about Baltimore. But I really want to just pull us back a little bit, just because back when Kimberly walked in here with me earlier, I remembered that in 2019, we were really on a path to undo the root causes of racism, classism, and gender oppression that are deeply ingirded inside of these institutions. And we were having a robust conversation about that. And I think between the pandemic and all of our lives, we just haven't been able to go back to that. I was working with HUD and housing back in 2016. So we've been having these conversations, for a while. So it feels big and it feels hard because it's everywhere. But if you remember that the founding of this country was a belief in a hierarchy of human value. based upon race, based upon gender, based upon geography. So the reason that your work feels really hard and heavy is because you're undoing a fundamental basic understanding of how we created all of your institutions, right? So like, if we know that HUD was created and people were put in big housing, I can use New Orleans where I'm from. So put in big housing facilities where they didn't, because they were housed and basically quarantined in a part of the city. And now you're putting them across the city. You made no infrastructure for that because your basic assumption was we got to put them all together to keep them away from others. Once you undo that assumption, it changes fundamentally how you do your work. If you believe the reason women have C-sections or hysterectomies is because they're hysterical, then all of your work is how do we make these women start acting better versus how do we ensure they have the social support that they need across the community? So the framework, we have it in back, we created a thing with ACOG called the Cycle to Respectful Maternity Care. It's researchy and nerdy as the people that HUD were talking about. But the point was when we actually talked to women, what they wanted first was for us to unlearn the harmful things that we were taught. I speak in the I was taught in medical school that there were 3 biological races in the 1990s. This is not, I'm not talking about sharecropping. I'm talking about 1990s. I'm not that old, right? So my embryology teacher said there were 3 types of skin, mongoloid, caucasoid, and negroid. That means that there are people who are my age, 50 years old, across the state of Louisiana, who were taught the same thing in their nursing classes and so they believe the reason people don't need a C-section, all these things y'all have been talking about comes from our basic understanding of how we were taught and trained. So we have to unlearn those things. We have to know that race, gender is a social construct. Girls are not better at cooking and sewing and boys are better at sports. Like all of those things were made up for power and control. So the more that we can work on in each of your institutions, unlearning, so the work that Baltimore has started doing works because they're working with landlords to unlearn bad habits. They learn that all the tenants are going to be awful. And so they have to unlearn that, guess what? Pregnant people are not actually awful. Just as the tenants have to learn things like if you were always in a place where all your bills were paid and you'd have to pay a light bill for the first time, it is a big to-do. Like we have not even accounted for that. So when you talk to patients, we talk to clients and they move from big housing to be somebody's tenant, they honestly have never done that before. So just blame them for not paying their light bill when you're not even accounted for, now they have to pay one. Really makes no logical sense. Like it really, so this is what the people on the ground have to deal with.
No,
right?
I'll do it. She probably isn't hearing you. Just a moment. She'll be down.
Move from kind of centralized. So the beauty of HRSA, and this is my last thing I like to talk to Dr. Warren about this. So CDC has a brand. People know CDC. NIH has a brand. People know it. Nobody has heard of HRSA. Y'all do so much work. You are the Health Services Researchers Association. You're supposed to be. So when I think about Title 10, Title 5, midwifery, all the stuff that I do, it starts with you all. So how do we ensure that HRSA understands its role, sees itself as a big boy? You are as big as CDC and NIH. What are you doing? How are you unlearning the things that created you to be in these silos? Why do we keep having to re-up the need for title money for maternal child health? Makes no sense. We're begging for money for moms and babies in a country that has the worst outcomes for maternal child health in the world, in the industrialized world. This is the reason I get to go to Geneva all the time is because y'all aren't branded well, okay? I get invited to the UN because we have the worst outcomes in the world and the world looks at us and thinks we look crazy. We spend a lot of money on a bunch of things that don't make a lot of sense. So I'm offering and asking, not that you have to hire MBEC for our respectful maternity care. There's a lot of other people who are doing, my colleague Karen Scott has Undoing Obstetric Racism. This is not about me promoting my product. This is me asking for us to rethink and relearn how we do our work, all of us, no matter where you sit. If you are at a researcher at a university, if you're running public policy for HHS, if you fundamentally believe we're broken and that your job is to fix us, I don't need you to do your job anymore. If you understand none of us are broken, but there have been systems and structures and policies that have been trying to break us, and you have the power, either through your vote or through your work or through your policy making to undo that, then you enter your job every day very differently. You show up very differently and you show up for the patients and the clients very differently. So that is my request of this committee to really rethink and unlearn the harm of white supremacy because it is killing all of us. So that is it.
Thank you, Dr. Joya. Always a pleasure to hear from you. And it has been a long time. Thank you. Thank you for coming in person too. I'm going to move us along. I know we have lunch in a little bit. Kristen Farmer, I've been looking out in the Zoom. I don't see you, but if you are here online, want to raise your hand, we'll circle back. I do see oh, thank you, Kristen. Nice to see you. And then after Kristen, we're gonna have Love Thurman, who I see in the Zoom, just to tee that up, and then John Mueller last. Thank you for being with us. Kristen, you're on.
Thank you all and good afternoon. Certainly have enjoyed this session. My name is Kristen Farmer, and I've been working in maternal and child health for the last 8 years. I'm the founder of a nonprofit organization in Cleveland, Akron, Ohio called Birth and Beautiful Communities. I've spent my career really working on preserving the sanctity of birth. That was why I was interested in birth in the first place. And midwifery. I'm a big advocate of midwifery. So about 2 years ago, or over 2 years ago, after having a ton of success with the organization that I founded as a perinatal support agency, a doula agency, to be able to train women to become doulas and provide services free of charge to women in the Cleveland, Akron communities of those doula services. I got to this place where I sort of had this breaking point, so where I was seeing some improvement in the outcomes and the work that we were doing, but I was not seeing the impact that I really wanted to see across the spectrum of birth work. And so I took a sabbatical. And it's been over 2 years, and I sort of went on this sort of spiritual journey because I wanted to find out and understand deeper as to why were we seeing the outcomes, the poor outcomes that we were seeing. Because at first my question was, why are Black babies dying at the rate they are? But my question became a deeper question when I started to ask, why is it that Black people have the worst outcomes in pretty much everything across education and all systemic issues? And I wasn't satisfied with the answer just being systemic racism, because that's one factor, but that's an external factor. And so what can we do internally, empowering ourselves in order to overcome any barriers that have come up against us? And so I created sort of this outline of strategy, so to speak, you know, as to what I believe anyway that would help to improve birth outcomes. And the first thing is that most of the programs that we have are very systems focused. We have to incentivize women to participate into them. And I think that a part of us don't really think about the fact that systems are created or made up of communities, and communities are made up of families, and families are made up of individuals. And so if we want to see communities change, then we have to change first. Our external chaos that we see within our societies and communities is just a reflection of our own internal chaos. And so what do we do about that? And how do we empower ourselves? And how do we empower the people around us so that we all feel empowered to advocate for ourselves in whatever spaces that we are in? And so I think that a part of the programming that I have been developing under Birth and Beautiful Communities and since has been around empowerment. And because if a woman does not feel empowered within herself, if she has a negative self-image about herself, then it's going to be hard for her to advocate for herself, which is why doulas are so powerful and so important, because even if the mother can't advocate for herself, there is someone who can advocate for ourselves, but are we creating spaces for women to be able to gain that positive self-image and look at themselves as powerful beings on this planet who have the capability and ability to empower themselves? The second thing is that according to March of Dimes, we have close to 1,100 perinatal deserts across the United States. And a part of that is because we don't have a traditional birth worker pipeline. For a long time, I have been thinking about how do we get younger women into the profession of birth work by even teaching middle schoolers and high schoolers about birth, because we don't really learn about our bodies. And more women go on to have babies than those that don't have babies. And so a lot of times women are just finding out about their bodies when they become pregnant. And so by that time, the education curve is, I don't want to say necessarily too late, but it's definitely a curve. And so, you know, we can do a better job at educating and normalizing birth in our younger years, in the middle school and high school years. And it's also a way for us to recruit more women or just people in general who will become a part of the birth work pipeline that would include doulas and midwife assistants and midwives, and also those who go on to become OBGYNs. Another point is that the United States is not home birth friendly, and not as friendly either to midwives, considering that most of the developed world, primarily those births are attended by midwives. Here in the United States, about 95% of births are attended by physicians. And we love physicians, but midwives absolutely do serve a purpose, because close to 85% of women can birth without complications. And so I would like to see an increase in midwives. Even within this committee, I have heard the term midwifery a few times since I've been in here, but I looked at the list and I didn't see any midwives who are a part of this advisory committee. And I think that those are very important voices that absolutely should be at the table. And I think that, you know, we also should work on earmarking funding for traditional midwifery, and giving more opportunities for women or for people to just become midwives as well. Because again, I cannot stress enough the importance of midwives and women having options to birth in hospital and birth outside of hospital, and birth without fear that they may get in trouble if they want to give birth at home. And I think that mothers and fathers and families overall just need more financial support and flexibility, because two things certainly can be true at the same time. On one end, there is that very basic need, the housing, the shelter, the food. Those things are very important, but that self-actualization part is also important too. And so again, what are we doing to give that support and that space to those people, those individuals and those families, so that they develop a positive self-image about themselves? Because if they have a positive self-image about themselves, they can empower and go into any spaces, even beyond the maternal and child health space. And lastly, I absolutely believe in the power of doulas. And so I would like to see there be more support, and there has been. When I first started this work in 2014 in my city, nobody had ever even heard of what a doula is or what a doula did. So that was like a completely new concept. And so I think overall, I just would like to see a lot more innovation, because I know that there's been a hiatus and it was COVID and we've been, you know, sort of on a break, but this is my first maternal and child health meeting that I've been to in over 2 years. And you know, a lot of the same conversations are still happening around social determinants of health and equity and these things. And so I just challenge us to get back into our creative genius and think about these things in a very innovative way. Think about it outside of the box, forget, you know, the rules, so that we can really challenge ourselves to solve this issue. Thank you.
Thank you so much, Kristen, for your time and your comments. Dr. Socialove Thurman is on next. And I want to thank the committee members for letting us drift a little bit into your lunch break. Dr. Socialove Thurman, are you on?
Hi, everybody. Can you hear me? Well, I won't take too much of your time since I know I'm between you and lunch. But thanks for having me. Osio Nagata. My name is Socialove Thurman, and I'm a citizen of the Cherokee Nation of Oklahoma. I'm also Yuchi in Delaware. And I serve as our Chief Health Officer for the Seattle Indian Health Board. And I would just say I got to speak with this committee not too long ago in September when you had your meeting at Shakopee. So hello again. I wanted to just kind of bring the voice to urban Indians, as I always want to, just because the funding isn't always in our favor to be able to do the work that we need to do. So we are a qualified, federally qualified health center, urban Indian organization, as well as a tribal epidemiology center, the only in the country that does national scope for all urban Indian programs. And we've been in operation for about 52 years now, providing care primarily to our American Indian Alaska Native population, but for all people in what we would call the Native way. And so I work here in our clinic providing direct clinical care and offer OB and postpartum care as well. The thing that I always want to reiterate is that 76% of American Indian Alaska Native people reside in urban areas. And so we are a really valued part of the IHS continuum of care, but don't always get the money that we need to do this work. And so, you know, one of the things that we have been really striving for is really thinking about how we can create more culturally attuned, community-based programming. And I just want to piggyback a lot on what Christine just mentioned. As a direct care practitioner, what I'm seeing a lot of is that, you know, as urban Indians, we don't always have access to IHS hospitals or places where people can really feel like they get culturally attuned care. And of course, as we all talked about, the racism and just active genocide that our people feel when they enter hospitals is really traumatic. And so what I'm hearing from a lot of folks lately is, you know, we're losing prenatal patients because they don't want to deliver in the hospital. And we don't have really a place for them to deliver. And so I do want to piggyback, because what I hear a lot of our patients wanting is more midwifery services. And so that isn't something that we have offered in our clinic just yet, but it's definitely something that we're really looking forward to bringing, because one of the biggest things people need is options. People just want to be able to, whether they can have a safe home birth, and we can do everything we can to make them feel safe and remove a lot of those fears or those low risk births that could happen. And we work really closely with hospitals so that there isn't the stigma and the shame that happens if you do need a transport to the hospital from a home birth that needs higher level care. And midwives can be a really good bridge for this. And so that's just something I've been thinking about a lot for the people that we serve here, is just what can we do that is different? And we do have to think outside of the box, because I continually hear about the harm that is happening, and I've seen it when I worked in OB in the local hospital, that it's just really, really harming our patients, and it's actually harming the brown and Black providers as well in the hospital. And so it's become very difficult to be able to really advocate for low risk, low intervention deliveries. So I did just want to put that out there, since I heard that just now. The other thing that we're really seeing a lot of is, you know, due to historical trauma, so many of the things that have happened to our people, of course, we're seeing higher rates of suicide, violence, substance use, and more being talked about is interpersonal violence at home that is directly affecting the health of moms and babies. And so what I really want to advocate for is the funding for more of our community-based programming that can help, whether it be doulas, workforce development to get more doulas, more midwives, more advocates for people in the community, because we really need to bring back that village of people who are around women during the sacred time, and be able to lay witness to some of the harms that they can see when women aren't able to have that village or that community right now. COVID has really just highlighted so much of this, and I feel like we're just trying to play catch up at this point to create safe places for our women. So one of the things at SHB that we're working on is we just purchased a property to reinstate our inpatient treatment program. And what we're really excited about is this will be a 92-bed treatment center in Washington State here that will also offer inpatient treatment for pregnant and parenting people, and provide on-site childcare for kids up to 5. And there's, you know, I think every urban Indian program, every tribe in Washington could create inpatient programming for pregnant people, and it still wouldn't be enough. And so, you know, we're going to be able to offer 10 beds, and that's something that I'm really excited about. But I hope that we'll continue to see more funding to create culturally attuned inpatient treatment, because studies have shown that our cultural ways like talking circles, drum groups, cradle board making, and really teaching safe sleeping through cradle board making can be a really great way to bring pregnant people, especially who have been gone for a long time, really suffering with addiction, sort of back in and grounded while they're growing their. And then the other thing that I wanted to just piggyback on is the importance of doulas. Washington State was, we're really happy that they were able to pass the credentialing program for doulas in the state of Washington for Medicaid, and I think more states need to follow suit and see doulas as important and critical as funding for our hospitals and clinics. And workforce development is a big part of this, and so more funding for bringing people up. I've heard all the way down to middle school, which I think is something that we don't talk about, but we have a family medicine program. We would love to have a nurse practitioner program, a midwife program eventually, just the ability to train more people of color to do this work. And then lastly, one thing that we're really excited about is we did receive the HRSA quality improvement funding for what we're calling birthing sovereignty, which is really about revitalizing Indigenous birthing communities. And so what we're going to be focusing on with this funding is introducing Indigenous focused group prenatal care, kind of similar to centering, but being able to create our own Indigenous curriculum that will take care of women from conception up until at least 1 year postpartum, and be able to bring their babies into the circle as well. Because one thing that we often forget about is the postpartum period and how important that is for women, but also just the high rates of infant mortality we see. And so we're excited to be able to really bring people together in a holistic approach with traditional Indian medicine really at the heart of that, through teachings about birthing ways and really trying to revitalize a lot of the teachings that have been lost in a group setting, and really take away some of the Western focused care and really bring back more of our Indigenous ways of birthing. So that's something we're really excited about, and I hope that as we develop that, we can share that out with other urban and tribal communities too. And none of that could happen if we didn't have amazing partnerships with our community, including Hummingbird Family Services, which is a group that does a lot of doula, home visiting programming, and even tonight they're having a town hall that's focused on neonatal maternal mortality in our community, and they're bringing together tons of people to talk about it. And so what I hope to see is that more of these town halls are happening, that we're actually listening to the people who are most affected by these terrible rates of mortality. And so what's happening is the community groups are stepping up to do that work. And I hope that other people can follow suit, that we as leaders can really start to host and hear what the community really wants, and because ultimately they will have the answers that we need. So thank you.
Thank you so much, Dr. Love Thurman. I'm sorry I had to just interrupt there. I did realize we were starting to wrap up. Thank you so much. We've taken all of those comments, and we just have one person following who's been waiting patiently. And thank you again to the committee members. John Mueller, could you unmute, please?
Yes, can you hear me?
Yes, thank you.
Yes, thank you for accommodating me. My name is John Mueller, and I'm a retired public works engineer and former water treatment professional. And I thank you for this opportunity to continue advocating for the end of artificial water fluoridation. Last week, I emailed materials to this committee, which hopefully you have reviewed as they pertain directly to infant and maternal mental health, respecting the NTP's report on the science and the current TSCA lawsuit to end fluoridation. I am now going to read to you the brief closing statements in an article published in the spring 1990 edition, 24 years ago, of the Florida State University Journal of Land Use and Environmental Law. The title of the article is Highlights in North American Litigation During the 20th Century on Artificial Fluoridation of Public Water Supplies. And I quote, "The end of fluoridation will take time, but not because time is necessary to develop essential scientific information. We already know enough to appreciate the enormity of the risk. We knew enough many years ago. But the end will finally arrive because, as Aristotle said at the beginning of the Metaphysics, all men by nature desire to know. The article then finishes by telling us, quote, ignorance cannot be perpetuated forever. The necessary legal and scientific reforms will come in the 21st century. Our descendants will look back on us and they will be amazed. I pray that you will agree that the fluoridation controversy has now reached critical mass, favoring the end of the practice, and that the time is now for ending dental treatment with our tap water. The current administration is telling us the time is now, as directed in President Biden's highest priority initiatives on environmental justice and listening to the science, spelled out in multiple executive orders, including 13985, 13990, 14008, and further reiterating and promoting those in the more recent Executive Order 14091. The rapidly increasing public awareness of this issue also tells us the time is now. An article was recently published by an online business news service about the current TSCA lawsuit. The article has had over 120,000 views just in its first few weeks. In summary, it is time to apply the precautionary principle and first do no harm. Current and emerging science tells us fluoridation is harmful to prenatal and early life brain development. The precautionary principle can be embraced and applied most judiciously and with integrity by the EPA conceding in the TSCA lawsuit with coordination through the White House Environmental Justice Interagency Council established in Executive Order 14008, Section 220. Thank you again for this special opportunity to help promote public health and especially the future brain trust of our great nation. Thank you.
Thank you, John, and I apologize for mispronouncing your last name, and thank you again for waiting patiently. I know we couldn't get to you at the March meeting, so thank you to the committee members as well for staying active. And I'm going to turn it back to our chair. And again, just want to thank all of those that took the time to give public comments to the committee members. We have another set tomorrow, but Belinda, I'll turn it back to you.
Thank you.
Thank you, Vanessa, and thank you all for all of your public comments. I think if you stay around or have time to stay around either today or tomorrow and start hearing some of the recommendations that we may be trying to move forward in the future, you may hear some of your comments again. So thank you again for your time. Now I'm going to ask the committee and apologize to them because we still need to start back at 1:45 because we have a very we don't want to take any time away from our community voices session that is scheduled to start at 1:45. So thank you all, and everybody have a quick but wonderful lunch. We're going to get started back. Give us a moment in the room. And in the room, you feel free to keep eating your lunch or your snack.
No, Jeff. You do whatever keeps you awake.
I do have a louder voice. So we're coming back from lunch. I hope everyone had a wonderful lunch, no matter the length of time. As long as you had a time to step away, we're grateful for those of you who came back and appreciate it. And if you're still eating lunch, feel free to keep doing so. We are good with that. And we're going to follow our agenda, and we're moving now into our community voices section of our agenda. And we specifically asked these two individuals to come and join us today. They're both virtual, but they're going to be talking about more around social determinants of health and specifically the work that they've been doing in their engagement around the Catalyst grants. So we will start with Taylor. Hi, Taylor.
Hello.
We're going to let you get started, dear. So we have Taylor Thompson with us. She's with the Indiana Healthy Beginnings at Home program. So we will start with Taylor.
Okay. So I've been with the program for I want to say for about 2 months, maybe give or take. I was real skeptical about the program though, because nobody ever calls and want to help you out. So excuse me, I was at first a little skeptical about even doing the program. I didn't know if it was real, and then I ended up meeting with the individual that is, I guess, if you want to say, my case manager. And she has helped me and guided me like through a lot of stuff that I needed help with. Because I was homeless with 3 of my kids. We were kind of living with my mom and just like around like with people that I was real cool with. Even though like I was working full time, like I had a steady income, my income was not bad. I just could not one really afford to move, and it wasn't working in my favor. So we were kind of homeless, just bouncing around, and then they came around and asked me if I wanted to participate in the program, and here I am 2 months later.
So Taylor, can you tell us a little bit about, I know you say you were skeptical, so we understand the whole issue of trust and trying to make sure that you're engaged with people that you already have a relationship with that will help you move to trust. But can you talk a little bit? I know you've been in the program for 2 months, but how do you think the program has been beneficial to you?
Well, first of all, they got me into an apartment pretty quickly. So now I have my own space. My children, they're a lot happier. They're in their own space. So it's a nice relief that I don't have to worry about where they're going to sleep at, or what we're going to do for the next couple of days. So that's how it's been beneficial for me. As far as like everything else, like if I reach out to my case manager, asking her for resources on anything, she has made progress with getting me those resources. Or even when we have our little weekly visits, she will look stuff up on her computer to help me out.
Thank you, Taylor. Do you mind sharing the ages of your children?
Yes, my oldest is 15, and then I have a 8 and 9-year-old, and then I'm currently 29 weeks pregnant with my last a baby girl.
We hear you, dear. If there was anything that, if you think about the program that you've been in and think about the efforts that have been to support you with this, because again, we understand that, you had to get comfortable with it first. Is there anything that that you would like to recommend or share with the committee as to how a program like this or a similar program could be supportive to families?
Yeah, because I feel like Indiana, because I'm from Indianapolis, Indiana, and I feel like there's very limited resources for one single parents. We have the basic stuff, the food stamps, the SNAP, the state insurance, stuff like that. Some people, we get Section 8 and stuff out here, but I feel like we're very limited. So I feel like people who like really need the help, who's trying, I feel like they would really benefit, especially pregnant women. It's hard. I feel like it's harder on pregnant women. At least I know for me, because I'm a high risk pregnancy. So my work schedule is way different than what it was before I was pregnant. So like the program, like having the program to kind of back me up, it's nice because I don't have to worry about if I'm able to make rent, if I'm able to pay a bill. Like it's stress free.
That is good to hear, that it's removing a lot of stress from your life, which we know the impact of that on your health as well as the health of your family.
Yeah.
I would like to open it up to other members in the room or who are virtual. If you would like to ask Taylor any questions, or Taylor, we can let Drina speak and then come back. Maybe we'll go there. So Taylor, can you?
However you guys want to do it.
Okay. Thank you for holding on for a little while, Taylor. So we're going to now switch to Drina Plummer. Drina is with the Baltimore Healthy Start program, and she's also participating in their housing effort. So Drina.
Yes, hello?
Hi there.
Hello?
Can you hear me, Drina? This is Belinda.
Yes, I can hear you.
Okay. You want to share a little bit about yourself and your connection to the program there with Baltimore Healthy Start?
Yes, I joined Healthy Start last year when I was pregnant, and they helped me through a lot. They helped me get the things that I need, the housing program and everything else, yes.
So can you go into a little bit more details, Drina, about the type of support that you received with the Baltimore program?
They helped me to keep my blood pressure down when I was pregnant because I was kind of a high risk of pregnancy. So they helped me with that. They helped me with clothing, resources on housing, on how to get it. And they about to help me with like job opportunities as well. Because right now I'm currently not working and I'm looking for employment.
Okay. Thank you, Drina. Anything with the committee any recommendations that you would have or anything you want to share with us around the program that you're that you're participating in, or any program that supports pregnant individuals and parents?
Yes, I would recommend this program to them. If they need help, they will help you, come out, call you, and you can call them whatever you need and all that. Yes.
Thank you, Drina. And are there any specific parts of the program that you like, that you kind of elevate, or you think this is the most exciting part? And I'm glad this is that one piece of the program that's there.
Yes, it was this one program called the Belly Buddies, and they help with like some breathing exercises on how to sleep and all that stuff. Yes.
Oh, we're going to ask Bill to tell us more about that program. Okay. So apparently Michelle's going to chime in on that one as well. So we'll open. No, go on, Drina. Don't let me cut you off.
No, you're fine. Fine.
I was going to open it up to other committee members to see if they have questions. We really appreciate both of you all joining us today to kind of share your perspective. We do want you to think about it in the next few minutes. If there's something, if you were thinking about designing a program in this country or in your community to support pregnant individuals and their children and families, what would you want the components of that program to be? And while you're doing that, I'll see if there are any questions. Yes, I have anyone have a question? Yes, we have a question in the room. Okay.
So first I want to thank both of you for being here with us today. Thanks for teaching us. My name is Kate Bernard. I'm a physician who does prenatal care. And, my question for you is, I hear that, sometimes getting into these programs and the trust that's needed to engage and that sort of thing is a hurdle. Can you tell us a little bit more about what that's about and what we as providers can do to kind of help overcome those hurdles, make it more, help connect folks to services like this?
I would say maybe just having a knowledge of it, because I actually heard of the program through my insurance care source. So it wasn't through my provider or anything like that. But I think like if the provider has the knowledge, that's someone that we trust, obviously, because you're looking after our kids. So like if you guys had that knowledge to say, hey, this is a program I can recommend, I feel like we won't be as skeptical to join or maybe even listen to what the person has to say. But some random person just calling you stating, hey, I'm from CareSource and I'm going to transfer you over to so-and-so because they have this program. It's kind of like, you're not calling, like, are you really calling to help me? Or are you calling because you want my social security and my bank information? So I guess just having that knowledge between the provider and the patient, I guess it'll help everything smooth over.
Thank you. I think that's brilliant and actually actionable. So thank you.
Thank you. And Doreen, I don't want to cut you off if there's anything you want to add to that.
Yes, that's how I learned about Healthy Start through my my OBGYN. She told me about the program, and they gave me a call within like 2 to 3 days. And I thought it was a perfect opportunity to see what the program was about.
Thank you, Drina. I think Sherry, I think your hand is up. If you want to come off of mute, Sherry. Sherry,
Yes, thank you very much. And thank both of you very much for sharing with us your story. That's your perspective is so valuable to help us make recommendations that are meaningful for families. So thank you very much for that. My question is, again, in that mindset of how we can make the very best recommendations, I would like to ask you, especially Taylor, because you are so new to the program, and it did talk about you were understandably a little apprehensive about the program initially, and in this period of time, this last 2 months, you are saying now that you trust the program and you see the benefits for yourself and your family. When you think back to that first connection or the first couple of times that you met with somebody from the program, could you share with us what helped you begin to trust the program? What happened in that interaction that helped you be able to see that it was okay, safe for you to participate in this program?
I would have to say it will probably have to be my case manager. I feel like if she wasn't so relating and down to earth and so willing, I probably wouldn't have went ahead with it. And she wasn't pushy. You know how some people, they're just like, you have to get it done right now. Like, she gave me my options. She told me the details of the program, and she gave me like a folder that had like the details of it. And she was just like, why don't you just read over it, take it home and sleep on it. She was like, if you want to do it, you'll do it. If you don't, then you don't. So it wasn't forced. It was the ball was in my court at that time. I don't know. She was a very trusting person. And I know that sounds so crazy because I had just met her, but like, you could tell that she was there to help and that she wasn't there for anything else other than, my benefit. Like, she wanted to see my best interest. And I think like her doing that. And then like, as far as like, when I went on tours, she was there. If I text her and asked her a question about the program, she answered. It wasn't like, there wasn't no hesitation. Like, she knew it, she was on it. So I think that's what made me, go ahead and go with the program, just because like of the case manager that I have.
Well, thank you very much for that insight that you're sharing with us, Taylor. What I'm hearing is that you reluctantly or with some caution engaged with a person who gave you control and put you in the driver's seat for providing that other person with what would be meaningful for you, and that it was not a checklist that person had to accomplish. It was giving it the time and space to allow you to become more comfortable and to know that you would be the one who would be making the decisions on your life for yourself and in the program. Thank you.
You're welcome.
Thank you, Sherry, for that question. But Doreen, I don't know if you want to respond to it as well. It's your call, dear.
She said everything on point.
So you just know it's a person that you really have developed you feel like you can trust them. And that's an important piece. Anyone else on the committee have any questions that they would like to ask or any comments they want to make? To us, this is always one of the most important parts of our meeting, is actually getting to hear from community representatives, people who actually are utilizing the services, that live in the community. Because we learn a lot from you all. I mean, you are truly know that you are the subject matter experts on your own care and your ability to participate in some of these programs. So we appreciate your time. I think, do we have other questions? Just don't want to leave anybody out. Yes, we have one other question here.
Hi, my name is Alika. I just wanted to know if is there anything that you think could be done different or you might have felt was a waste of time or should change? Because I know the programs are great, but I just wanted to know if there are like just lessons learned, if there's anything that you would change or do different.
To me, I don't think nothing really needs to be changed. Everything is just perfect to me. Like the way they do stuff, how they call you, see if you okay, and etc.
As far as my end, I'm gonna say no, because I don't, as me being still new to the program, I haven't witnessed, I guess anything quote unquote bad or out of place yet. And everything for me, I feel like it went pretty quickly from me meeting them to me making my decision and to me moving and everything else that they've done. So I really can't say anything bad.
Thank you, and I wish you all the best.
Thank you.
And Sharonda, I hear that you've got your hand up. You want to come off of mute and ask a question?
Yes. Before your case manager mentioned the program to you, did you have any knowledge of the programs? Is it something that was, advertised or that you saw any literature about?
No, I haven't heard of this program until last year when I got pregnant and when my OBGYN told me about it. I had no knowledge or anything.
Yes, same. I didn't know anything about the program until CareSource reached out to me about it.
I have a follow-up to that, I'm sorry. And if do you think that if you would have known about the program or heard about it, or other people may hear about it, you think you would have participated in it? If you would have had more knowledge of it, do you think that would have eased your willingness to participate in it?
Yeah, of course. Yeah, if it was advertised, then yeah, if I would have known about it, I most definitely would have joined.
Well, this is my first child, so if I didn't have a child, I probably wouldn't even known about it until last year. So, and I would recommend it to any first time parents or any parents that have like a second or third child to do the program.
Thank you. Did that get to your questions?
Yes, thank you.
Thanks, Sharonda. Others? Yes, Lachelle.
I don't have a question, but I do have a comment, and that's been one of my issues since I came to Healthy Start, that all these great things are happening in the community with Healthy Starts around the nation, and people don't really know about it. So we don't have like a national platform, and I'm not taking away anything from other health concerns like heart disease or cancer, but we don't have that big national concerted voice to reduce infant mortality. And yet in our communities, and I'll speak for myself personally, most people that I know have either lost a child or know someone who has lost a child. So why don't we get that huge national platform like everything else does? Because these are our babies that are dying. And so it's sad to hear them say, and we try to promote Baltimore Healthy Start as much as we can, but it's way bigger than Baltimore. And we do need a national platform to let people know that babies are dying, and we need the support on a national, on a big time level, like cancer, like heart disease and other things like that.
Thank you, Lachelle. I think others in the room may be shaking their head. Yes, you're right.
I don't want to interrupt, but with Catalyst, she mentioned CareSource.
We need to get you to the mic.
HRSA is a partner in the Catalyst grant, so that's how all the connections happening.
Thank you. Well, I don't want to cut anyone off, but we please join me in thanking Taylor and Drina for joining us this afternoon.
Thank you.
You are
Thank
both
you.
welcome to stay on as long as you would like. Again, thank you so much for joining us, and we look forward to maybe at some point to meet you in person, okay?
All right, sounds good.
Take care, both of you.
You too.
You
Thank you.
So now we're going to continue on our agenda. We may be a minute or two ahead of schedule. We'll see how long that lasts. I know, hopefully I didn't just jinx the rest of the day. So now we're going to move into presentations and conversations around the federal Healthy Start program. I think Lachelle kicked it off by reminding us, Healthy Start is a federal program that its sole focus is on improving birth outcomes and specifically looking at perinatal disparities. But this is also an opportunity for us to really delve deeper into the Healthy Start program. As I reminded you all earlier, we are the advisory group for this federal program. And so they do look to us for, recommendations at time or just to make sure we are aware of the program. So we will start with Lachelle, who, as you all already know, is the project director, the executive director for Baltimore Healthy Start. And then after Lachelle, we'll have Ada Detterman, who is here in the division. And she is one of the project officers. Is she one of your project? No, you're not a project officer. She's our data person. She's our data lead for Healthy Start. And then we will go to Mia Morrison, who is one of the project officers. Team lead. Well, I will find out who, apparently I don't know anyone working in the program anymore. Okay. I did say that yesterday, didn't I? I should have just followed with my guts and read the notes. Okay, so now we're going to turn it over to you, Lachelle.
Okay, so hello again, everybody. So this presentation is going to be all about who Baltimore Healthy Start is. We can advance the slide. So Baltimore Healthy Start was established in 1991, just like this committee was established in 1991. We are one of the original 15 Healthy Start projects. We are the only federally funded program of its kind in the state of Maryland. We are a member of Maryland Nonprofits, and we work in partnership with Be More for Healthy Babies, which many of you may have heard of, is a citywide strategy in Baltimore to reduce infant mortality. Next slide, please. What we do, we work with our families in their residences and in the communities to ensure that every child has a safe, nurturing, thriving environment every day for the first few years of life and beyond. Next slide. Our mission is to reduce infant and maternal mortality and morbidity by utilizing the life course perspective. Andre's gone, but he mentioned the life course perspective, by improving the health and well-being of women and their families through the provision of comprehensive supportive services offered in the communities where they live. So we don't just focus on the health part of the maternal health, because it is about the whole life of the woman. So Maxine Reed-Vance, who's been at our Healthy Start since it came about pretty much, she always says health is in the community. So it's not just what's happening at the healthcare provider, but it's all those other things that influence a woman's life. And that's how we approach our help with families. Next slide, please. So the Healthy Start Initiative, I think I'm preaching to the choir here because it's a lot of Healthy Start people in the room, but it's designed to reduce disparities in perinatal health outcomes. Next slide. So where we are, we work in communities, we're in Baltimore City, and we work in communities with rates of infant mortality at least 1.5 times the US national average, and high rates of other adverse perinatal outcomes such as low birth weight, preterm birth, maternal morbidity, and maternal mortality. And so in Baltimore, we have 38 census tracts that we serve in the city. Baltimore is really a city of sides, but we're on both sides of the city. So we try to capture as many people as we can in the underserved areas of Baltimore City. Next slide. So these are some stats for Baltimore City in 2019. This was like the most comprehensive stats I could get across the board. Sad to say, up to date. But as far as the low birth weight for African Americans is 15.7, as far as whites is 7.5. And you can just go on down and see the list and see that we are still at least double that of whites in Baltimore City for the adverse birth outcomes. Next slide, please. Our target areas are the most marginalized areas in the city. We recruit and enroll pregnant and postpartum women regardless of their risk. So some other programs you'll hear about, they tier families in order to come in, or they tier families in order to receive services. We believe at Baltimore Healthy Start that if you live in our area, then you are at risk. And so if you live in one of our areas, you're automatically eligible for the program. And we do have a 90 to 95% penetration rate in our target areas. We actually have what we call recruiters who go out and canvass our areas. And so they knock on doors, they go in stores, they go everywhere to look for pregnant women. They approach people on the bus stop, and I actually seen them do it. And I'm like, I would not give you all my information if I were her, but they give it to them. And so, and so that's how we get that 90 to 95% penetration rate in our areas. Next slide, please. This talks about the 2020 infant mortality rate for African Americans in Baltimore City is 14 per 1,000 live births. And of course, COVID negatively impacted our infant mortality rates. We were on a good trajectory for years in the city, and when COVID came, we witnessed a lot more infant deaths. Unfortunately, the infant death rates began to rise again. We attribute a lot of it in our Healthy Start area to the fact that we weren't able to access our families in the ways that we have in years. And so we went to virtual visits, we went to virtual groups, and we weren't actually laying the finger on the families or going into the homes and actually seeing what was going on. So unfortunately, we have had an increase in infant deaths in recent years. Next slide, please. We have a lot of benchmarks, Dr. Warren. We have a lot of benchmarks, but I just thought that this one was so extraordinary that I wanted I wanted to pull out this one just to kind of give a little bit of the impact of what Baltimore Healthy Start and what Healthy Starts across the nation do with our work with families. When we started, the breastfeeding initiation rate in our project area was 8%. In 2022, we pulled the numbers. It was 66% breastfeeding initiation rate. And although that's not the target, that's a lot of work that has been done. And then when we look at our Baltimore Healthy Start program as a whole, because we have other programs, not just our HRSA funded programs, 73.45% of our families across all of our Healthy Start programs have initiated breastfeeding. So just wanted to show just a snapshot of the impact of the work that we're doing. Next slide, please. We serve over 1,000 families in Baltimore City every year. Those are our numbers for 2021 and our numbers for 2022 of families served. Next slide, please. The 4 approaches improve women's health, improve family health and wellness, promote systems change, and assure impact and effectiveness through workforce development, data collection, quality improvement, performance monitoring, and evaluation. Next slide. So who we serve, in order to be eligible for our program, a person must be either pregnant, be a woman with a child 6 months or younger, be the father of an expected woman, or have the child in their care and live within our service areas. And then once families are enrolled, we serve them until the babies turn 18 months old. At that point, well, prior to that point, we began working with Early Head Start, daycare providers and other programs in our area to do a warm handoff so that once they age out of Healthy Start services, they are not just left with no safety net to continue services. So Early Head Start and the Judy Center in Baltimore has been really helpful with us transitioning our families as well. Next slide. So this is the good part. What we do, we have core client services and population health. We do outreach and participant recruitment, which I mentioned, the recruiters canvassing the neighborhoods. We also go anywhere people ask us to come, we go. We go to health fairs, we go to community events. We're out and about to let people know who Healthy Start is and what we do. We also, in recent years, have become more active with the social media. And now we have a young person on our team who has even gotten us on TikTok. So I'm excited about that. We're on Facebook, we're on Instagram, we're on Twitter, but now we're on TikTok too. So that's part of our outreach as well. We do case management and care coordination. Home visiting is part of that comprehensive approach that we take to care coordination. I do always say we're not just a home visiting program. That's one of the strategies that we use to engage and help families. We also have a certified registered nurse practitioner who goes out and she does postpartum home visits. And she's the only person on our team who was still going out into the community during COVID. So everything else became virtual, but she still went out postpartumly to meet with the moms. We have what we call a maternal health intervention program where we talk to moms about post-birth warning signs and stuff as well. And so she was very instrumental in getting that message out. We do health education through groups and special events. We do maternal depression screening and referrals. We do interconception care. We do developmental screenings and referrals for our babies. We work closely with our infants and toddlers program. If our babies do not screen developmentally appropriate, to do referrals and coordination of services. We do STI screening and we do pregnancy testing. Another great program that I'm very excited that we have is our dyad care. We partner with Total Healthcare, and we've recently gotten funds to partner with another federally qualified health center in our area to provide mother-baby visits. Excuse me. One of our benchmarks that we have trouble with a lot is moms going back for their postpartum visits and going back within the time frame that's specified. So we did realize, though, that moms take babies to their appointments, right? They take the babies. So Maxine, I keep saying her name, Dr. Joy knows her well. She, a long time ago, had this idea, like if we have the mom's appointment at the same time that we have the baby's appointment, then we guarantee that mom comes. And so with the dyad care, and it's a supplement through HRSA that we got in 2019, with the dyad care, when our moms go in, they are seen, and we have one of our community health workers that is in doing the social determinants of health questions, but they're also doing the medical checks at 2 weeks, 2 months, 4 months, 6 months, 9 months, and 12 months, so that mom is seen and all her needs are taken care of as well as the baby being seen. So that has, of course, increased our postpartum return rates, right? So excited about that. We also have our Safer Childbirth Cities project, which has, we have a partnership with the Preeclampsia Foundation, which is called Patients as Partners, where we train moms to talk about their birth stories and talk to hospital administration and hospital providers about what it is they need, how they were treated, and how they can make things better for moms in the birthing process. Also with Merck, we are working to develop a severe maternal morbidity review in Baltimore City, because we sit on the maternal mortality review and we sit on the child fatality review, but we want to review cases and talk to moms and talk to people before the deaths occur. And so that's part of our Merck Safer Childbirth Cities project as well. We also talked a lot earlier about our Community Action Network. The whole purpose of that group is to make life better for Baltimoreans. And so it's comprised of our moms, other organizations in the community, for-profit, nonprofit, anyone who wants to make life better for people in Baltimore is welcome to join our Community Action Network. And then we also have the doula training and mentoring, where we are training people from our community to be doulas and then act as doulas for people within the Baltimore Healthy Start program and other moms in Baltimore City. And we're also mentoring them to be able to get, now in Maryland, they're able to request reimbursement from Medicaid for their doula services. And so once our grant project is over, they will have the ability to request reimbursement for their services to families. I talked about our housing university and our Catalyst for Infant Health Equity initiatives already. So next slide, please. So there's Belly Buddies under our family engagement and wellness activities. So Drina talked about Belly Buddies. Belly Buddies was established in 2012 by Baltimore Healthy Start. It's a prenatal stress reduction program for moms. So with Belly Buddies, they go through 8 weeks with people who have a close delivery date with them, and they actually become Belly Buddies. But they do a lot of stress reducing techniques. They do yoga, they do knitting, they do parenting classes. And at the end, we have a blessing word ceremony where they actually connect. And so that is a big draw with our Healthy Start program. And it does work. We do see the outcomes. The moms have healthy weight babies. Most of the moms doing the Belly Buddies program initiate breastfeeding. And I didn't bring the stats for Belly Buddies, but the stats are there up there. We also have breastfeeding education. We did at one time work with WIC to get some of our moms trained to be peer counselors. And so they checked in with moms and help them along their breastfeeding journeys as well. We partner with a local community college to do GED classes. We have a food pantry with the food bank, emergency diapers, formula, cribs. We have a Healthy Start store where we created our own dollars, and moms can use those dollars to shop in our store to purchase things that they can't get on SNAP, but they might run out of towards the end of the month. So they can get like baby supplies, cleaning supplies, pretty much anything you name. If it's not in the store and they have a special request, we can get it based on their bucks. We do have an early childhood development program because a lot of times when we have groups in session, the children are in the center. And so we have programming to address their needs as well. We have fatherhood services. We have a phenomenal fatherhood engagement specialist, pregnancy testing, talked about the nurse. We do have a teen group because we feel like if you engage not only the young women, but the young men as well, before they get to the childbearing age, they're more likely to have better outcomes when they get to that time. We do circle of security parenting classes. We do have a van, and we use Lyft now and Uber to get moms to where they need to go, like doctor's appointments and then to see us. And I talked about the parent leadership group, which I'm very proud to say I bought to our Baltimore Healthy Start, because when I came, they didn't have the parent leadership group. And I'm like, hey, we need to hear directly from them about what they want to do, how they want to do it, how we can best help. And so I will say that the community voice is one of the most important things that we have implemented. Next slide, please. And those are some of the moms that are in the housing. You saw Drina, she's there with the Housing Truths Project shirt on, but those are some of the moms that are in the Housing University right now. And that's at our kickoff that happened a few weeks ago. They brought the babies in. So that's it. Thank you.
Thank you, LaShelle. Can you hang around so we can ask some questions later? Thank you. And we'll go to Ada.
All right, hi everyone. Thank you for having us here. I'm with Healthy Start. Well, I'm actually the division's data and evaluation team lead. But we're very happy to be here to present on Healthy Start today. With the slides going up, yes. And then also, I just wanted to not only thank you for the invitation, but also just note how hard all of our information is due to the hard work of our grantees. We have 101 Healthy Start grantees that report a lot of information to us, and so I just wanted to say that this is due to all of their commitment and hard work that we have this to present today. Okay, so thank you. So next slide, please. Okay, so I have a short agenda. I'm just going to review the data, talk about the data source, and also a little bit about the next steps. I'm going to go quickly through the data. It's about just really a bunch of charts on the performance measures and benchmarks that LaShelle mentioned. And also I'd like to just say that we can have links available if you want to see details about how these measures are defined. Okay, next slide. All right, with relation to the data sources, we have two sources primarily that we've been using for this data presentation. One is our discretionary grants information system, the DGIS we call it. It's MCHB's performance measurement system. All of the programs report here. It collects information on like financial, quality improvement, health equity, grant impact, demographics, and like some program specific measures. Healthy Start has 19 benchmark measures that our grantees report on. And I'm happy to say that the grantees are doing well across the board on most of these performance measures. And this data comes to us in aggregate form annually. At the bottom, we have a birth and death indicators template, and this is where we capture the birth death outcomes. And so it's the number of live births by singleton status and birth to multiples, preterm birth, low birth weight, and number of infant deaths. We also have a few other data sources like a narrative progress report, and we have a newer data system that I will talk about a little bit later. Next slide. Okay, next slide, please. Okay, so first I wanted to say that, again, we have 101 grantees, and we're in the middle of our 5-year project period, which runs from 2019 through 2024. And so the presentation today will capture information and from 2019 through 2021. And you can't see the legend here, it doesn't seem, but in gray is 2019, blue is 2020, and gold is 2021. So I just wanted to note that the number, despite the pandemic, we've seen a number of the increasing numbers, participant numbers over the course of the project period so far. Starting with, you can see all participants there. In 2019, it was just below 60,000 to in 2021, hitting about 77,000. So they've been doing a lot of work despite the challenges, in the environment. We also have a good mix of participant types. As you can see here, they serve pregnant women, non-pregnant, meaning it could be either postnatal or preconception. And so pregnant women annually comprise about 30% of our total population or participants served. Infants and children range annually from 30 to almost 50%. And then we also have a focus to serve men. Our goal is to try to get about 10,000 men per year, and you can see we get about half of that. Okay, next slide, please. With regard to race and ethnicity, let's see. We serve the participants are about 60% Black every year, and we also have about 20% that are white. A good number are unknown, and then the rest, sort of fall across the other racial categories or multi-race. And then also, and one of the things that Lachelle mentioned is that, we do focus on the Black-white infant mortality disparity. However, Healthy Start grantees do. Anyone who lives within their catchment area is eligible for the services. So if anyone who comes to their door, they will assist because you're sort of given high risk status or eligibility status if you live in that neighborhood and meet other criteria being like reproductive age and such. Okay, in terms of ethnicity of the participants, we've been increasing from about 20% to 25% between 2019 and 2021 that are Hispanic. Okay, next slide. Okay, with regard to healthcare access, first I wanted to orient you to the chart. So the pink bars that you see here provide national data, and I tried to find comparisons that that closely matched our measure as much as possible. And then the lines that you see across going horizontal, the red lines in the charts, those are the Healthy Start benchmark targets, which often range between like 80, 90% or 100%. So, but they vary based on the measure. Okay, so I'm happy to report that Healthy Start has consistently met and or exceeded targets related to healthcare access. As you can see, the large majority of our participants report having insurance, likely due to Healthy Start's assistance linking them to Medicaid. It's comparable to the Healthy People 2030's most recent data report of 90%. And also nearly all Healthy Start women and children report having a usual source of care by 2021, which is also likely associated with their insurance status and the fact that Healthy Start programs link participants to healthcare providers. And you can see with the usual source of care, we actually surpass the national data equivalents reported in the CDC's behavioral risk factor surveillance system and for children within MCHB's National Survey of Children's Health. Okay, next slide. All right, the slide really should be titled Women's Healthcare Utilization. I forgot to change this one. I just wanted to share that with regard to early prenatal care, we measure whether the participants have had a prenatal care visit in their first trimester. And so we can see that we've had a steady increase since the start of our program period and surpassing the target in 2021, not quite matching that of what was reported in CDC params in 2020, but it's getting pretty good. And this is really not an official Healthy Start benchmark, but we do report this to our congressional budget justification. So it's one of our priority measures. Postpartum visit, currently we assess postpartum visit as having a visit within 4 to 6 weeks post-delivery. So you can see we've fallen short of our 80% target. And we are aware that this might be due partly to the fact that we do have a short window for postpartum. ACOG recommends going out like the first 12 weeks. So, and you can see with CDC params, they also do the 4 to 6 weeks. So we're a bit behind on that piece. Well woman visit, we are exceeding the target and doing better than the national data element. So, and outperforming what we see with the BRFS, the Behavioral Risk Factor Surveillance System. And that's having a preventive visit in the last year. Okay, next slide. Okay, so we also assess reproductive life plan, which means that it measures their whether or not they have one, has if they have an intent to have children, using contraception and also using condoms to prevent STDs. The majority of our participants report having reproductive life plan, and you can see we surpassed the high 90% benchmark in 2021. Interconception spacing, we measure the percent that did not conceive within 18 months of their previous birth. And again, we've met the target all 3 years and beat out what we see for Healthy People 2030, which has the same measure exactly. Okay, and then lastly for the slide, no tobacco use in the 3rd trimester is another important measure. And you can see that we exceeded the target set in 2021, although we're not quite as high as the national comparison. All right, next slide. Okay, so I just wanted to note with this personal well-being trends is that we have very high benchmarks here. They're all 100%. So, it's almost hard. I mean, it's impossible really to ever really get that when you're working at this scale. But you can see that I think, attending to personal well-being is one of Healthy Start's strong suits. We have nearly universal depression screening of Healthy Start women participants. And I wanted to, you can see the national comparison is very low. It's not exactly a one-to-one match. Our rate is about the participant screened, and that one is really more about the number of primary care visits or the percent of primary care visits where depression screening has occurred. And that's based on Healthy People 2030. And then again, for referral, we have a pretty high percentage in 2021 of the people who screen positive. 85% of them have been referred for additional follow-up or treatment, which is, a really great outcome, since mental health sometimes is not, as high a priority for primary care visits. And then again, we have good screening of our participants for intimate partner violence of the women participants, and with the last year of this data set being 85% of women screened. Next slide. Okay, so we can see that overall Healthy Start participants are following important guidelines and caring for their children, which is likely associated with, the program's efforts to, engage and give them all the educational programs that Lachelle just mentioned. We have a number of measures here. Safe sleep, we base on 3 criteria. It's a firm surface without soft bedding, being put to sleep on their back, and also sleeping alone in their bedding, in their bed. And you can see we exceeded the target in 2021 as compared to the CDC PRAMs, where, it's close to the same, the national data, but they're really only assessing back to sleep here, and their other criteria are actually much lower. Okay, so Healthy Start is just under the benchmark for breastfeeding like ever for initiation. We have a benchmark of 82%. You can see we're slowly increasing towards that. We're below the 88% outcome reported by PRAMs. Breastfeeding at 6 months, though, remains a challenging target for our population. And we understand that this might be due to a number of factors, cultural, racial differences, unsupportive work policies, age. Sometimes younger participants just don't breastfeed as often, as frequently. So there are a number of factors, and just like the general environments in which they live. So that's one of the measures we really want to work on moving forward. And then in terms of well child visit, we have excellent results for children receiving their well child visits per the American Academy of Pediatrics recommended schedule, as you can see here, as compared to the National Health Interview Survey for children 0 to 4. We're right at the same level. Next slide. And I'm sorry about that. There's a highlight here, and we kept deleting it, but it somehow keeps popping up for some reason. So, okay. These measures for home life trends are intended to show the program's influence on participants' parenting practices and involvement with their children. We have a daily reading measure for reading to their children at least 3 or more days per week. You can see we exceed our targets with that. And it's similar to what's reported in the national data set, although that one's a bit more, like that one's 4 or more days per week. In terms of father partner involvement in both of these categories, this is really like the mother's report of, it's not an assessment of the father's behaviors. So women participants reported increasing levels of father or partner involvement during their pregnancy. You can see over the past, from the start to 2021, which is, it's pretty high considering almost hitting the target, considering when you think about the different types of relationship status. So, they may not be together, but, maybe still involved. And so I think that has a lot to do with the Healthy Start, really trying to focus on family. And then the father partner involvement with children who in the program who are less than 24 months old. You can see that's also increasing and exceeding the target that we set at 80%. And of course, that's an important issue for child development. Next slide. All right, Lachelle talked about the Community Action Network. And this is something every Healthy Start grantee is required to participate in. They are supposed to have a network of members of the community, business leaders, people with lived experiences, a range of partners to work together to improve more of the social structure and the environment in which the people live. So we have 3 measures, well, 2, but one has 2 subparts that assess our what we call the CANs. The first is collective impact, and this measures the CANs' ability to collectively apply their resources to implementing, one or more strategies to achieve common goals among the partners. And these questions, there are 5 questions we use that each have 2 points. It's about having a common agenda, sharing measurement systems, mutually reinforcing activities, continuous communication, and having a backbone infrastructure in place. And here you can see I pulled out the ones that the grantees that scored between 8 and 10. And so you can see that they've increased over the years to almost 80% in 2021, meeting those criteria. The one in the center, the CAN components, it's based on 3 measures, whether or not they have regularly scheduled meetings, if they have membership from 3 or more community sectors, and then having a 12-month work plan. And they have to have all of these to be successful. And you can see that in the last year, in 2021, 87% of our grantees met these criteria. And then lastly, an important part is the CAN participation. And you can see 3/4 of our grantees met this participation threshold. And basically this is having CANs where at least 25% of the members or the membership of the CAN are Healthy Start participants or other community members with similar lived experiences. So, it's to make sure that they inform the CAN, with real life information and experience. All right, next slide. Okay, so now these are our outcomes for the birth and death indicators. And so in gold, we have Healthy Start, and in blue are the national outcomes as reported by CDC. And as you know, by design, Healthy Start serves areas where disparities are greatest. So we would never expect really that our data will match the national data just because we have that built-in disparity, but we do hope to see improvements over time, or at least sort of, be aligned with the direction that CDC is going. And then also I just wanted to note that the 2019 data is not as comparable because in 2020, we started using singleton births only to assess low birth weight and preterm birth. And so for both between 2020 and 2021, for preterm birth and low birth weight, both in the US and within Healthy Start, there were slight increases in the preterm birth and low birth weight. But then you can see for infant mortality rate, we have a different experience. Healthy Start grantees have been showing a decrease in their IMR 2019, starting with 8.05 deaths per 1,000 live births, and dropping down to 6.67. Whereas nationally it's a bit more steady. There was a bit of a drop in 2020 and a slight increase in 2021. And our next step really is to determine, whether these differences are significant, and we're in the middle of doing that now. Okay, next slide. All right, and so we just wanted to mention that we do use our Healthy Start data, not just to inform us and, for reporting compliance, but we really use it to share the information with others. As I shared, we use our data in the congressional budget justification. The middle, like another example is a report to Congress that we submit. This is like the Office of Minority Health, but we're highlighted in there. And then also sometimes we have, supplements within the Maternal and Child Health Journal where we highlight activities and of the Healthy Start program. So we do try to share the story widely. Next slide. Okay, and just next slide, please. Okay, I just wanted to quickly touch on one more data system that we have. This is the Healthy Start Monitoring and Evaluation Data System. We call this HSMed. And it was launched at the end of 2020. Our first full year of data was 2021. And our grantees submit client level data that's de-identified based on 3 Healthy Start forms. And the data team right now is in the process. So we have a lot of data from this, and we're in the process of doing some data cleanup and creating our data sets and prepping it for analysis. So our goal is to have HSMED be the primary data source beginning in 2024. And I'll get to why that's important with the next slide. So with HSMED, what we're really excited about is the fact that we have de-identified client level data, particularly for race and ethnicity. And this is where we can really start to explore, are we addressing the disparities? We weren't able to do that as well when you get the data in aggregate, because we typically get the race and ethnicity in separate pools from the outcomes. And this way we can actually track things, on a client level. And let's see, we can use this information to tell a more complete, compelling, and accurate Healthy Start story. And again, like I said, really think about how is Healthy Start addressing the disparities within the populations, because we can look at things by race and ethnicity. Also, being able to stratify this data across a number of different data types, like thinking about the participant, grantee, and community levels, and investigating whether participant demographics, healthcare utilization, and everything are associated with improved outcomes and such. And so we hope to share this data with you all in the near future. Okay, I think next slide. And then the next 3 slides are just references for all of the national data. So you're able to, look into that if you'd like. And I just wanted to thank you all for letting us be here. And if you have any questions, my contact is at the end. Thank you.
Thank you, Ada. We may have some questions before you leave today. Thanks. Yes, ma'am.
Hi, good afternoon. My name is Mia Morrison, and I'm a supervisory public health analyst and team lead in the Division of Healthy Start and Perinatal Services in the Healthy Start branch. And today I'm presenting on behalf of our branch chief, Benita Baker, who unfortunately is unable to attend. And I'm pleased to be able to talk on the topic around our 3 key engagement activities that took place over calendar year 2022 and 2023, and how these activities will inform our future Healthy Start priorities. Next slide, please. So the 3 engagement activities that I'm going to touch on today are 1, the infant health equity convenings. And this was a series of 4 meetings that took place over calendar year 2022, where we invited over 30 key partners, subject matter experts, individuals with lived experience from around the nation to speak about their recommendations and action steps for the Bureau and for the field on how we can work to achieve infant health equity. The second engagement activity that I'll talk about today is our grantee listening sessions. And that was a series of 2 conversations that took place in October of 2022. All of the current Healthy Start grantees were invited to participate, and the majority of them attended. We talked to them about lessons learned from the current grant cycle. What were the strengths? What were the challenges? And what are their recommendations for continuing to improve our Healthy Start programming that we can take with us into further grant cycles? And the last engagement activity that I'm going to draw upon today is our request for information that was released through a Federal Register notice from January to February of 2023. We asked the field for input on a series of questions ranging from program design and implementation, and also touching upon data and evaluation. We received over 100 responses to our request for the information. Many of the respondents were students citing research and studies that they had learned about in their classes. And we also got a sizable amount of respondents from current grantees, clinical providers, and advocacy organizations. Next slide. So across all 3 engagement activities, we received 3 broad categories of feedback. We heard a lot about the importance of flexibility in our programming, of addressing social and structural determinants of health within our Healthy Start grant design, and also considerations around identifying ways that we can reduce grantee burden. Next slide. So as I go through the subsequent slides, I'm going to drill down on 4 main takeaways. One was increasing the emphasis of addressing upstream factors and social and structural determinants of health, which impact perinatal health in the communities that Healthy Start grants work. The second is identifying ways to increase the emphasis on strengthening family and community engagement, from program design to implementation to evaluation. The third is identifying mechanisms that we can use to continue to support grantees in implementing strategies that are flexible and are customized to addressing the key drivers of infant mortality within their communities. And lastly, I'll talk about the considerations that we received around reducing grantee burden. Next slide. So this next slide is quite dense, as are the subsequent 4 slides, but I'm going to walk through them and talk about the recommendations that we received from our engagement activities, and then highlight how we've been immediately able to address them in our FY23 Healthy Start Initiative Enhanced NOFO, and how we're also considering them in terms of future priorities for Healthy Start program design. So a major recommendation that we received around increasing the emphasis around upstream factors and social and structural determinants of health impacting perinatal health, we received recommendations around thinking about bringing together non-traditional partners. I think this room is very well versed in how social and structural determinants of health impact the health of mothers and infants throughout the life course. But an action step that was called out to us in the infant health equity convenings charged us to find ways to convene partners from both the clinical setting and also from social service settings, and for organizations that are uniquely poised to address the social and structural determinants of health needs within the community. From our grantee listening sessions, they charged us to identify increased ways to design programs that affect the root causes of health disparities at the upstream level. We also heard about how many of our Healthy Start grantees are working to address mental health needs in their community, and that access to mental health services remains a huge challenge in many of the communities that Healthy Starts are working in. And again, from the request for information, we heard about the need for increased flexibility to address social and structural determinants of health, and particularly housing, transportation, and the built environment was called out. In terms of our FY23 NOFO, we've been able to address some of these recommendations immediately. We've emphasized in our program requirements and expectations that Healthy Start projects are expected to provide referrals, support navigation, and linkages to not only clinical care, but also services and organizations addressing social determinants of health within the community. With the work with respect to the community consortia, which is also known as the Community Action Networks, the work is really guided by a plan that the community develops to address social determinants of health within the community. There's measurement around progress to obtain those goals. And also we have activities built in so that members of the community consortia, including the coordinator, participate in technical assistance activities around addressing social determinants of health. Next slide. So with respect to family and community engagement, we heard a call to really prioritize and amplify the lived experience of mothers, fathers, birthing people, and community members. In fact, not only a call to value this feedback and this perspective, but also to ensure that there's a pipeline from an advocacy role to a career in MCH should families and participants choose to pursue that. We also heard the importance around compensating people with lived experience for their participation in activities like the CAN or the community consortia. And we heard great suggestions from our grantees around increasing the availability of incentives to engage families in activities and in leadership activities, as well as opportunities for the community to hear updates and feedback on how the grant is performing. In FY23, we've been able to address some of these recommendations in a few ways. One, we've stipulated in the NOFO that the community consortia acts as and advises and informs the planning, development, and implementation of the direct and enabling services that Healthy Start projects implement. We've added language to emphasize that as a best practice, the community consortia coordinator should be representative of and from the project area. And we've also added suggestions that the community consortia chair or co-chair should be a current or former Healthy Start participant. In terms of leadership development opportunities, I'm really excited to briefly touch upon a recent activity that was led by our Technical Assistance Center at the end of May. They had a national consumer convening in Chicago where they brought together families, community health workers, and other community members to build a network of family voices that can advocate and provide leadership around topics pertaining to Healthy Start. This community convening, consumer convening also provided participants with opportunities for training and strengthening their leadership development skills. Next slide, please. So on this next slide, I'll talk a little bit about what we heard around increasing flexibility to customize the approaches to addressing the key drivers of infant mortality within the community. I want to say first and foremost, throughout all of our engagement activities, we really heard about the strengths that organizations, families, and communities bring to the work that we do. And so it's with that basis, that understanding of those strengths that we heard recommendations around strategies that would particularly work in their communities. And I think much of what Lachelle talked about earlier highlights how each Healthy Start brings a unique perspective on how they'll address the key challenges to perinatal health in their communities. One recommendation that we heard from the infant health equity convenings is fostering a cultural shift to honoring cultural knowledge, tradition, and expertise as evidence. And from the requests for information, we heard about the need to customize strategies based upon the unique needs of the target population within the project area. We also heard very specific suggestions, some of which we were able to immediately incorporate into our FY23 NOFO. So for example, the ability to develop, if two applicants are proposing an overlapping project area, thinking about a way that we could give them an opportunity to develop MOUs or MOAs after applying if they propose to serve an overlapping geographic area in certain instances. And so within the FY23 NOFO, we are calling out the increased flexibility to customize interventions to meet the unique needs of the target population. We're also providing more flexibility around the leadership opportunities that Healthy Start projects participate in. So we are calling out to them to identify which leadership opportunities at the state, local, or community level would be most impactful for their target population. In terms of direct and enabling services, we're offering more range in the types of services that are offered to families. So for example, not only are projects expected to provide case management and care coordination, but we also want them to focus on group-based health and parenting education as well. applicants will also have the ability to use part of their funding for a clinical provider, and whether that's a nurse practitioner, behavioral health specialist, certified nurse midwife, we want them to select that clinical provider based upon the needs of their target population. In addition, with respect to flexibility, the community consortia works with the community in order to develop a plan that addresses the needs of their community specifically, and the social determinant of health that they would like to target. Next slide, please. So lastly, I'll talk about what we heard regarding grantee burden. I think throughout all 3 engagement sessions, we heard about the importance of ensuring that frontline staff like community health workers, doulas, and midwives, that their role is respected as equal to that of clinical providers. We heard a lot about the burnout that many of the frontline staff are experiencing, specifically in the wake of the peak of the COVID pandemic. And we heard a call to prioritize recruitment and retention strategies so that Healthy Start projects can maintain their community health workers that build those lasting rapport with families. We heard a call to consider quality over quantity in terms of numbers served. And we also heard that it's important to understand that many of the community health workers are experiencing the same stressors that are faced by the families and their own caseloads. In the FY23 NOFO, we've specifically highlighted that applicants should consider strategies to support staff retention. And we linked to resources that have been developed by the Bureau to help applicants think through some of those strategies. In terms of the data and reporting burden, we did an internal analysis, and we definitely heard the call that while grantees are committed to demonstrating their impact, they challenged us to find ways that we could reduce the reporting burden for them. We examined what our program priorities are. We examined potential areas of redundancy in the information that we're capturing. And through that analysis, we were able to remove 9 of the benchmarks. And so the FY23 grantees will see a reduction in the data for benchmarks that they're collecting. Additionally, we have reduced the number for numbers served in the FY23 NOFO. For the case managed participants, Healthy Start programs are expected to serve expected to work with 450 participants and 200 through group-based education. Additionally, moving forward, we're examining our own internal monitoring protocols to identify ways that we can further reduce grantee burden. Next slide, please. So this is my contact information. If you have any questions about the information that I presented, I'm happy to answer questions today. If you have questions about the FY23 NOFO, I'm also happy to take those via email or today as well. Thank you so much for your time.
Thank you so much. So now we're going to open it up for questions. So any questions from any other committee members? Either ex officio or appointed? Yes.
I just have a quick question for Ada. I don't know if you've gotten any provisional 2022 numbers yet, but I know at the national level, what we're seeing is there is a significant increase in infant mortality overall. And so I guess I'm more of a comment to just, you might be prepared to see something like that. Did I?
Okay. Sorry, it looks like it's red, so I wasn't sure if it was on. Yes, we don't have the 22 data. I do have the inputs from the grantees. I have to compile them still. So that's something we're working on. And for 2022 data, with regard to measures, we don't yet have that. We get those at the end of the month, but yes, but we're currently about to switch to 22 data analysis. But thank you for the heads up.
We did notice that at the city level in Baltimore, which I mentioned in my presentation.
And I wonder if, you know, are we tracking any impact from COVID? Because we were seeing that in other areas. And I know 2022 could be some COVID, and maybe not. So I don't know if you all are looking at it from that way.
So we have not officially put anything out on COVID, but we have been kind of tracking numbers, and one of the issues that we run into is just how it is listed on the death certificates in terms, and we're just not seeing very many COVID cases for infants in general. So it may not be necessarily COVID directly, it may be.
Oh, yeah, I'm thinking more about where access
COVID
to prenatal
adjacent.
care. Yeah,
That's kind-
adjacent.
that- so it
That's a
may
good
be
word.
more related to that,
Mhm.
but we don't have the link data yet for 22 to check into that. And so I can't speak in terms of
Understood.
access or, you know, how people are getting care, but we just know that overall we're seeing that in the provisional numbers.
Yes, Marie, thank you.
Great presentations. I'm just curious, both ACOG and the Academy of Pediatrics and the Academy of Family Physicians have all recommended this concept of fourth trimester care. You had mentioned in your presentation that 12 weeks postpartum, even that 1 year postpartum, how having expanded access and routine follow-up can help prevent downstream consequences, both on a perinatal standpoint, but then also capturing some of the highest causes of morbidity and mortality for particularly our Black birthing parents. So can you explain to me how that's been incorporated, if it's been incorporated, and how you can see that scaling in a more ready fashion?
Sure, Dr. Warren, do you want me to answer? It's okay? Okay. Yeah, so we have been, I was aware of the ACOG 2018 recommendation. And so we've been working on this for about a year, trying to figure out how to do that measure to extend out the 12 weeks. And I know I can mention both, but okay, so within, sorry. Okay, so within our Title V program, they are moving towards having the 12-week postpartum visit, measure as well. And we're going to be, Healthy Start will be aligned to that, as well. And, we're also mindful of the fact that, a lot of states are moving towards having Medicaid sort of cover the year postpartum. And so, it would be great if we could think even beyond that and really kind of expand that, as you mentioned, because that's where a lot of the maternal mortality, like 1/3 of the maternal deaths occur, and the severe morbidities and, the follow-up. So we just want to make sure that, we are on that, we are tracking these issues and trying to move our programs in that direction.
Oh, and go ahead, Dr.
I was just going to say to what Ada mentioned, so Title V, which is the MCH block grant, we've just published the draft guidance on that. And for the first time in many, many years, we've actually put in a required measure for states. A lot of states have a lot of flexibility to choose, but we actually in the maternal domain are looking at a postpartum visit, which we required for all states to report, given the current focus of the department and the administration.
And I was just going to add just a concrete strategy from our FY23 NOFO. We've called out doulas as an important component of a clinical care team if a grantee selects to use their funding to hire doulas. And we know that doulas can work with mothers in the postpartum period to help them identify those maternal early warning signs. And so, yeah, we're constantly thinking of strategies that we can embed within our NOFO to think about that critical early postpartum period.
One last thing, the Academy. Sure, can you hear me now?
Yes.
Okay, so my apologies. So for the Academy of Family Physicians, we're actually working on a project on fourth trimester care, specifically to identify what are the best practices for primary care clinicians, not just maternity care clinicians, but primary care clinicians in that 1 year postpartum period to identify, screen universally, and know how to manage, treat, and support birthing individuals. So that should be coming out actually in the coming months as well.
Okay. Question
I
kind
need
of
you to
takes
get
it
closer to
really
my
close.
ears.
That takes it back a little bit. I think I learned this about 100 and a couple programs funded annually. How many aren't? The applications that are received in a need and that kind of thing that don't get funded.
So we can find out whether we can share the exact number. We certainly get far more applications than we do, than we have the ability to fund, that we have resources to fund. So let me see if we can give an exact number in terms of the last application cycle. One of the things we do have that we published, I believe in the Healthy Start 23, the enhanced NOFO, was a list of the communities with excess infant deaths of 15 or more. And just that list alone takes up about would take up about half of the available slots for Healthy Start. But let me see if we can get you an exact number.
And I know you're looking for the number, but at one point it was based on 300 communities in the country qualified for Healthy Start, but it may not still be true. But I know at one point that was the goal was, and about a third of the communities were funded. Because they had the rate, based on the rate of having their infant mortality rate was 1.5 times. That was the data at one point.
And we could pull that. I mean, in partnership, our EPI folks in partnership with NCHS can look and see, because that's, I mean, that would be a simple analysis to see how many, we do it at the county level to see how many counties. One of the aspects of Healthy Start is sometimes it's a single county, sometimes it's a part of a county, sometimes it's a group of counties. So, but we could look to see how many counties have infant mortality rates that high. One of, as you all know well, the other piece of that is what's the number. So you might have an area that is rural or frontier that has, just because the numbers are so small, have really wide variations in their rates. But we could do some digging on that.
Were you going to ask another question? Okay.
So I've got some knowledge gaps and so like, how do you define, I mean, is it dependent on the community, the size of the community? It's not county, it's a certain number of births, or I actually don't know how you can define a Healthy Start community.
Mia?
Oh, sure. So Healthy Start communities can define their project area using counties, zip codes, or portions of counties or zip codes. But they must meet the requirement for the infant mortality rate, which is 1.5 times the national average, and a specific number of infant deaths in a 3-year period. If they don't meet the number of infant deaths, then they can qualify using low birth weight rates or preterm birth rates.
So if you're really thinking about rural areas, or there's potentially a big geographic area that could define themselves as a Healthy Start community to get the number of births that you're, or adverse outcomes.
So many of our rural project areas are larger geographically.
Other questions? Yes, Steve.
So maybe it's Ada can answer this one. The stillbirth rates too.
A little closer to the mic.
Oh, sorry.
Thank you.
Are stillbirth rates? Maybe I missed it on, because I mean there are certainly disparities in that area as well. Is that part of your measurement?
No, currently we don't track that. We do have questions related to other outcomes in the HSMED data that I said that we're analyzing. That's the participant level data, but we haven't actually pulled that information at this time. But in the future, we might be able to report on that. We do have other outcomes that we can track.
I think there has been a growing interest in that, certainly across the department, and colleagues at NICHD and CDC have been engaged in that work. A number of our state Title V programs are doing work related to stillbirth, and many of the Healthy Start sites participate in their local fetal and infant mortality review. So even though it's not reported as a benchmark measure for them, they're engaged in those fetal deaths at the local level, and that the review of those.
Yeah, and we at the CDC are starting lucky to have funding from NICHD, we're hoping.
A little closer to the mic.
But to use our program MatLink, I don't know if anybody here is familiar with MatLink, which looks at mothers that have had exposures to opioids in the babies. We're also going to have a pilot stillbirth modules at some of those entities, so we can gather more, first find out like what information is or is not being gathered and what those disparities are, to be able to start to look at causation and other issues.
Ada, I have one first a comment. Thank you so very much for sharing this data. I think many people have been wondering where the Healthy Start data is, and for you to do such an excellent job in sharing it and pulling it together. We appreciate it. I was also very pleased because I hear from Healthy Start sites at different points in time, not just the one in my own state, but others, that the benchmarks are going to come down because there was concern about, I think it's like 36 pages worth of information you have to complete on one participant, which did seem a bit much. Not just to me, but for people that I'm hearing from, and I see Lachelle shaking her head as well. And so I'm grateful to see that that is being revisited because, you know, my mindset, and it can just be mine, my mindset is don't ask for anything you're not going to utilize because that's time that could be spent having some direct engagement and actually working on the program versus capturing the information. So very happy to see that. So thank you for that component. I wonder if there been any conversations around, and I hear this from Healthy Start sites, around the number served, because the number served is the same no matter whether you are frontier or rural or an urban area. And realizing that when you're dealing with the transportation issues or just the size of the population, it's a different type of way that you have to serve them. So has there been any conversations around, and I don't know if it came out in the RFI or in the listening sessions around, if you are a rural area or a frontier area, do you still qualify, but you serve fewer people? So has any of that been in any of your conversations?
Yes, so thank you for bringing that up. That is something that has been noted through the RFI, and it's something that the team put some thought into considering how to approach. For the FY23 grant cycle, we've tried to bake in a little bit of flexibility around the numbers served in terms of breaking up the intensity of services into those receiving case management care coordination and those receiving the group-based education. We've lowered slightly the number receiving case management care coordination. And we realized that depending on the geography of the project area, it still may be a wide area that projects are serving. I do think that one silver lining that's come out of the pandemic is the use of telehealth tools to connect with families. And that's part of the flexibility that we'd like to see in how applicants are proposing to serve their families. We definitely understand that virtual can't replace that face-to-face human contact, but for some families who may feel more comfortable, or if it's a great burden to come to a Healthy Start site, or it's not feasible for a community health worker to, drive to a remote area on a weekly basis. We do appreciate seeing those strategies that applicants and our current grantees are using. I know that that's not an immediate fix for that comment that's been raised, but I do want to assure that the Bureau is continuing to put thought into it.
Thank you so much. Appreciate that thought process. I think one of the challenges for frontier and rural communities is still access to broadband internet. So, when you're doing the telehealth, it sounds good until you actually try to make the connection. So yes, I see, Lachelle, your hand went up.
Yes, I had, I guess it's one question, but it's twofold. Is there consideration to not having it be level funding for the 5 years? Because what happens at the Healthy Start program is that we have the same amount to serve families, and the price of everything increases each year, but our grant level is the same for 5 years. So it makes it difficult to attract and maintain staff, especially since everyone now is into community health workers, whereas Healthy Start was based on community-based for 30 years, and now everybody else is catching up. So we compete against hospitals and big organizations who can better compensate their teams and also grow each year in the compensation and benefits, and that's something that we don't have the luxury of at our level. So just wondering if that was considered.
I will say there was feedback from the field because one of the questions had to do with like funding and funding strategy. So 2 cycles ago, there was a tiered approach to funding, different funding levels. This year, everybody got the same amount. And so one of the things we were interested in was, is there a preferred strategy? And it was mixed in terms of what folks want. I think the just very practically, the challenge we have with what you talked about is the funding we get from the Congress stays flat. So we don't have the ability to ramp up the funding over time. What that would mean is we'd have to fund fewer programs. And I think we have really wrestled with that internally. Do you try to serve as many communities as you can with some money, or do you, if we were to get more money, we could fund more communities. And so with the Healthy Start Enhanced, we got in 23, we're funding 10 more communities. But when the size of the pot remains the same, that's the constraint, unfortunately, we've been working under.
Yeah, just to that point, something that I know that is a increasing area of concern within the medical community is how do you get the right level of service to those in the population that are in highest need and have downstream highest impact as far as cost utilization and poor outcomes. And so I think, if I may, reframe the approach is not necessarily losing any of the services, is getting better at identifying who absolutely needs those services and who can have a greater impact from the interventions, because we have limited resources. And so to that point, I'm curious, in the CDC or with our partnerships, has there been any movement towards identifying not just specific, because we all know the segregate populations that are highest risk, right? So we all know that, but how do we identify the actual people, areas, populations that would most highly benefit from a public health standpoint from the interventions that are available? Because then we can create margin to bring people up to the rural spaces, right? So I think that would be, while we want everyone to have universal access, we're dealing with limited means. And Congress, to that point, they're interested in how do we save unnecessary expenses.
This is not really a direct answer to your question, but we've had conversations, like I'm also part of the evaluation team, and working with our contractor, we did pull together, they have sort of like this expert panel that works behind the scenes with them. So we have pulled our expert panel together to kind of think about how do you sort of do like a risk assessment profile for the, within the participant group so that way maybe you can have more targeted interventions or more intensive interventions going towards the ones at highest risk if they've had like prior adverse outcomes, or there are a host of things that we've discussed at some of these meetings to try to figure out what's a way that we can use, like especially our data that we have collected, to try to figure out how to kind of like maybe do tiered approach in that manner and have more frequent visits with those, and maybe have a quarterly visit with those that maybe are a bit lower risk, but still considered high risk because they live in our communities.
And I would hope that the expert panel reflects the demographic populations that are most adversely affected as well, because it helps to identify blind sides too, but that's wonderful. Thank you.
I think one other change we introduced in the most recent NOFO was the addition of the group education option, recognizing that there might be some economy of scale in a lighter touch intervention. At the same time, we were very clear, like, I don't count a health fair as a group, like a one-time health fair as a group educational event, in terms of having some sort of more involved touch. So that's a new thing for this cycle. We'll see where that goes, but that may be a way that will help folks sort of triage resources to be able to focus more intensive resources on a more sustained basis on a smaller group, and then be able to reach broader folks at the community level through those group sessions.
And when you asked your question, Marie, I quickly looked at Kate Menard because she and I were thinking about, I think, the same thing. In North Carolina, we didn't do it as part of Healthy Start, but we did do it as part of our pregnancy medical home, where as part of our pregnancy medical home, we actually developed a maternal and infant impactability score. So we can determine which population or which individual actually would benefit the most from getting care management services. So there's been some work that's been done with that. I think it is, I don't think we can just share it because I don't even know if I have it, but I think we can connect you with the people that did it in North Carolina and have some conversations if that's something. Kate.
I'll just add that there's some work that we published on that
Yes.
the works we published on that program that showed a narrowing in the low birth weight was the outcome and narrowed the disparities in low birth weight through that change in stratifying who received care management. I think a lot about, and that's just stimulating me to think more and more about whether, yeah, Baltimore's done this beautiful work at the community level, and you made a great case that you're, working with the community, not so much with individuals, whereas, so that's certain communities that are benefiting from that. Like, man, wouldn't it be great if everybody could be a Healthy Start community, right? Because everybody needs it. But the pregnancy medical home program, which was the managed care, it was a care management program for the entire population before we split into 5 managed care programs, but was for the entire population, and an entire everyone got a risk screen, and well, not everyone, but as many as we could, and implement. And that data was used to find out who would benefit most from care management. But is it better to use the funds to these targeted community populations, or is it better to use the funds to, at the population nation, find more people all over the place? I'd be interested in your thoughts, Dr. Warren, on that, or is it a blend? I don't know.
I think probably a blend of both. The reality is we're still talking about relatively small dollars. So right now the Healthy Start grants are $1 million a year for the community. So to do both of those things might be a tall order. We also always go back to what does the authorizing legislation and instruction in the congressional budget tell us to do. And I think you're seeing that across multiple of our programs, that approach of there is sort of a population level, sort of, targeted universalism approach, and then thinking about, okay, for folks who either screen or are identified through those efforts, getting a much more focused service. Home visiting follows a similar kind of model in some communities. So good for us to continue to think about.
And I will just acknowledge now, Lachelle did an awesome job with her presentation, but when you've seen one Healthy Start site, you've seen one Healthy Start site. And Lachelle could probably talk about other resources that she has leveraged to be able to do all of the work that they do in Baltimore. She's not able to do this with $1 million. She needs more than that. And so I don't want people to walk away thinking, oh, every Healthy Start site looks exactly like that. They do not. But Lachelle, I don't know if you were going to say something.
Yeah, that's what I was just about to say, Belinda. A lot of the things that I mentioned are not funded by HRSA because we only at 900 and something thousand per year, which was cut. We used to get 2 million per year to do the work. And so it is a collaboration between a lot of funding sources. So at Healthy Start programs, and mine is not unique. We find ourselves kind of like in a hamster wheel of always trying to find funding to keep the work going, to do what the families need. So it's not, I know I probably made it sound easy, but it's not easy at all. And Andre is gone now, but earlier he talked about hubs, and I said to myself, that's what Healthy Starts really are. We are hubs in the community. There's a lot of things that come under our umbrellas. And so if it was just not HRSA to fund these initiatives that are supposed to be reducing maternal health, but if it came together of a bunch of federal programs that really looked at all of the work that Healthy Starts do in the communities and to meet the needs of families, then we probably could get enough, and it not just come solely from the Maternal Health Bureau at HRSA, but from other programs as well. So.
I see another question from Sharonda. And Sharonda, do you want to come off a mute and ask your question?
Yes, I do. So my question is, I know, it's mostly lower income that usually is the focus. But I noticed that in our area, and maybe more areas, but there's been a huge cry for help for median income households because they kind of fall into that hole of not low enough for needing for being able to be eligible for assistance, and then but not enough to actually keep everything afloat as well. So is there anything in place to address the help for those pregnant mothers?
Great question, and I can begin to address that. So Healthy Start, and I can speak directly to the guidance that's in the FY23 Healthy Start enhanced initiative. Funded projects are intended to serve families within the project area. Over 50% should be from the target population, and the target population is the population with the highest infant mortality rate living within the project area. However, any pregnant woman, interconception, woman, father who's interested in Healthy Start services living in the project area should be able to receive them.
So Sharonda, it's really not specifically based on income,
Okay, that's good to know.
but that's a good question. Thank you. Yes, Karen, I'm sorry.
This made me think about centering pregnancy models. And I don't know, I'm wearing my old state health official hat more than I am the CDC hat, because that's not where we are. But CMS has never really done, in my mind, and you may know more than me about this, Michael, really pushed state Medicaid organizations to think about better ways to fund centering pregnancy models. You know, when I was seeing your belly buddies and thinking that it's still Healthy Start light, but it's better than nothing. And if it was funded appropriately, you know, because there is so much evidence to show that it decreases maternal and infant morbidity and mortality. I don't know.
I will just say that's we didn't specifically call out centering since it is a proprietary model, but we did reference group prenatal care to that point in the FY23 NOFO as a strategy that folks could use their money to do, because prior it had really been focused on individual case management, and opening that up to group, that's one of the allowable uses there. But to your point, there's not enough money in Healthy Start to do that. And so thinking about other strategies, Title V comes to mind. Some of the state Title V programs have done group prenatal care pilots. I think more what I've seen with working with individual managed care organizations within states, it's certainly something we could take back. Yeah. I mean, there was the Strong Start a number of years ago, and so there is some evaluation that would lean in that direction, both for that, pregnancy medical homes, birthing centers. I'm sure there's something I'm leaving out, but yeah.
But there are some states that incentivize group prenatal care. South Carolina does it. I think Georgia, we just got funding from our General Assembly in North Carolina that we will be incentivizing. So CMS is engaged in it. They may not be elevating it yet, but I know there's a handful of states, yes, Allison, that actually does, Medicaid does incentivize it.
They are looking, I think, also, and you may want to think about bringing, can you hear me? Yeah. You may even want to think about CMS. I think CMS has been trying very hard to modernize and extend benefit as well as measurement. And so I think they also have the birthing friendly hospital designations that they've rolled out that have parameters that have to be measured in order to meet sort of that bundle. So I think they are doing probably about as much as they can on their funding side, at least to try to right size some of the reimbursement. I don't know if it's everything that you all are talking about, but I think they have tried quite a bit over the past year.
Thank you. Any other questions before you get to go on break? Any questions? Yes, Marie.
I'm going to just reiterate, the United States still has the highest Black maternal infant mortality rate in the world. And so while it is important that everyone get equal access to these amazing resources, at the end of the day, we still are in a maternal health crisis in our country. And so I would be very interested in seeing how CMS addresses that specifically. If there are specific geographic areas, rural, remote, or urban, that are serving a particular population that is literally dying by the second in the country, then that is what we need, in addition to generalized expansion. We don't have the luxury of time to keep pontificating on things we already know exist, which is Black birthing people are dying. Black babies are dying and could be prevented. We had a recent Olympiad who died in childbirth at home. Young, healthy Olympiad with suspicion of preeclampsia. And so while it's our job to create additional urgency in the things that are working, and then to expand the programs that we know are working to the populations that need it the most.
Thank you, Maria. We will, I will say our CMS representative was not able to join us today, but we'll make sure that we pass this information on. But that's a good segue into our conversation after lunch. After break. You did have lunch, I know you did. So we'll take a 15-minute break now, and if we can get everyone to come back at 3:48 to get you your whole 15 minutes. Thanks. On our agenda next, we have time for just some open discussion from the committee, and we wanted to use this as an opportunity to first think about the presentations that we've heard today, see what resonates with people. I know we've had some really awesome presentations, good discussion. And then we're going to roll over into thinking through about some of the recommendations or priority areas that we can consider to develop recommendations for. But before we go into those priority areas, I do want to open it up to see if anyone has anything they want to share based on the conversations and the discussions and the great presentations that we've had today. We have spent a great deal of time focusing on social determinants of health or social drivers of health. We specifically narrowed the focus down for this meeting to housing. And then we wanted to have some time to really delve into the federal Healthy Start program so that all of us would be aware of it. So any thoughts, questions, concerns as we think about our next steps? As I shared earlier, our last round of recommendations, we submitted 59 recommendations. And the Secretary, we anticipate we will get a response at some point, but 59 is a lot. So we may want to narrow down and maybe not do 59 this go round. I have enjoyed the conversations I've had with each of you because I did reach out to all of the appointed members. I haven't gotten to the ex officios yet, but the appointed members, I did reach out and do one-on-one conversations with each one of you just to get a thought about priorities that were coming to your mind that you were thinking about that we should move forward with. So within this next, when we have our meeting in December, we'll use that as an opportunity to figure out exactly some specific presentations that we may want to be around those areas so that we can make sure we're following and looking at the latest evidence or any promising strategies that may be going on in that area. And y'all are just going to let me just keep talking, right? Yes, thank you, Phyllis. If you get close to the mic, you could pull the whole thing forward.
So I think it was very great to have the housing and health presentation. And they were awesome. I would also suggest that we think about housing in IN health. We pilot test in Baltimore, we pilot tested through our nurse-led clinics at Johns Hopkins School of Nursing. We pilot tested a couple of projects where we actually set up nurse-led centers in housing. One was in elder housing and one was in a shelter for abused women, of which at any time, 1/4 of the 60 residents that were there were childbearing or had babies recently. And we got some promising results. And I think because of the combination of federal agencies, HUD, HRSA, the focus on workforce diversity, preparing other work, like you could have these projects staffed by midwives, doulas, and other community health workers. And I think it would have some of the very important outcomes that we see that as a result of home visiting. But where you could even probably do some centering pregnancy situations if they were in housing settings or where women are, or in, if there are federally located or subsidized housing areas where you might have a high proportion, or maybe even in some of the Healthy Start programs, just testing innovations for doing that, bringing healthcare to where women are, because it decreases transportation barriers and all of the other kind of things that sometimes women have in terms of, and other parents, fathers, kids could do well childcare there, and accessing barriers. We also had some health care in our childcare centers that the School of Nursing staff. So just the thought of thinking about innovations and kind of bringing effective activities together in one place that makes it easier for women to access care. And then I wanted to follow up on something that Maria was talking about, and I think it's the struggle we have around just allocation of federal resources, the question of equality versus equity. And we know that there are some communities that, we've all seen that diagram of little boys of different heights, and what happens if you give them a stool to stand on that's the same, or you give them a stool that's based on their height so they can see over the wall. I think everybody's seen that. It's the same thing here that I think probably certainly the mood of the country and that kind of thing, but we know that there are, as Maria alluded to, we know that there are some populations that need more resources. Some of it has come from what Joya said in terms of institutional racism, how we put agencies together that have created these disparities and unequal outcomes in healthcare. And so I think it's something that will take a lot of courage, I think, but it's something that I think we need to continue to think about, and whether or not how we could get resources where they are most needed.
Thank you, Phyllis. Others want to chime in? If someone wants to say something virtually, you're welcome to just come off. Well, you already unmuted.
So one quick thing in response to Dr. Sharp's comments, I think we've been trying for a few years now in the Bureau to think, how do we laser focus on inequities, and how do we target it? I mean, it gets back to this conversation we've been having before. Do you try to do something really broad, or do you focus? And so, we did the first analysis looking at the excess infant deaths and the distribution of those. So we know the states those are in, we know the counties those are in, those deaths due to disparity or inequity. In the most recent Healthy Start competition, not only did we call that out, but we've given those priority points so that the communities with the highest number of excess infant deaths actually get additional points in the scoring. And so that doesn't completely get us there, but I think it's a step moving in that direction to think, I mean, to use your example of the stools, it's the stool to be able to move. So it's more to do, but it's a step in that direction.
Thank you. Others?
I have a comment.
Yes.
That goes right in line with what I was bringing out earlier about the income. We do know that for African American women, that disparity is there regardless of their income. So if we're focusing just on lower income moms, we miss a whole group of women that still need, or birthing parents that still need that type of assistance, because they are still experiencing the same inequities.
Thank you, Sharonda. Yes, Steve.
Sure. I'm really happy to know that we're going to St. Louis in December to visit Sharonda, because having gone to medical school there back 43 years ago, you know, I know at that point, it was a segregated city. The medical system was totally segregated. And I think Sharonda could probably also tell you that things haven't improved a lot, despite the fact that, you know, there have been efforts. So I'm excited about doing that. I wanted to say too, how much I appreciated what Marie Elizabeth said too, that it's our job to point out the urgency. I mean, we're hearing about all these things. I think all the work with Healthy Start is great because what it does is it proves what works. Strong Start proved what worked. The problem just has been we've faced barriers. And I think tomorrow we're going to hear from Medicaid managed care and barriers. That I think that's what Jennifer Moore and her colleagues are going to bring to us. So I think that'll be great. But I just know from the experience that we have in Minnesota, some states are under-resourced as far as Medicaid. They're Louisiana, probably for sure. I know that for sure. Minnesota is not. If you add up the monthly payments for mother and baby through the course of a pregnancy episode, it's $28,000. And I think in Louisiana, the last time I checked with some of your colleagues, it might have been 7,000 or 8,000. I mean, it's not much. And so that 28,000 though is currently given to entities that are supposedly managing care, but entities that we know work, midwife care, birth center care, are they're underfunded by the management, those who are managing funds. Because you just go back to, you know, most states have data reporting, or actually financial reporting of how much is spent. And, you know, it's obviously a federal and, you know, state funding, which is probably why CMS has such a hard time doing anything, because the feds will point to the states and say, they're doing their own thing and it's got the politics of that state. The states will point to CMS and say, CMS won't let us do this. So it's kind of it's a cover, it's a fig leaf for both to say we can't do anything. I think it's going to really take leadership in a bipartisan way of leaders saying enough of this. We've been talking about it for so long. So I know for sure in Minnesota, we're trying to test things that would work better, putting in the hands the management of the care in those who are managing the care as a team. And it includes all the way from doulas through midwives, physicians, hospital systems. So I'm looking forward to tomorrow to continue pushing on that.
Yes, Marie. Thank you.
Yeah, Belinda, something that I know you and I talked about was, you know, one, a desire to have some implementable recommendations in the near future, mid future, and late future, right? So giving some context as far as chronicity is concerned with some of our recommendations. Something that I think would be interesting to explore is how can we encourage and how can programs like NHSC, for instance, encourage pathways for clinician extenders to maternal infant care? So we talked about community health workers as being a vetted evidence-based intervention and extension that can not only bring return on investment, but also help to reduce downstream outcomes. But then also we have potentially other healthcare professionals or healthcare proxies that can help support the work. In the substance use side, we have behavioral health technicians. And so they're not necessarily behavioral health specialists. They can't prescribe medication, but they know just enough to do the screening and they know their community just enough so that they can be a gateway into access to care. And so I would be interested in identifying what are some novel approaches to expanding access to care to communities that need it, and considering, are there para-professionals, just like we have para-teachers, right? Para-education. Do we have para-professionals that can help be extensions within this collaborative maternity care model? So that's something I would like to look into a little bit more. Do we have best practices? The other thing that I think is interesting is doing a deeper dive into what diversity means from a federal definition standpoint, and then what diversity might mean from a state standpoint, because that is very different. So in Massachusetts, for instance, there are about
I think we're at 28 different ethnicities that are listed when you are describing race and ethnicity in their general data. That's not the case in the federal standpoint when we're getting funding. However, we do know that there is a diverse experience within those who identify as Black or Hispanic, right? There's diverse and with that context comes different expectations and different approaches to those populations. And then the third thing that I don't think we've done enough, and I'd be interested to look into, is this concept of rurality, but taking a sub-context of different cultures within the rural experience in America for our birthing parents and the families that take care of them. I think we have an opportunity to go just a little bit deeper in understanding the complexity of rural healthcare and access and understanding what that means. I can tell you that New Hampshire Policy Institute has done robust research regarding how do you define rurality and how that contributes to disparities in a unique way. And just about every state in the United States has rural pockets, right? So I think that might be interesting to for us to look into, and then that could give the secretary hopefully some additional insight and nuance as they're considering approaches to this topic.
Thank you, Marie. I'm gonna switch us a little bit. Keep those thoughts coming because I did again meet with each one of you individually, and so I pulled together at a high level some of the recommendations that were coming from you all as to areas that we should prioritize. So can you pull up those slides? Thank you. And I didn't associate any name with it, so if you see yourself in it, that is great. Hopefully everybody saw themselves since I was merging them all together from multiple conversations. And I wanted you all to just kind of see the various priority areas that we have that based on the interest around the table, and that includes the virtual table. This is just part of them. So one of the potential priority areas that several of you mentioned was the focus around wraparound service and thinking about the models of prenatal care, looking at things like social work, community health workers, doulas, what is going on with lactation specialists. All of those were in an area that some of you all were interested in. Another area of interest was the impact of social determinants of health or those social drivers of health. This included transportation, rural access, housing, job training, childcare, livable wage, even legal justice. These were some of the priority areas. One of the other areas was reproductive justice. What's the impact of unwanted pregnancies? The impact of health, of reproductive health restrictions that we are seeing in around our country. A fourth area was systems challenges. So, you know, if you look at unwanted pregnancy, what is going on with some of the systems that individuals may need to utilize with our adoption system, with our foster care system, for example. The next slide, please, because I don't want you all to think it's just 4. The next area is systems of care to support rural hospitals. So we think about around our country, rural hospitals are closing, and also issues around levels of care. And some of the conversations that I heard around levels of care were, some of it is related to the rurality of our country, but some of it is related to hospitals have been bought by larger entities. So you can look in your state and say, well, most of the hospitals are owned by 3 or 4 different entities or 1 or 2, and how does that impact our regionalization process? There was also interest in data around preterm birth, around maternal mortality, severe maternal morbidity. I probably should have put stillbirths there as well, because that was another area where they were priority focused. And then there were some that were interested in the root causes of disparities, our inequities, racial discrimination, bias, and what's going on with our political climate and how do we address those areas. Another area is impactful opportunity. So what is working in our communities? What does the evidence say should be working? But most importantly, what is working around the country? Some communities are doing a really good job in addressing these issues. So what is working? What are those promising strategies or those evidence-based? And what can we learn from them to be able to utilize it more broadly and to help it spread? And then one more slide. How does the money flow with the payers? And this is the private dollars and the public dollars. What is going on with the money? As they say, follow the money. There was also interest in preconception and interconception health and health care in general. Some of this was fourth trimester, but a lot of the conversation was around what is happening to individuals before they get pregnant, and what are those systems that are in place to support them, and how do you reach them? There was also interest in looking specifically at extreme preterm births as well as birth defects. And then last but definitely not least is accountability. So how are all of these things, depending on which direction we choose to go, how is it measured? So there are 12 buckets right now, and that doesn't include probably our conversations from today. There were 12 buckets based on individual conversations that we've been able to have. And I do appreciate your time that you gave me to have these individual conversations, but it is trying to figure out, we do not want, I don't think the secretary even wants us to give him 59 more recommendations. I think we've got to narrow down our focus and really think through what is actionable. So some of the questions I started thinking about to help us narrow it down is what resonates with the majority of us? Is there anything else on this list that can be merged? And if we go down this road, what are the implications of trying to do some of it in smaller work groups? Realizing right now we're not at full capacity. We have 9 members since we've lost Charlene. So we have 10 members. So we have 10 members. We anticipate some more members hopefully will be on board by December. That is the hope. And we know that it is trying to be elevated. But right now it is us. And so how do we, and the ex officios on the thing, and we have wonderful staff to support us, but we do need to think about that. So again, I want us to really think through, we can go in a lot of different directions, or we can pick a couple of directions and try to get more information about them, learn about them, and then kind of make recommendations from them. What is your pleasure? And ex officios, please feel free to speak up as well, because even though I didn't do one-on-ones with you all, we still have time between now and December. Yes, Kate.
When I look at this wonderful list, I always see some people, in them and that sort of thing. And
I left all names.
Everything's deserving, right? And important. But I'm thinking, how would I go? I like the idea of kind of seeing what resonates with most, and because that's where we need passion right behind these in order to get the work done. But how do you decide? Like, do you decide by, one of those 4x4s of what's possible, what's high impact, possible in this environment, in this political environment, even, to impact, and what's impactable? I just think if we could almost have a framework for rating them, in our decision making, that might be helpful.
We can come up with a way to rate them, if need be, because we can turn this and we can put, we'll put up some flip charts in a minute and put some dots around. But I think there are other ways we can do it as well. But that's an excellent point. Marie?
Yeah, and just to expand on that a little bit, what are the areas of focus for the secretary as well? Like what are his, like what's on his agenda, and how can we potentially amplify and address in a more strategic and actionable way? Would we be able to have somewhat of an insight into that?
Well, and I think that Allison, I'll let Allison speak, because I think there's a way we can do that. It's just like, we talked yesterday to Carol Johnson, the HRSA administrator, to try to find out some of those same things and really try to figure out how do we narrow this down. Because part of reason that we've asked all of these national partners to come and present in our meetings is to really think through synergy. So what are the national partners focused on as well? If you recall our March meeting, we had several of them, or quite a few of them, actually present and let us know what their priorities were. Tomorrow, we have 2 other groups that's going to share priorities. So it may be connecting it to about where is synergy at this point in time. But yes, Allison.
Yeah, I was going to suggest the other thing. So very similar. All of us are working on agency priority goals, and we're also working on, if you're familiar with it, the maternal health blueprint that is issued by the White House that reflects the department's priorities. And so if you look at those areas, we can, as the ex officios, we can tell you some of the places we're already working to help you narrow your list. It's hard for you all to know all the pieces, parts of the things we're already doing. And if that gives you a way to identify gaps, that's something that I think we could do as a group.
Yes, Karen.
I think the other thing, and I say this probably not as the CDC right now, but as in my other lives, is maybe looking at what can advising the federal government that the federal government can actually make a difference. Or is this a real problem in our country, but it's not going to get, if you're trying to prioritize, is it something that's in the purview of the federal government? And if it's not, then it means you have to go advocate to Congress rather than share it with the secretary. So I think maybe thinking was you're trying to prioritize, kind of like what can the secretary with his divisions, agencies,
What can he
and the
influence?
president do? And so how do we give them things that are actionable instead of this is really, really a bad problem, but you guys have absolutely no levers to pull? That doesn't mean it's not equally or even more important, but just not within this group's purview.
And I think that's a great way we can think about it. But a part of me also thinks about, do we use it also as an opportunity that even if it's not on someone's radar, to help move it to their radar? And so when you limit it to just what is already on everyone's radar, again, it may just be finding out what are the priorities, and it may work perfectly for this group. But I wouldn't want us to just limit ourselves there if we really think there are issues. As I say, if the house is on fire, we need to be able to share that now. And those things may be on the radar. Hopefully they are, but I totally understand. And I think we've had several meetings where the conversation has been around. So what does the secretary have the ability to influence? And should our recommendations just fall there? And that's the direction we can go if that's where the majority wants to go. Oh, and Sherry has her hand raised, and then I'll come to Marie.
Yes, thank you very much. I have a scattering of thoughts, so I'll try to organize them at least to the extent that you'll be able to understand what it is I'm thinking right now. One is that I think could be very informative for us to be able to tackle this work that we're doing, is to have a deep understanding of what is involved in states who have Medicaid waiver. Those are intended to be innovations, and there is more emphasis on social determinants of health or social drivers of health. And that's, if we could have an understanding of what has come from, what have we learned from those Medicaid waivers, and how we might be able to see the fit, the alignment with what it is that we wish to learn about and make recommendations for. They go back a long ways, and I think there's a wealth of information there that would inform our work. I also would be really interested in learning how the CMS bulletins are formulated, where they come from. It appears to me as an outsider that it does not require legislative action, that it's a mandate coming from CMS and imposed on states who receive Medicaid dollars. And whether or not that might be a way of advancing the work that we're doing to be able to have an understanding in how we might be able to communicate with CMS and create those mandates that go out to states. We know that a social driver of health is zip code, and that goes beyond the metropolitan areas and into the rural areas as well. I spent 10 years working in the NICU, and a premature, ultra premature baby coming in, being transported from a rural area was always a very complicated medical presentation beyond the births of premature babies within the hospital. And that's an important consideration. Quality of education and literacy and health literacy also is disproportionately impacting rural communities. And I really feel supporting our rural communities could have two major benefits. One is it has the possibility, I believe and hope, to pull the country together. And that could be a perhaps even nonpartisan issue, how we support rural communities. And in supporting rural communities, we also are working toward national security. We know that military offenses from outside the country are targeting populated areas. And we know from World War II in Germany that it was the rural communities that actually rescued society and all of the operations therein. And supporting our rural communities could be framed as a national security. And then when I think about literacy, I think about the incarcerated people. We currently have a strategy of incarcerating illiteracy as a way of removing them from the general population. And we also know that babies are born in prison. And I think that we need to keep that on our radar as well, is what's going on in our prisons and how that's impacting families, how that's impacting pregnant individuals and babies. Those are my scattered thoughts.
Thank you, Sherry. We appreciate your thoughts. And I think Marie, your hand was up.
Yeah, I think those are great points, Sherry. And I think what would be helpful, just summarizing some of the comments that we had, is we just need to know what the current state is, so we know where we can impact. At least I do. So having a list of the objectives or the goals and seeing what is already in process, there might already be programs and synergies that can be amplified through the Secretary's purview. I also think it is extremely important for us to identify what is this fiscal impact of whatever we decide to propose to the Secretary. Either where is there lack of information to identify fiscal impact, or what are some models and potential frameworks that would be involved in clarifying and defining fiscal impact? Because even if it may not be what we suggest, may not be in the purview of the Secretary, if we have a tangible amount or dollar requirement, that might provide some creative resources with all of the stakeholders that we have access to. I think also providing fiscal impact would help to identify what is the what is the longevity, again, timeline, and what is realistically can be accomplished in a short term versus long term. So that to me seems very important in whatever we decide to do.
Thank you, Marie. Anyone else? So if I'm hearing you all correctly, we want a little bit more information on what the priorities are coming from the Secretary and all of the, as well as the offices that he has that he can influence, that he actually has purview over. Am I hearing that correctly? We want to know what those priorities are so that we can see if there's a way to, to help elevate some of those issues, to maybe provide more support for them. But also, if I'm hearing correctly, are some of those priorities, can they be directed to looking at what is happening in rural communities, what is happening in communities of color, where there are, in specific communities of color, where their outcomes may be far worse than others. I just want to make sure I am hearing everyone correctly. So when we start working on this December agenda, you all won't come back and say, well, that's not what we talked about. So we want to hear from the secretary's parties. I think we can get with the ex officio. And I think Kristen is now on with CMS. And I'm not trying to put you on the spot, Kristen. Kristen Zackerman, if you just want to come on and say hello, we won't ask you to answer any questions right now. If you want to just come off of mute and say hello.
Hi. Hi. Thanks so much. Sorry, I wasn't able to join earlier, but I was very happy to see the priority slides that you put up from your meetings with the individual members. That was great to see.
Thank you, Kristen. I've got a feeling we're going to be asking you some questions later. We just won't ask them today.
happy to field them and or take them back if I'm not able to answer on the spot, but we'll definitely follow up with the group.
Thank you. Yes, Kate.
But what you said back to us, I think we heard. But I just want to express that you had a couple questions up there that I think we can actually make progress on now. And I'm looking around there. Am I the only surgeon in the group? Like, I think we need to get going. You made that point. I mean, I if we wait till December and wait for more information to make a decision about how we're going to focus these,
back the slides up.
at least my term on this committee will be passed before we get going. So, can we move forward at least part way while we gather that more information requested?
We
Marie?
can. I mean, what we can do is tonight, everybody can look at these. We can email these 12 potential priority areas out. Everyone can look at them tonight. We still have some time on the agenda in the morning to kind of narrow this focus down. So you can look at them. And if someone wants to make a case for an area that we already have gotten some synergy and we want to move forward, we can, there's nothing that says we have to wait for the priorities of the secretary on that. I think the reason we wanted to look for the priorities of the secretary and specifically the offices under his purview was really just to see if there's an opportunity to collaborate or to try to elevate something that is already something he wants to work on, and that we can see some positive movement quicker than delaying it. So we can go in that direction, because it's a lot. This is not the whole conversation from each of you all. This is just me pulling together some of the highlights from the multiple conversations and merging in areas, because like some of these areas, several of you all said this is something I wanted to do. And no one ever, and I was clear when we met, I was didn't say, well, you can't come up with one thing. I said, what are your thoughts? What are your priority areas? So many people came with a whole long list and others limited to 2 or 3. So there's no right or wrong way to do this. I just want to make sure we're doing it in a way that we can, all of us feel comfortable about it, or at least the vast majority of us feel comfortable with it. And so for us to do something, but if we don't make a decision today, tomorrow, then we basically, we have to make a decision by tomorrow. But if we don't make a decision today or tomorrow, then what we're going to be thinking about is what happens in December. And there's a lot of time between now and December. And I know everyone is busy, but there's activity that we can be doing between now and December. We can be, people can take on the role of saying, hey, this is a specific area of interest for me. I want to try to pull what research is available, what data is out there, what efforts are already going on. I'm sure Vanessa and Sarah will be willing to help us think through that and to pull that information together. And then you can take it upon yourself to be able to review it so that we can at least have a more focused conversation in December about it. Or we can have we can do smaller work groups and do this. So we can go in any direction we want to. I think the last iteration that many of you are familiar with our second, we divided up into 3 work groups. And so we had a work group on equity, we had a work group on data and research, and we had a work group that really looked at clinical care and things of that nature. So we can go down that road. We can throw all of the work groups out of the window and narrow the work groups down to where the priorities are. It is totally up to us which direction we go. Just realize that when we have a work group, that means we need somebody else besides one person to be working on it. Hence the term group.
Belinda, can I just
Yes.
jump in? So in addition to the slides tonight, I will also send out the HHS STOH Advancing Equity 2-pager that Dr. Chappell talked about, as well as the White House Addressing Maternal Health Blueprint for folks to take a look at. It's like 63 pages, but it does outline like, objective 1.1, 1.2, et cetera. And I just did a quick search for rural. That's in there like 50 times. So yeah, something else just to inform. The other thing, just to keep in the back of your minds, one of my like pet projects, the reason I took this job was to look at previous recommendations and think about where they're going. Are they being implemented? What's feasible, what's not? And sort of thinking about how that can be cataloged to share back with you and the public. So as we think about priorities, like think about what it might look like for me to catalog that.
I think this is why Sarah and I make such a good team. I just pulled up the recommendations the committee put forward in August of 2021. You probably have fresh in your mind the American Indian Alaska Native recommendations, but prior to that set, the committee focused on maternity and infant care systems and financing, workforce expansion and diversification, environmental risks, and border health. So if you want to take a look back at that set of recommendations, just to refresh on what you already gave to us that we're actively, as Sarah said, trying to work on and log what's been implemented or adopted. Just don't want to have you guys repeat in an area that you already had some really good concrete things.
And that's a really good idea. We can go back to those recommendations. And if we don't feel like we felt movement on those recommendations, we can recommend them again. Because again, it just keeps them in that pipeline of making sure that the secretary realizes it's a priority for us. So is everyone good with having a little bit of work to do tonight to think about? You don't have to read the whole 63 pages of the blueprint, though a few of us have read it over time. It's just been a minute, so some of us might just be going back doing a refresher course. So Allison will walk us through it tomorrow. That may be the ones that we sent. Yeah, there's a 12-page version of
These are
the committee's recommendation, right, that we can also send out. Yes, Kara.
Do we know, I mean, this committee's been meeting since 1991. Do we have any history of what recommendations were successful or not? Or, I know that's what you're talking about, but I'm just sort of thinking, what got traction and moved forward, or, how do we think about strategy, right?
Well, and I think, when the committee came together in 1991, it was all at the same time where they were coming out with Healthy Start because of the high infant mortality rate and the high disparities. But I'll let Sarah just chime in and know what the others are, because Belinda does not know right off the top of her head.
30 years
Yeah.
of recommendations. So I'm just sort of wondering,
Yeah,
Is
I
there
will
any high
say,
points?
yeah, I'll let Dr. Warren respond as well, but just thinking about what I've looked at in the most recent years, which I think goes like 6 years back.
Before 2020, when the committee made before 2020, when you all made COVID recommendations, the last set that had been submitted to HHS was from 2013, and that report's also online. And we've taken a look at those, and they're pretty broad. So it would actually be quite easy to say if some movement's been done, because I think there's been a lot of work in those areas, but we can also send that around, but it's posted online as well.
And I think the trends, there's very obvious trends and recommendations that if you look back, I haven't gone all the way back to the 90s yet, but even just the last 6 years, you can see there's obvious trends in what's being recommended. These priorities, they're all there. So Dr. Warren, do you have anything else to add?
Yeah, no, I think it's an important priority we've identified to go, because the committee over the course of existence has been very generative. And so it's important to us to be able to say what is out there, so we're not continually repeating the same thing over and over, but then what's the progress that's been made on those. I will say, and the administrator shared with Belinda this example yesterday, that she has been in federal government for a number of years. The first time she heard about Medicaid expansion to the postpartum period was from this committee. Clearly, that was a number of years ago, but an idea that had roots in this group, among others. So clearly, there have been some substantial policy changes, and we don't yet, we will have the granularity of the entirety of the recommendations and what has come from them. So stay tuned.
Thank you. Other thoughts, questions, concerns for tonight? Before we move into, we talked about overnight, we're gonna send out a couple of light reading. We will also send out these 12 priority areas. We will have about 30, 45 minutes in the morning to narrow down our focus and really to think about how we want to move forward in the morning. I will be thinking about it with you all tonight. And I think those are the main things. So I think that's it. Yeah, because listen. I have any housekeeping things for tonight.
My only thing just to add is very minor. We will have this room tomorrow too, and the door will be locked. So if you want to leave your like name badges, and I wouldn't leave anything like personal, but the name badges and the name tents, feel free to do so if you like really want to sit in the same seat tomorrow. Yes.
We'll get here early and just move the name tags around to see if you remember, right? Okay, we're gonna give you a few minutes back on your day. I know some of you all were dying to get out of here by 5 o'clock, but because you didn't get your whole lunch, we want to thank everybody that is out in Zoom in the virtual land. Thank you for joining us. You will get the same information to review tonight, so don't think because you're not here in the building that you can't check your email as well. And we will continue and move this conversation to a closure tomorrow. So everyone have a wonderful evening, be safe, and have, maybe you can get out and walk a little bit while you're reading, before you read, not while you're reading. Thank you, have a good evening.